ಬೇಗ ಮೇಲೆ ಕಳಿಸ್ತೀನಿ, ತಂಬಿ ಕಳಿಸ್ತೀನಿ, ಕೆಳಗಡೆ ಬಾ.
लोग बोलने से 10 लोग
आ जाएंगे अंदर. Good morning, Bengaluru. Welcome to the second day of the Krssdi at Nama Bengaluru. I'm sure all of us agree that we have a lot of fluctuations in our own life that's very similar to the glycemic variability that diabetic patients face. So the topic for today is glycemic variability and CV risk. Focus on remogliflozin in Indian evidence. And the chairperson for the same would be Dr. Praveen Gangadhara, who's the consultant diabetologist at Dr. Mohan's Diabetes Specialty Center at Malleshwaram. And the speaker for the topic would be Dr. Shekhar.
Hello, good morning. At the outset, I would like to thank the KRSSDI team, Dr. Suman sir, Manohar sir, and Vijay Kumar sir for this wonderful opportunity. I would like to start off the opening batsman for the day two. We have a very interesting topic. I think today there are two hot topics. One is we talk about the glycemic variability, the time and range. And second is this, the new class of molecule, what you call as the SGLT2 inhibitors, which have been a kind of a game changer in the management of diabetes. To give more info on this class, especially the focus on remogliflozin, we have Dr. Y. Shekhar, who is a consultant physician and a diabetologist. He would be taking us through this next 20 minutes on this class and also the topic of glycemic variability. I'm handing over the talk to Dr. Shekhar. Thank you.
Thank you, Dr. Praveen. Good morning, everyone. Fifth day of the test match, I think, today, between India and Bangladesh. So the result is anticipated, mostly in favor of India only. And so seems to be the crowd. They are not too interested, but I was just joking. There are a lot of people who are stuck there because of the mind-body workshop, which is very interesting, going on in Hall B, Dr. K.R. Narsim Sethi Hall. So to start the proceedings for the day, let us look back at our own clinical practice. How do we practice? Now, on a day-to-day basis, we see a lot of patients with diabetes coming to our clinics, and what we usually tell them is, okay, your sugars are fine, check your sugars after, say, 3 months and come back to us. But what we miss mainly is that, is it only the fasting and PP that we have to look at, or do we need to look at the 24-hour blood sugar readings also? So personally, what I feel is that we should always tell our patients that to keep checking their blood sugars once in a while. Maybe it need not be a fasting and a postprandial sugar level. They can also check a random any time of the day, or they can do a pre-lunch and a post-lunch, or a pre-dinner and a post-dinner. They can maintain a chart of that. And when they come to us for the next visit, they can very well show us the results. So that will give us a better idea about the blood sugar control over the 24-hour period mostly. We can call it like that. So this is where our topic is based around today. So glycemic variability. Now, like we can see in this graph presented here, in the first one, what we see is that the blood sugar levels have remained 40% high in a 24-hour period. The second one shows that the blood sugar has remained 25% high, and the third one shows that the blood sugars have been remained within acceptable limits or within the range throughout the day. Now, why do we talk about this time in range, or glycemic variability is what we are calling it? Not glycemic variability, like all of us know, we have been talking about it for quite some time now, that for about approximately 70% of the day, or approximately 17 hours in a 24-hour period, the blood sugars should be within well-accepted limits. So in the next graph, in the bottom graph, what you can see is that this shows a 15-day glucose traces of two subjects. Both of them had identical HbA1c levels of 8%, but different degrees of glycemic variability. So this high glycemic variability in subject 1, the top one, it was reflected by numerous episodes of both hypo and hyperglycemia. So variability doesn't mean only a hyperglycemia, but yes, it can be hypoglycemic episodes also. However, the second subject, he didn't have much of any of these such episodes. Now, why are you talking about this jumping or up and down of these numbers, or this yo-yo curve that we see the oscillations? Why? Because all of us know that diabetes mellitus per se is a known risk factor for cardiovascular disease. And based on the Framingham score, which is one of the most commonly used algorithms to estimate the 10-year cardiovascular risk of an individual, diabetes mellitus patients they show an increased incidence of cardiovascular events and have a 2 to 4-fold higher risk of cardiovascular mortality. So patients with diabetes already are at a risk of cardiovascular problems. So the Framingham score has proved it. Now recently, the attention has turned to glycemic variability as an independent risk factor underlying the CVD risk in addition to hyperglycemia per se. So it is not hyperglycemia per se, but even glycemic variability can also further enhance or increase the risk of cardiovascular morbidity and mortality. And recent studies have shown that glucose oscillations were more significantly associated with atherosclerotic related diseases than chronic hyperglycemia in patients with type 2 diabetes. So this yo-yo phenomenon, what we see, the oscillations in the blood sugar levels, whether it is a hyper or a hypo, is mostly associated with the atherosclerotic cardiovascular disease than hyper alone. This high glycemic variability in patients with acute coronary syndrome was associated with increased major adverse cardiovascular events, MACE, and cerebrovascular events also. Now, what we usually notice is that the postprandial blood sugar level goes up, spikes up a little. In many of us, especially the Indian population, if you see, the spikes are too high. That can be because of the carbohydrate food that we intake. Now, how does this postprandial hyperglycemia trouble us? So what this postprandial hyperglycemia or these glucose spikes do is that they can lead to inflammation, oxidative stress, endothelial dysfunction, and finally lead to cardiovascular events. So there can be vascular failure. So the risk factors are like hypertension, diabetes, dyslipidemia, etc. They can lead to inflammation, oxidative stress, or endothelial dysfunction, which can otherwise lead to again oxidative stress and metabolic abnormalities. So this can lead to smooth muscle cell proliferation or a plaque formation and further cause plaque instability leading to a plaque rupture or a thrombus formation, finally or ultimately leading to a cardiovascular event. Or in the smooth muscle, they can cause calcifications, like if it is a medial, example, the aorta you can see, or the intermedial, like the coronary artery. So postprandial hyperglycemia is a very important pathophysiological state contributing to vascular failure leading to cardiovascular events. Like I was talking earlier, the dietary pattern in Indian type 2 diabetes population in the STAR study, what was seen is that imbalanced dietary habits contribute to a high prevalence of insulin resistance and metabolic syndrome in the Indian population. There is a significant relationship between dietary patterns and risk of diabetes or pre-diabetes. So Indians are at a higher risk of diabetes or pre-diabetes also. There is a clear link between carbohydrate intake and postprandial glucose levels and insulin response. Indian meal pattern of high carbohydrate rich meal leads to a high PPG excursions after breakfast because of high glucagon and cortisol in the morning, and after lunch, and also after dinner, because of dinner is usually because of inactivity at night time. Now this meal pattern affects the glycemic variability, including the postprandial glucose excursions or hyperglycemia, especially in Indian diabetic patients having high carbohydrate rich meal. So the dietary habits of type 2 diabetes participants that were there are not much different from those of non-type 2 diabetic participants, and total carbohydrate constitutes 64.1% of the total energy from diet in type 2 diabetes patients, which is higher than that recommended in our country. We will discuss two small studies now. The first study is a prospective multi-center open label study to assess the effect of remogliflozin on glycemic variability when compared to dapagliflozin using CGM, that is called the REMED-GV study. So this was a randomized controlled trial to compare the effect of remogliflozin versus dapagliflozin on 24-hour glucose profile assessed by CGM in Indian patients of type 2 diabetes. The rationale of the study was that because remogliflozin is a novel SGLT2 inhibitor and it is approved for type 2 diabetes treatment with a twice daily regimen as compared to other approved SGLT2 inhibitors with a once daily regimen. The twice daily regimen of remogliflozin has been shown to provide equivalent glycemic control to dapagliflozin in phase 3 study. However, the impact of glycemic variability due to twice daily regimen was unknown, and remogliflozin twice daily regimen can potentially offer a better postprandial control in Indian patients whose dietary pattern consists of 2 large carbohydrate meals. So whether it's a lunch or dinner, yes, we definitely have a large carbohydrate meal. So this study was conducted to evaluate the effect of remogliflozin versus dapagliflozin on 24-hour CGM readings in Indian type 2 diabetes patients. Now, the objectives of the study: was to evaluate the effect of remogliflozin on 24-hour glucose profile by parameters derived from the CGM in Indian patients, and to compare the effect of remogliflozin on 24-hour glucose levels with dapagliflozin, again from the CGM readings. And the secondary objective was to evaluate the safety and tolerability of remogliflozin in comparison to dapagliflozin. So the study methodology was, it was a randomized 2-arm parallel open label study that was done. So the patients in both the groups are aware of what drug they were getting, and the study patients, they were mostly uncontrolled type 2 diabetes patients on stable therapy of metformin monotherapy or dual therapy of a metformin and a DPP4 inhibitor, and the duration of treatment of the study was of 6 weeks. Now the sample size, though it was very small, but it has provided some significant readings in that. So the sample size was 75, and the final analysis, they had around 65 patients. They divided both the patients, 33 in the remogliflozin arm and 32 in the dapagliflozin arm. And the remogliflozin, they had used 100 mg BD, and dapagliflozin was 10 mg, that is full dose once daily they had used. And it was done at 4 centers. The inclusion-exclusion criteria we have seen in most of the studies that was followed as per protocol. And the interesting part is that patients were enrolled on day 1, and they were fixed with a CGM device. Now this CGM device was removed on day 15, and the data was captured for those 15 days. In between, both the groups were started on either remo or dapagliflozin from the 8th day. So first 7 days, the CGM was only capturing the glucose readings of both the groups. From 8th day onwards, when the patients were initiated, they had 1 more week to again take down the data when the patients were initiated on either remogliflozin or dapagliflozin. And 15th day, once they discontinued the CGM or they removed the CGM, the study continued. The patients were continued on remogliflozin and dapagliflozin, and a new CGM device was implanted on day 36. So this again, they continued for another 2 weeks, so that was around 14 days, and on the 49th day, the CGM device was removed. Now, this CGM device, which gave us readings of the phase 1, that is the first 7 days, or we should say the first 7 days plus the 7 days again with the remo and dapa, and again the next 2 weeks with remo and dapa. So this is what gave us some very interesting readings. Now if you look at the patient demographics, so they had, like I said, they had 33 patients in the remo group and 32 patients in the dapagliflozin group. The duration of diabetes in months in both the groups, if you see, which is something very interesting, that patients who were in the remogliflozin group had were more than 5 years diabetic, and those in the dapagliflozin group were more than 4 years diabetic patients. Now comparison of glycemic parameters at baseline, if you see, both groups had almost similar HbA1c levels at 8.24 and 8.42, and the TIR of the same almost. Whether you look at the postprandial 1 hour or postprandial 2 hour glucose levels were also at the same reading, which was not significant. When we compare the glycemic parameters from baseline to phase 1, so this phase 1, when they were implanted with the device on day 1 and the device was removed on day 15, when you compare those readings, there were many significant readings that were seen with the remo and dapagliflozin both. So the mean glucose reduced at the end of phase 1 in the remo group as well as in the dapagliflozin group. Similarly, the MAGE, CV, LAGE, MPPG levels, the 1 hour postprandial and the 2 hour postprandial blood sugar readings also reduced significantly in both the groups. When you look at phase 2, again from baseline when they compared to phase 2, here there were some interesting readings again. The remogliflozin group showed a very good or significant reduction in the HbA1c, the mean glucose, the time in range, the MAGE, LAG, the MPPG, the 1 hour postprandial and 2 hour postprandial. However, the mean glucose levels, the cardiovascular events, the MPPG, 1 hour and 2 hour postprandial blood sugar levels were not so significantly changed in the dapagliflozin group. And when you want to comparison of change in the glycemic parameter values from baseline, there was not much of a significant difference in both the groups, whether it was the remo group or the dapagliflozin group. Again, in the mean change in time in range value, if you want to see, there was significant improvement from baseline to phase 1 and phase 2 with both remo and dapagliflozin, and there was no significant difference in improvement observed between. So when they compared remo and dapa together, there was not much of a significant difference in the time in range values. Again, when they wanted to look at change in postprandial glycemic parameters from baseline to phase 2, there was reduction in postprandial glycemic parameters with both remogliflozin and dapagliflozin. However, this reduction in the postprandial glycemic parameters was statistically significant in the remogliflozin group and not in the dapagliflozin group. So the mean or overall and meal time, if you want to see change in the MPPG from baseline to phase 2, if you want to see, the remogliflozin group showed much better drop in the MPPG levels. So this is represented here. So if you want to look at the breakfast, lunch or dinner levels, so remogliflozin showed better reduction in the blood sugar levels when compared to dapagliflozin. So there was a statistically significant reduction in the mean postprandial glucose excursions that were usually noticed in individuals in the remogliflozin group or with remogliflozin, usually and was seen at breakfast and dinner, whereas with dapagliflozin they were seen only at dinner time. Now the mean change in 1 hour postprandial glucose from phase 1 to phase 2, if you want to compare, again, if you want to see, there was a statistically significant reduction in 1 hour postprandial blood sugar levels with remogliflozin, but not with dapagliflozin, which was found at all meal times. Again, if you want to look at the change in 2 hour postprandial glucose levels, there was a statistically significant reduction in 2 hour PP glucose levels with remogliflozin at all meal time, but with dapagliflozin, it was seen only at breakfast and dinner. Now, if you want to compare the mean change in continuous CGM profile across the 24 hours from baseline to phase 2, what is noticed is that more reduction was seen with remogliflozin when compared to dapagliflozin, especially at night times. Now, this high carbohydrate meal and postprandial hyperglycemia in Indian type 2 diabetes patients, all of us know that during breakfast, lunch and dinner or after these 3 meals, our glucose levels go up. Now, remogliflozin, twice daily dosing and PPH control in Indian type 2 diabetes patients, if you want to see, remogliflozin showed that it has better control in the postprandial glucose excursions also that are usually noticed. Now, what are the conclusions of the REMIT-GV study? That this was a randomized active control open label study of 6 weeks, and the objective was to evaluate and compare the glycemic parameters. The results, what did they show? That there was significant improvement in time in range and HbA1c levels within both the groups, like within remogliflozin and dapagliflozin group, but no difference between the groups. So between DAPA and remo, there is no comparison when it comes to improvement in TIR and HbA1c. There was significant improvement in postprandial glycemic parameters also with remogliflozin, which were more significant than dapagliflozin. And there was also significant improvement in postprandial glycemic parameters at almost every meal time with remogliflozin, but there were few with dapagliflozin. And if you want to talk about the adverse events, they were almost similar in both the groups. Now, we'll have a brief summary about glycemic variability. Now, it is glycemic variability, as all of us know. So, we want to control blood sugars throughout the day, and the control in terms of both long-term parameters like HbA1c and short-term parameters like TIR, CV, MPPG should be the main objective of any anti-diabetic therapy. And postprandial hyperglycemia is an independent risk factor for CVD and has shown to further increase the risk of cardiovascular events in diabetic patients. Indian meal pattern that we have usually of a high carbohydrate meal every day contributes to the postprandial hyperglycemic excursions that we see. In the REMIT-GV study, what was noticed is that remogliflozin and dapagliflozin both showed similar significant improvement in the glycemic variability parameters, and for postprandial glycemic parameters and PP 2 hours, the improvement was significant with remogliflozin but not so significant with dapagliflozin. Also, there was significant improvement in almost every meal was seen with remogliflozin, but at a few meal time with dapagliflozin. So, remogliflozin might be better in reducing the glycemic variability with effective postprandial glycemic excursion control in Indian type 2 diabetic patients. We have one more small study here to discuss, that is the REMOLUTION, which was a clinical study. Interim analysis was done. This was a prospective, active, post-marketing surveillance study to assess the safety and effectiveness of remogliflozin and remogliflozin plus metformin, fixed dose combination in management of type 2 diabetes mellitus patients. So the design was, this was a prospective, multi-center, open label, single arm, observational, active, post-marketing surveillance study, and people with type 2 diabetes who are eligible to receive and prescribe the remogliflozin or remogliflozin metformin combination were taken into the study as per the discretion of the investigator. There was no intervention in terms of medication, investigation or procedures required as per the protocol and data generated in the course of routine clinical practice was collected. The patient participation duration was maximum up to 12 months, and the study was planned to recruit approximately 10,000 patients from approximately 100 sites across the country. Now, again, the same, we know about this inclusion and exclusion criteria. The patients who were diagnosed, and the study planned to recruit around 5,000 patients across 64 sites in India. Now, this is the summary of the subject disposition. So, 2,500 subjects were included who had completed the 12 months period follow-up. And demographics, if you want to see, age was 54.6, gender female to male was almost similar at 44 and 55. BMI also was, they were a little bit on the higher side of the BMI. And almost all the 1,800 patients completed the study, and a few had to be discontinued because of adverse events. So concomitant diabetic medication history, if you want to see, among the patients that were included, 2,500, few were on sulfonylurea, so most of them were on sulfonylurea, few were on AGI, DPP-4 inhibitor, TZD, insulin, and others. And they were started either on remogliflozin 100 mg or remogliflozin plus metformin 500 or metformin 1000 milligrams. So, so the overall summary of treatment emergent adverse events, if you want to see, that there have been the commonly reported adverse events were asthenia, pain, arthralgia, all this which are associated with usage of SGLT2 inhibitors, and some events that required serious intervention were hypoglycemia, UTI, but they happened in a very few patients. So, if you want to, again, the commonly reported SAEs were polyuria, cardiac disorders, bladder neck obstruction, sepsis, and pneumonia. Now, efficacy, if you want to see, the summary of proportion of patients achieving good glycemic control, if you want to see, at 12-month visit, most of the patients who were enrolled in the study had very good HbA1c reduction of around 7%. And remogliflozin metformin 500 or 1 gram, or only remogliflozin, the mean fasting glucose levels also reduced significantly. There was also a significant reduction in the postprandial glucose levels in all the three groups. And HbA1c also reduced from baseline and again when compared to 12-month visit, the HbA1c reduction was also very noticeable and significant. So remogliflozin, robust Indian studies backing our innovations. So there is rich evidence of remogliflozin in Indian type 2 diabetes patients, whether it's the Forever, where they had 182 Indian type 2 diabetes patients, or the Inspire, which had almost 37,000 patients, Revolution, which is still ongoing, and 5,000 plus patients are there, and phase 3 is 906 again, and Remit GV. So these are all ongoing large studies with remogliflozin. Thank you.
Thank you, Dr. Shekhar, for this wonderful and lucid presentation. I think you summarized it well. When you compare with DAPA, thanks to the short half-life of Remo, when you use twice daily, it has a better time and range as compared to once daily DAPA. So the usual burning question I think we ask is, before DAPA went off patent, I think Remo was everyone's favorite. It's not that this is a bad molecule, but though we know that SGLT2 in per se has a class effect in terms of heart failure and delaying the progression of diabetic kidney disease, why is still the EGFR cutoff still around 60 for Remo?
No, we do not have much of data when it comes to EGFR. So there needs to be a little bit more data with Remo so that will build the confidence of the diabetologist to prescribe.
Thank you. Thank you. Any, we can take 2 questions from the audience. Anyone, any questions from the audience? Any personal experience while comparing Remo with DAPA? Any personal concern of Remo being a twice daily molecule? Any worry about nocturia? Right. Okay. What is your take, sir, on when you talk about Remo as a twice daily molecule? How are your patients?
See, that could be one reason why we saw in this trial that the postprandial glucose excursions were not so noticeable with Remo because it was used twice daily, whereas DAPA was given only once daily in the study. So that could be something that's masking the effect of dapagliflozin when compared to Remo because it was given twice daily. Or maybe we can say enhancing the effect of remogliflozin.
To share my personal experience, I had a patient who was on Remo doing well, mainly because before DAPA went off patent. So once DAPA went off patent, I tried to switch him over just like that, though things are good. The patient himself actually reverted back to Remo twice daily, mainly because of the glycemic. When he obviously used to monitor his SMBG profiles, he felt he was doing well with this. My worry was nocturia, so I made it once, but I think it's not as bad molecule as we think. It does do the job. It's more like comparing vildagliptin with sitagliptin. The twice daily of vildagliptin kind of has a better time and range when compared to sitagliptin, though kind of both are equally good molecules. And nocturia, I guess, is not a bad. Individualization of the patient is more important based on the diet and their SMBG profiles.
See, when a patient walks into a chamber, you are the best judge to decide what is good for the patient. So what is best for the patient you can do or give, do that.
Yeah. Completely agree, sir. Thank you.
Thank you.
Thank you. Thank you.
Thank you, doctor, for enlightening us on the glycemic variability with remogliflozin. I think it's a Sunday morning. We all need to wake up. All of housekeeping announcement. I would request all who are outside to please settle inside, as it's already an hour when the session has started. An interesting topic now. I think all of us come across various people in our day-to-day life. N number of people we come across. And we cannot communicate the same way with everyone. So we need to have some observation, some learning on how do we communicate with each and every person. So today's topic will enlighten us on interpersonal skills, panacea for personal and professional growth. And the chairperson for the following session would be Dr. Arvind, who's the Senior Medical Officer at ISRO, and Dr. Suresh Kolapure, who's Consultant Physician at ISRO. And the speaker will be none other than Mr. Pankaj Srivastav, who's a very good expert in this topic. Welcome to the chairperson.
Hello. I thank the organizers for inviting for the professional and personal growth. He's a pharma professional with close to 40 years. Without wasting time, I'll hand over the mic to.
So good morning, everyone. Well, right at the outset, I'd like to thank the organizing committee, especially to Dr. Suman, to Dr. Manohar, to Dr. Vijay for giving me this opportunity to interact on a subject which is very close to my heart. And I'm going to explain to you why I say so. Simply because in my professional journey of last 40 years, I have seen numerous professionals, and that includes even doctors also, whom I considered as exceptionally brilliant. And when I say so, I am saying simply because the type of accolades what they had achieved in their respective arena. But still I felt that the type of influence which they should have wielded on the masses, they were not able to do so. And one of the main reasons what I felt always was their ability to get along with people. And very early in my career, one of my close friends had once said that, Pankaj Srivastav, your scientific prowess, your technical knowledge will only take you in your career up to a certain extent, and beyond that, it's your ability to get along with people which matters a lot. And I think that is one of the reasons why I'm standing in front of you to share some of the nuggets of interpersonal skills, which will definitely be extremely helpful, I can assure you, in your professional as well as in your personal journey. Now, I mean, if you asked me what are the basic tenets of interpersonal skills, well, the first main point is your emotional intelligence. You see, please appreciate that gone are those days when we used to talk about IQ. IQ is no doubt important. But more than IQ, when it comes to interpersonal relations, it is your EQ, your emotional intelligence. And when I say so, emotional intelligence, it's a vast topic. But there are two aspects of this which I'd like to touch upon. And they are, first, chances that the things are not going the way you expect things to go. And that's the time when you need to have your self-awareness as to what are the things which you like, what are the things which you don't like, what are the triggers which makes you angry and sad and happy, etc., etc. So that if you are fully aware about your self-awareness, you know, when things are either going your way or not going your way, you know exactly what are going to be the reactions. That's the first thing when it comes to self-awareness. And then based on self-awareness comes the self-control as to how do you react to those situations. Because ultimately that is what is going to decide how your relations are going to be. So that is one. Second thing is, of course, your cognitive intelligence. I mean, for doctors, it's extremely important because your relations also depend on what type of treatment outcomes our patients are going to have. So from that point of view, your ability to diagnose, system thinking, what is the way in which you are going to arrive at your decision, and pattern recognition, etc. This will go a long way in the diagnosis of your various diseases. More than that, of course, is another thing, which is social intelligence. And when I talk about social intelligence, all these things are a part of that, like empathy, like active listening, influencing skills, right? Social awareness and teamwork. And I'm going to dwell on this a little bit more, especially on empathy and compassion in my next slides. Because please appreciate, these are two separate things. Empathy, everybody knows. Empathy is putting yourself in the other person's shoes. But what is the compassion? And for doctors, I feel empathy and compassion both go hand in hand and are extremely important if you really want to have good interpersonal relations, good, binding with, good connect with your patients. Of course, influencing skill will involve so many things, like your own ability to communicate with the patients are coming, etc. And teamwork, of course, because everybody is now working in the team. So let me dwell upon what are the interpersonal skills we are talking about as far as the professional growth is concerned. Well, you will appreciate that the doctor-patient interactions these days are changing, right? Diseases are becoming extremely complex. 2 years back, we didn't know what is COVID. I remember when COVID struck, there were all types of things which were going on. We were talking about, cytokine storms and how we are going to deal, etc. Let me also tell you that I always associated fungus with green color. It was for the first time I read something like black fungus when COVID struck, right? So the diseases are becoming complex. Still, we do not know what's going to be the long-term complications of long COVID. We keep on hearing whether it's going to be impacting the heart, because heart failures are also happening in those patients quite often nowadays, those who have suffered from COVID, etc. So things are becoming complex. There are various healthcare teams now working. Increased patients' expectations also there. Patients are not what it used to be, say, 40 years back. Blame and complaint culture is also quite prevalent nowadays. Litigations, diversity, resource limitations, all these things pose a great challenge as far as our doctors are concerned. I also remember some 30, 40 years back when I started my career, whatever doctors they used to say, and some of the senior doctors will vouch, their suggestions were gospel truth. Patients never used to ask anything. But can we say the same thing now? And there are various reasons for that. I don't want to, due to positive time, I will not dwell on that. But otherwise, the things have changed over the years. And from patternistic model, which used to happen, say, 30, 40 years back, we have now informative model, where doctors, they give the patients facts. Then it moved to deliberative model, where doctors were telling that, look, this is the problem, and this is my preference. And now today, thanks to internet, thanks to Google, the situation has come that doctors say, look, this is the diagnosis, this is my preference, and still I will help you to arrive at some consensus, so that at least the patient's consensus also matters a lot. May not be in ICU settings, but otherwise, when it comes to chronic diseases management, patient's willingness is also extremely important, because merely prescribing medicines is not going to give you the desired results, simply because the compliance plays a very important role there. So this whole paradigm, ecosystem of doctor-patient interactions has gone completely changed. Now, in this situation, why this is important? Simply because, as I've mentioned, from patternistic model to more patient-centric approach we are talking these days, empathy, compassion, and trust, they are the cornerstones. And when I talk about empathy, what exactly, what I mean is understanding from which background the patient is coming. I remember when I was a small kid and when I used to go to doctors, I had observed many doctors, they were friends of my father. They used to ask about patient history. They used to take what you are doing, what your children are doing. And later on I realized that basically they were trying to figure out from which socioeconomic strata this person is coming and how I should deal with him. That was the compassion. Now based on that was the empathy. Now based on that comes the compassion as to how you are going to help the patients. And I'll give you example. Suppose there's since I'm talking to a diabetologist group, suppose there's a patient who's coming to you with a serum creatinine of say 4.75 and this person requires dialysis. Now, if you have actually interacted with this patient and you have come to know that this patient comes from a lower socioeconomic strata where he has to undertake a lot of other responsibilities, and if you are able to suggest this patient to a center where maybe the dialysis is slightly at an economical rate done, that is the type of compassion. Or if you suggest him some other measures by way of which he can reduce his disease expenses, that is the compassion what I'm talking about. Now, this requires a lot of personal touch also. But then, trust me, this goes a long way. Because you might have impacted that one patient, but this one patient is going to influence 20 other people as far as the goodwill is concerned. So that is what I'm talking about, the importance of empathy as well as compassion. Now, coming back to further. There was a study which was done by Mike Stone, Director, Patients Association. It's an old study, but still it holds true even now. And the question was, what do patients want? So this survey was done, and there were 5 things which emerged from this survey. First thing was eye contact. Patients said that when I go to a doctor, what I expect is that doctor must pay attention to what I'm saying, what I'm expressing. And very often when the doctors, they are distracted, when they are not listening to attentively what I'm sharing, it puts me off. So that was one expectation of the patients. Second was the partnership. Even then also in 2003, mind you, the patients, they expressed that I want that the doctor must ask my opinion also. It's not that whatever comes, he simply writes. So even in 2003, this point came up. Third was the communication. Communication plays a very important role. Your language, ultimately, many times the patients, they get overawed by the stature of the doctor also, which is also a fact. If I'm going to meet a professor, an HOD, and sometimes I'll get overawed, I may not be able to explain that. So it's important for the doctors also to put this person at ease so that he's able to explain his point of view. Fourthly, of course, time, because nowadays, nobody has got time, and patients' expectations are huge. Thanks to, again, Google. When they come to you, they would have Googled so many things. They have got so many doubts. And under this situation, the patient's coming to you. So he's got lots and lots of questions, and they want to listen only from the doctors, not from the counselors. That's another problem. And of course, lastly, appointments. So that was also one of the expectations patients said that we want that the doctors, they must adhere to the time. I want to pose one question to this audience. How much time do you feel a doctor spends in India? There was a BMJ study which got published. So I'm giving you 5 responses. There was 2 minutes, 5 minutes, 8 minutes, 10 and 20. 10 and 20 you can discount. May not be true. Straight away I am telling you. But out of A, B, C, what do you feel? How much time our doctors are giving? 2 minutes? 5 minutes? 5 minutes? A and B. Okay. Okay, I will take it. Reason is, see, when you are going to a bigger center, maybe because the time schedule is done in such a manner that doctors are able to give 2 to 5 minutes. I completely agree. Answer is 2 minutes as per this BMJ study. But spare a thought for those doctors who are working in district hospitals where there are 20 patients surrounding them, right? And 20 or 30 waiting outside, jostling to go inside the room. And under these circumstances, he is working. Spare a thought for him. How much time, poor fellow, he can give? So the situation is that it may vary even from 1 minute to less than 1 minute also in some cases. Now, in this scenario, if you have to connect with the patient, it's practically impossible, right? So that's the problem, which from a clinician's point of view, I want to say that. How much time is there? I'm just looking at it. Then comes the empathy and compassion. Now, these are, again, very important points, but how can you increase your empathy and compassion? So I'm going to give you one formula. That formula is EIR. That's the EIR is the formula if you want to improve your empathy and compassion score. LIR. L stands for listening. So if you are a good listener, whatever patients they are telling you, if you can listen attentively, then obviously you will be able to build connect with the patient. Second is the interest. See, interest is all those 5 points which I just now highlighted. Interest is patient also observes whether the doctor is really interested in me or not. And this interest, he will see how much eye contact you are able to give, how much listening you are able to give. All these things will actually determine whether you are really interested in the patient. And thirdly, of course, is the respect. I mean, respect, think about it. I mean, a patient who's coming from a very lower socioeconomic strata, do you really provide that sort of respect to that patient? I will not say anything. I leave this thought with you only. But then all these three things, they go a long way in building the empathy and compassion score. And some of the other points are like honesty, consistency, whatever you are saying, and of course your commitment to the patient, right? Then of course, I mean, it goes without saying, this cartoon says, the pain starts in my husband's lower back, then it travels up to the spine, to his neck, then it comes out of his mouth into my ears, and that's why I get these headaches. I mean, the moral of the story is, if you are really listening, you will be able to go to the root cause of the problem, right? Now, so therefore, if I want to summarize what are the skill sets needed for your professional growth, well, verbal communication, troubleshooting skills, coping with pressures, team players, good listener, all these things, work etiquettes, self-confidence, positive approach to criticism, time management, empathy, all these things will go a long way in building your connect as far as your professional competence is concerned. Now, in the remaining 5 minutes, I'm going to touch upon how your interpersonal relations can be extremely helpful as far as your personal growth is concerned. Now, when it comes to personal interactions, you know, there is a very old concept. This concept is known as Johari window. This concept was propounded by Joseph Luft and Harry Ingham somewhere in 1955, and this still holds true. Now what it says there are 4 scenarios, right? The first scenario is where you know certain things about the other person and the other person also knows about you. So that is one quadrant where both of you know each other. The second quadrant is this one. The second quadrant is where, you know certain things about yourself, but the other person does not know. So if you want to build connect with this person, it is extremely important that you must reveal yourself. Now, reveal, I mean, I don't say that you reveal about those secrets which you should not. No, I'm not saying that. It's a very mature audience, so I don't want to name those things also. But then the fact is, certain facets of your life, if you are able to reveal to the other person, you will be able to build connect with that person. That's the second quadrant. The third quadrant is the unknown area, where you also do not know, the other person also do not know the potential. So, like for instance, if I say that, look, we both have not gone to, say, Mount Abu, just to give you an example, and let's explore. And if we both decide that, okay, fine, let us explore Mount Abu, your relations are going to increase if you both go and in a joint venture there. And if you're both, you or your families, they go together, your relations are going to be increasing. And the fourth quadrant is very important. It says blind spots. It says that other person knows about you, but you do not know those shortcomings. These blind spots, it's extremely important. I'll give you one example. Again, I'm watching the clock, so, you know, I always in my career, I was a very punctual person. 9 means 9 to me. And Deepak will vouch because he was once upon a time in the city of Bangalore, he used to work with me, right? 9 means 9. And this used to put off many of my people because in Bangalore, traffic, maybe, I mean, you are late by 5-10 minutes. Even if I was not saying anything, but that frustration used to be written all over my face. And that used to put off people. So sometimes you feel these are your strengths, but these are actually your weaknesses. So when you take a 360-degree feedback from the other person, you will come to know what are my blind spots, and then you may be able to correct those blind spots. So that is why it's extremely important that feedbacks must be taken. And when somebody gives feedback, you should be very honest, and with folded hands, you must accept it. Because what happens if your ego comes over there, that, look, I am so-and-so, how can I take feedback from this person? Then maybe the other person will not give you feedback, and your blind spot will remain as a blind spot, right? So in terms of your growth, in terms of your interpersonal skills, that will not happen. So this concept is extremely important when you want to build connect for your personal growth. So that's one. Secondly, of course, we all know that win-win situation is a best way of building relationship, because if there is any other thing, I win, you lose, the relations will not be very good. You might have won during that moment, but obviously this person is going to give it back when his turn comes, right? Same is the case. You know, I lose, you win. Okay, fine, I have conceded to you, but I will remain, I will think about it. Okay, fine, my turn will also come, then I will see. And then, of course, I lose, you lose. It's most destructive in the relationship. And win-win is the best way to foster your relationship. And lastly, I think I'm in time. Yes, lastly, how to say no. Now, this is again a very problematical area. Most of the people, they fear saying no, isn't it? Does it happen or not happen? Is it easy? I can tell you in my professional journey, whenever my bosses, they used to load with lot of targets, I used to find extremely difficult how to say no, because I used to feel the consequences, what consequences will be. If I say no to him, what will happen? But fact of the matter is, if you want to build relationship, you have to say no. Because if you don't say no and you say yes, and if you are not able to deliver, then your relations are going to be much worse. Right, so it is better to say no, but the point is how to say no. So I'm going to give you 4-step process how you can say no. Okay, first is listen to the request, right? Let him complete whatever the other person is saying, because very often we tend to interject when somebody is saying, right? The second thing is say politely no, but firmly, and don't build false hopes that, look, this is not possible, sir, and then you tell your schedule also why this is not possible. The third is give reasons why this is not possible, what are your priorities, etc., schedules, and that is going to reinforce your credibility. And the fourth one is give another alternative. You tell that, look, sir, this is not possible, but this is what I can do. So this way, at least, again, it's a sort of win-win situation also. This is not possible, this is very much possible. So in this way, you will be able to say no without infuriating the other person and without jeopardizing your relationships, right? With this, I would like to summarize. These are the things which I have just now talked about. 3 pillars of emotional intelligence. These are for professional growth. These are for personal growth. Thank you very much for your patient listening. I'm open for any questions.
Thank you, Mr. Pankaj. I think we had excellent, we could connect with the audience and communicate. And this ever-changing doctor and patient relationship, I liked that model of paternalistic to
Yes.
moving to communicative, and so if any 1 or 2 questions we can definitely take up.
Any questions, any observations?
I have a question.
Yes, sir.
Does this books really help? I mean, self-help, improve your communication. So if you search and you see so many. Does they really help, or?
See, books definitely help, because they will let you know the abstract, what are the basics. But ultimately, in interpersonal relations, it is your ability to implement that. You need to practice that. Anything which you don't practice, see, lectures, especially when it comes to skill building, are of less help. Skill building will only take place provided you practice that. Right, and for that practice, you need to have that atmosphere where you can practice that. So books, to summarize that, books definitely help, because you will know the abstract concepts, but then you need to practice that.
Thank you. There are no questions. I think we can wind up this session.
Thank you very much.
Thank you.
Good day.
We'll have a group photo. I would be joining for the group photo if you don't mind. Thank you, Pankaj sir and doctors. I think this will help me in interaction with all of you in the course of the day. Moving on to the next topic. we got to know about glycemic variability in our first topic. Now, the next topic will tell us how to mitigate these highs and lows in type 1 diabetes specifically. For this, I would like to invite the chairperson, Dr. Sushma Rai, who's the pediatric endocrinologist at Padmashri Diagnostics and Cod Road Hospital, and Dr. Preeti, who's a consultant diabetologist at Dr. Preeti's Diabetes Care Clinic at Jayanagar. And the speaker for the session would be Dr. Tony Joseph.
So a warm good morning to all of you. So we had a wonderful presentation on interpersonal skills by Mr. Pankaj. That was really interesting. And beyond this, we have another interesting topic on type 1 diabetes, like managing the highs and lows. And let me take the privilege to introduce Dr. Tony P. Joseph. He is the founder and director, Hormone India, consultant endocrinologist at Hormone India and at GG Hospital and Sri Gokulam Medical College. Sir, the podium is yours, sir.
Thank you, ma'am, for the kind introduction. And I would like to thank the organizing committee for having me here. So my topic is managing or mitigating the highs and lows in type 1 diabetes. So all of us see people with type 1 diabetes in our routine practice, and it is actually a headache when we see their blood sugars fluctuating between highs and lows, and sometimes coming within the normal range. So why these fluctuations occur in people with type 1 diabetes, I'll be discussing it in short. How to manage these fluctuations. Of course, we cannot totally avoid the highs and lows, but we can mitigate it. And two important aspects that I would like to cover on is sick day rules and ketone monitoring during these periods, and about hypoglycemia, how to manage it, and about glucagon administration during this time. So type 1 diabetes, we all know, is an autoimmune condition, leads to the beta cell destruction, insulin deficiency, hyperglycemia, and its related complications. So 100 years back, insulin was discovered, and it gave new life to people with type 1 diabetes. Prior to that, it was virtually a death sentence for people with type 1 diabetes. So type 1 diabetes is not just a disease of children and adolescents alone. So this is a UK-based study where they showed that at 60% of the patients with type 1 diabetes, they have their onset before 30 years, predominantly in the childhood age group between 4 to 6 years, where one peak is present, and between 10 to 14 years, where you have the second peak. But you have to know that in adults also, more than 30 years, the onset is seen in around 42%. Of the total number of type 1 diabetes patients, 40% have their onset after 30 years. And many of these children and adolescents, they grow up to be adults and come into the adult practice. So what happens in type 1 diabetes? You have absolute insulin deficiency, and you are giving exogenous insulin to these patients. And exogenous insulin cannot always be matched to the patient's carbohydrate intake, to the level of activity that he's doing, the emotional stress, the sleep. You cannot always match the insulin to the patient's requirement. So that is why patients might have hyperglycemia if the insulin is on the lower side, or hypoglycemia. And again, you don't have the paracrine glucagon signaling, whereby in normal patients, when there is hypoglycemia, there is a paracrine signaling to the alpha cells of the pancreas, and glucagon increases, and this mitigates the hypoglycemia. So this is not seen in people with type 1 diabetes. So also you have other associated autoimmune conditions associated with type 1 diabetes, like celiac disease, adrenal insufficiency, very commonly seen thyroid disorders. All these, if not diagnosed, can cause fluctuations in blood sugars. So the best therapy for people with type 1 diabetes is a basal bolus therapy, we all know this, or an insulin pump in those who can afford it. So how to reduce the highs and lows? So I'll be covering only some main topics here. So one of these is you can go for the newer basal insulins, especially the second generation basal insulins, which have very minimal glycemic variability, like the degludec or the glargine U300. And do rapid acting insulins help with respect to mitigating hypoglycemias? So this is this is a meta-analysis of 22 RCTs where they looked at short-acting insulins like aspart, lispro, and glulisin versus regular insulin. So here again, this found out that when you're using short-acting insulins, the chance of hypoglycemia, it significantly comes down. Nocturnal hypoglycemias, the chance of severe hypoglycemias, all these significantly come down. Another problem we face when patients are on multiple daily insulin injection is lipodystrophy. So lipodystrophy can either be lipohypertrophy or lipoatrophy, and this should always be looked for in patients having wide fluctuation in blood sugars. So in the first diagram, you can see lipohypertrophy. This is mainly because of insulin injection into the same site over and over again, which leads to the proliferation of fat cells at that particular point. So again, you have lipoatrophy also, which is atrophy of the fat cells that you can appreciate around the umbilicus. So be it lipohypertrophy or lipoatrophy, the problem is that if you inject insulin into these sites, you have erratic absorption of this insulin and erratic blood sugars. So how to avoid this glycemic fluctuation due to lipodystrophy? First of all, it is prevention. Ask the patient to rotate sites frequently, look at the sites at each visit, and advise them to change the needles or the syringes at least once a day. Carbohydrate counting is a very important part in people with type 1 diabetes. This is to match the amount of carbohydrate intake with the amount of insulin that you are giving. So this is not always possible to the right amount, but at least patients should have a rough idea of what the carbohydrate content in their meal is. So we know that these carbohydrates are ultimately converted into glucose. So here you see that there is a patient is eating a banana and he's having the banana is having around 17 grams of carbs, and this is converted to glucose into your bloodstream, and this glucose ultimately you should neutralize with the insulin. So how to start insulin in type 1 diabetes? We all know we start at 0.4 to 1 units per kg, and you can divide it equally between basal and bolus regimen, and then titrate according to the blood sugars. Correction factor is very important in people with type 1 diabetes, and this is also important in people with type 2 diabetes who are on multiple daily insulin injections. So you have two correction factors here. One is the insulin to carb ratio, where you correct for the grams of carbs by the required units of insulin. So basically, you get this from the formula 500 divided by total daily dose, or for rapid acting insulin analogs, and 450 divided by total daily dose when you are using a regular insulin. So this gives you the amount of the grams of carbohydrates that is neutralized by 1 unit of insulin. And then you have the insulin sensitivity factor, which is for correcting for the high blood sugars that are prevalent even before taking the meals. So this is got by the formula 1800 divided by the total daily dose if you are using a rapid acting insulin analog, and 1500 divided by total daily dose if you are using a regular insulin. So let's look at this with an example. So this is Amit, who's 21-year-old. He's having type 1 diabetes since last 2 years. He's on glargine U100 26 units a day and glulisin 8 units TDS. His total daily dose is 50 units. The insulin carb ratio, because he's using a rapid acting insulin analog, it is 500 divided by the total daily dose, which comes to 10. So this means that 1 unit of insulin will neutralize 10 grams of carbohydrate. And suppose he's going to have lunch at this point of time, and he's roughly calculating his carbohydrate intake to be around 80 grams. So his insulin requirement would be 80 divided by 10, which comes to around 8 units. Suppose his pre-lunch blood sugar at this point of time was 200. So you need to correct for that elevated blood sugar also. So this is where the insulin sensitivity factor comes in. So the correction factor is 1800 divided by total daily dose, which comes to 36 in this case. So 1 unit of glulisin in his case will reduce the blood sugars by 36 milligram percentage. And if you keep the target as 130, you can get by this formula 200 minus 130 divided by 36, you can get that the correction dose to reduce the blood sugar from 200 to 130 is around 2 units. So the total dose of insulin that is required in him will be the insulin dose for the carbohydrate intake plus the correction dose, which comes to 10 units. Continuous glucose monitoring again is very important, a very important tool both in type 1 diabetes and people with type 2 diabetes on multiple insulin injections. It avoids the finger pricks. It gives you the time in range, which is the better parameter than HbA1c. It gives you the time below range, time above range, and gives you an overall picture of the patient's blood sugar. Again, patients who are using the flash glucose monitoring device, they can actually see how the food is affecting their body, how particular foods are like increasing the blood sugar, or what foods are not elevating the blood sugars to a particular extent, or what exercise is doing to the body, etc. So people with similar A1C would not be having the similar glycemic profile. So we see this from this diagram where there is three people's glycemic profile that is shown, and we see that the person in red, he has a wide fluctuation in his blood sugar, and the person in yellow has the least fluctuation and is in the range most of the time. Again, SMBG will not give you a complete picture. If you look at this example, if the patient is monitoring the blood sugars at these points of time, he would be missing out on the high blood sugars and the hypoglycemias that are occurring during the night time. So insulin pumps again are a boon to patients with type 1 diabetes in those who can afford them. The newer pumps like the Minimed 780G, it automatically adjusts the basal insulin every 5 minutes according to the blood sugars. Again, newer bionic pancreas, the studies have come out. It does not even require carbohydrate counting. You just need to announce that you are taking a meal. And newer research is going on where both the insulin and the glucagon is being studied simultaneously, so that even if hypoglycemia occurs, it would be counteracted by the glucagon. So we know that one of the acute complications of hyperglycemia in type 1 diabetes is decay. So decay occurs in people with new onset diabetes who are young, low socioeconomic status, or having lack of health care. And already in established type 1 diabetes, if the patient is omitting insulin or there is pump failure or intercurrent illness, patient can go into decay. So one thing I would like to highlight here is that in order to prevent decay, you can at least monitor the blood sugars and ketones often. So how to do ketone monitoring? It's basically when a blood sugar is more than 250, at least at 2-point intervals, you need to monitor ketones. So ketones should be monitored when the blood sugars are high during illness, infections, injuries, or even if a patient is going for a strenuous activity. So you can do ketone monitoring in two ways, either a urine ketone or a blood ketone. Urine ketone can be easily done from the urine ketone strips, which are available usually as a pack of 50. And you can just dip the strip into the urine of the patient, take it out, compare with the color coding shown on the box. So depending on the color, from the light orangish color to the pink to purple, you see that the ketones are progressively increasing. Then you have the blood ketone monitoring. Blood ketone monitoring can be done by the Abbott Optium Neo devices or the readers of the Abbott flash devices. So blood ketone basically measures the beta hydroxybutyrate. So if the ketone levels are less than 0.6 millimoles per liter, then it is usually in the normal range, and if it is above that, you have to take action. If the ketones are more than 1.6, then the chance of decay rises, and if the ketones are more than 3 millimoles, then already the patient may be in decay. So why you measure this ketones? This is to take extra insulin dosage during the times of stress. So ketones can be elevated during the fasting state. This is a normal phenomenon. But when there is hyperglycemia in type 1 diabetes and you see that there is high ketones, you have to actually increase the dose of insulin. So many of times what patient does is, because they have poor eating habits during the time of illnesses, they skip the insulin. So this should not be done. This should be emphasized to the patient. And in addition to this, if you're finding an elevated ketone, you have to increase the dose of insulin. And using this table, you can roughly see how much insulin you should increase. So sick day rule should be emphasized to all people with type 1 diabetes. So basically, patients should be advised not to stop their insulin. They should be advised to check their blood sugars often. If the blood sugars are more than 250, they should check their ketones and if it is positive, they should increase the insulin dose or at least contact their healthcare providers. So during the sick days, patients can relax on their meal patterns. They can take the foods that they like. They can take in carbohydrate containing fluids like fruit juices. Patients should take in more fluids during this time. And if the patient is having nausea, vomiting, abdominal pain, diarrhea, or fever above 100 degrees Celsius with positive ketones, it is better to consult with the physician. So times to check ketones, these include new onset diabetes, when there is pump failure, when there is insulin omission, eating disorders, when the patient is taking low carb diet, when there is lack of diabetes education, when the patient is using drugs like steroids, alcohol or cocaine, or even if the patient is inadvertently on SGLT2 inhibitors. And also when there is mismatch between the insulin levels and the counter-regulatory hormones, like when the patient is doing a heavy, high-intensity exercise or infections, infarctions, surgery, trauma, etc. Hypoglycemia is one of the limiting factors that prevent us from achieving a good glycemic control. These are the levels of hypoglycemia. I think we all know this. And symptoms of hypoglycemia, again, we know this. We have both adrenergic symptoms and neuroglycopenic symptoms. Patients with type 1 diabetes are at threefold higher risk of having hypoglycemic events compared to type 2 diabetes. And with increasing duration of diabetes, the risk of hypoglycemia increases, both in type 1 diabetes and type 2 diabetes. So why the hypoglycemia? This I have already explained. Because you're giving exogenous insulin, you cannot always time it correctly with the carbohydrate intake, the activity of the patient, etc. And you do not have the paracrine signaling from the, you don't have the counter-regulatory glucagon hormone, which increases in cases of hypoglycemia. So one thing you have to know in type 1 diabetes is that at any level of A1C, you can have hypoglycemia. So this is not true in patients with type 2 diabetes, where if you have a high A1C, the chance of hypoglycemia is very, very minimal. But in patients with type 1 diabetes, if you are having high blood sugars, high A1C, the chance of hypoglycemia is also higher. And there is a condition called as hypoglycemic unawareness, which is present in 1 in 4 patients with type 1 diabetes, around 10% of patients with insulin-treated type 2 diabetes. This increases the risk of severe hypoglycemia by around 6-folds. And what you have to do is you have to scrupulously avoid hypoglycemia and keep the blood sugars at an elevated target in order to bring the patient out of this hypoglycemic unawareness state. So in simple words, type 1 diabetes is a condition where you are at a high risk of hypoglycemia. So what can we do about it? So at each visit, you ask the patient about symptoms of hypoglycemia, how many hypoglycemic episodes that he had in the previous week or the previous month, and look at the blood sugars of the patient and whether the blood sugars are low and the patient is experiencing symptoms or not. Sometimes the patient may have hypoglycemic unawareness also. So you review on how to treat these patients. You look at the you look at whether the patient knows to take glucose during this time, whether the patient is having glucose at home, either in the powder form or as candies, or advise them on what all corrective measures they can take during these times. And one insurance that the patient should keep at home is glucagon. So glucagon administration is very important. It is life-saving in patients who are having severe hypoglycemia. And we should ensure that the patient and bystanders know the use of this glucagon in cases where the patient is experiencing severe hypoglycemia. So prevention is the key. Patient should have a medical alert bracelets or medical alert cards when patient is going outside. So because of want of time, I'll just be skipping to glucagon. So glucagon is approved for severe hypoglycemia. It is seldom used in our practice. You have 2 generations of glucagon. One is the first generation glucagon, which is available as lyophilized powders. You have to reconstitute them. You have second generation glucagons, which are available as nasal powders. Then you have the pre-filled syringes, and you have the newer glucagon analogs. The problem with the first generation glucagon is that it should be reconstituted, and it is seen that even after having these glucagon with the bystanders. Most of the time, in 60% of the patients, 60% of the cases, they are not able to administer this glucagon because of the complexity of mixing it and then loading it into the syringe and taking the glucagon. So here this is overcome by the nasal glucagon. So in nasal glucagon, you just need to remove the wrapper, you take out the device, you put it into the patient's nostril and just push the plunger, and the patient will recover within 15 minutes. At least he will have some elevation in his blood sugar. And usually the time to success is 16 minutes in people who are using nasal glucagon. Then you have the native liquid glucagon preparations. This again is available in pre-filled syringes, and you just need to put it over the site of administration and just need to press it, hold it for 5 seconds, and the glucagon will gradually increase the patient's blood sugar. You have the Dasi glucagon, which is a more stable preparation of glucagon. It is produced by amino acid substitution. So this makes it more stable at room conditions. So Dasi glucagon is given as a dose of, I'll be finishing in 1 minute. So it is given in a dose of 0.6 mg, which comes in pre-filled syringes, but not available in our part. So just in crux, how to prevent the highs and lows. So basically it is about a healthy, balanced diet, asking the patients to count their carbs, and in patients who are not very intelligent, who can't do proper carb counting, at least ask them to keep the amount of carbohydrates constant. If you're taking a particular amount of rice or rotis or whatever carbohydrates, ask them to keep the amount constant so that at least you can adjust the insulin according to this. Ask them to do regular exercise, inspect the insulin sites at regular visits for lipodystrophy, preferably use first generation or even better second generation basal insulins and insulin analogs to prevent highs and even lows. Use correction doses of insulin for both the carbohydrate intake and for the prevailing high blood sugars. Continuous glucose monitoring should be advised at least every 3 to 6 months in people with type 1 diabetes, and more frequently if they are able to afford it. Insulin pumps are definitely a boon to those who can afford it. Sick day rule should be emphasized. Patients should not skip insulin during sick days. Ketone monitoring should be part of sick day protocol. Hypoglycemia treatment should be emphasized at each visit. Patients and bystanders should see to it that they are having glucagon in their house so that they can administer it at the right time in order to prevent serious hypoglycemia related injuries. So effective control of hyperglycemia, it requires effective prevention of hypoglycemia also. So thank you for the patient listening, and if there are any questions or queries, I'll be happy to take those.
All aspects. So if anybody has any questions. So I just had one thought.
Yes,
because pediatric endocrinologists, we just look at children with type 1, but as you rightly said, when the transition happens and and they move over to y'all, is there any role for any oral hypoglycemic agents to prevent the postprandial excursions?
Ma'am, there are definitely studies where you can use voglibos, you can use non-insulin dependent OHAs, like the voglibos, where you can prevent the absorption of glucose from the gut. Second is you can use SGLT2 inhibitors, but the problem is if you're using SGLT2 inhibitors, if the patient skips insulin, there is a chance of euglycemic decay. So it is always better to ask the patient to take insulin alone, and if the patient is developing another form of diabetes, like if the patient is having a family history of type 2 diabetes, he's becoming obese later on and he's developing the acanthosis and all, you can always try metformin.
As you said, if it is only type 1, I think we're just continuing the same
Yes,
care
ma'am.
what
Yes,
we offer
ma'am.
in pediatrics.
Yes, ma'am.
Okay, thank you so much.
Hello.
Yes, sir.
We have studies in type 2 diabetes regarding the percentage of patients having HbA1c at 7%, like that. Do you have any studies in type 1 diabetes? Because in type 2, we see mostly 25 to 30% of the patients will be in their goal. So
it is almost the same. type 1 diabetes, the control rate is only between 20 to 25%, and that too with frequent hyper and hypoglycemias. In type 2 diabetes, as you rightly said, sir, the data is around 30%, and similar to type 2, around 70 to 80% of type 1 are uncontrolled.
And even in your practice, have you seen type 1 diabetic patients requiring a high dose of insulin? Of course, is it due to insulin resistance or is it due to any other factors?
So type 1 diabetes usually does not require insulin more than 1 unit per kg, except in times of stress and infections. All the other times we usually are able to manage them with insulin doses within 1 unit per kg or around 1 unit per kg, 1 to 1.2 units per kg.
Thank you.
If I can just add to that, sir, we do see children who require more than 1 unit per kg, but most likely there are reasons. I think what Dr. Tony Joseph pointed out. So either, there are lipohypertrophies or, insulin is being skipped or the carbohydrate count is very high. So I think we need to go through those reasons when we definitely look at a higher dose.
And again during puberty time
and
also.
Puberty, of course. And maybe non-medical reasons also, we just have to. And I think in type 1, I know Mr. Pankaj said, doctors spend 1 to 2 minutes. But for us as pediatricians itself, we spend a lot of time. And in pediatric endocrinology, especially in children with diabetes, I think we spend a lot of time. And it will be unbelievable for the adult diabetologist if we say, sometimes we take over an hour for a single patient because a lot of counseling and, I think all the factors which you mentioned has to be actually conveyed to the family. So we spend a lot of time, Mr. Pankaj.
Yes, sir. Yeah.
Thank you very much. Just wanted to know what is the association of other disorders with type 1 in your practice? How many of them turn hypo or hypothyroid? What is growth hormone status in them? What about other associated conditions like malabsorption and so on? How often do you screen for them? And just wanted to, in your practice, how much you see them?
Okay, sir, in type 1 diabetes, other autoimmune conditions are very, very common, like hypothyroidism and sometimes hyperthyroidism. If you take both of these together, around 30 to 40% of patients with type 1 diabetes at some point in their life will develop this condition. So we asked for frequent screening of frequently doing a thyroid function test at least yearly in these patients. And regarding adrenal insufficiency, celiac disease, pernicious anemia, all these are there. It can be seen in people with type 1 diabetes, but you don't screen for these. If patient is having a fluctuating blood sugars, he's having symptoms of celiac disease like abdominal pain, bloating, etc., you go for a celiac disease screen. If patient is losing weight or having frequent hypoglycemias, developing pigmentation, postural symptoms, hyponatremia, then you go for adrenal insufficiency screening with an 8 AM cortisol. And pernicious anemia screening, usually we do not do, but once in a while you can look at the hemoglobin of these patients, and if you see that patient is having a macrocytic anemia, you can definitely go for the screening of this also.
Thank you.
Thank you so much, Tony Joseph. It was a wonderful presentation, and we got extra insights on how to do the correction policies for people type 1, and also mitigating the highs and lows. It was a wonderful presentation.
Thank you.
Thank you.
So we can have a group photograph of the chairperson and the speakers. Thank you, doctor, for enlightening us on the topic mitigating highs and lows in type 1 diabetes. So COVID has put a lot of light on vaccination. Now everyone is talking about vaccination. So the next topic will tell us adult immunization and diabetes. The chairperson for the next topic would be Dr. Prabhakar, who's a diabetologist, and Dr. Ramchandra Prabhu, who's a physician and diabetologist in Bangalore. The speaker would be Dr. Ravi Kumar.
It is Rajpur. Dr. Ravi Kumar is a Professor and HOD at JSS Medical College, Mysore. He will be taking on immunization. Sir, stage is yours, sir.
Thank you, Chairperson. I thank Dr. Manohar, Dr. Suman for giving me an opportunity to speak on this podium. Today I'll be speaking on adult immunization and diabetes. We all know that there is an increasing burden of non-communicable diseases across. We tend to see the big chunk of non-communicable diseases are cardiovascular diseases, cancers, and most important of them are the chronic respiratory diseases which we often see. And NCD kills almost to the extent of 41 million people every year, and 15 million of NCD deaths, unfortunately, fall into the age group of 30 to 69 years. There's the statistics which clearly says, and we are clearly aware that the 10 leading causes of deaths, if you look into that, apart from IHD or strokes and ischemic heart disease, infections take a major chunk. Okay, we clearly see that infections, either primary infections like pneumonias or in the background of COPD, contribute a significant risk for mortality and morbidity. And we all know that there is an increasing prevalence of diabetes, and we tend to see that almost 1 in 11 people across the globe tend to be diabetics, and India is still holding the second in the diabetic capital of the world. Now coming to the infection part. Diabetics, we all know that there is an increasing risk of developing and dying from infectious diseases. One of the most important complications of diabetes. Longer the duration of diabetes and poor glycemic control, the risk of infections to significantly increase. And this was a beautiful study which I found. This was from US, which clearly says that there is an increased risk of hospitalization and infection-related mortality in diabetics compared to non-diabetics, to the extent of almost 2 to 3-fold rise in diabetics, wherein the infection-related mortality is significantly higher. Now, what factors contribute with these infections in diabetics? One, we know that the humoral response or antibody response is poor, and we tend to see that diabetics tend to have significant cell-mediated abnormalities. We know that the CD4 to CD8 ratio is very, very important. And that's the major factor which tend to get altered when patients' immune defenses go. And CD4, CD8 ratio tend to get altered if patient has a poor glycemic status, impaired leukocyte function, and colonization with contribution pneumonia. And we all know that hyperglycemia contributes to various factors in neutrophil functions. That means, say, it reduces neutrophil degranulation. It comes in the way of chemokine expression, and it also comes in the way of phagocytosis by monocytes. It comes in the way of complement inhibition, and it also comes in the way of CD8 action. That means, say, you can just look into that. Hyperglycemia comes in the way of neutrophil function to a significant extent. There's something which is very clear. Say that infection worsens because of the underlying hyperglycemia. And hyperglycemia either directly or indirectly through macrovascular or microvascular complications and its disturbance on immune system tend to worsen the infection scenario, and infections tend to increase in diabetics. So we need to fight. So Dr. Manohar morning told about importance of yoga, exercise, diet, stress relief, sleep, and control of comorbidities, which are important to build our immune system. What next? We need to immunize ourselves. So immunization plays a major role in preventing infections. So what is immunization? Immunization refers to, there are two ways of immunizing ourselves. It refers to artificial induction of immunity, either by active ways or by passive ways. What is active immunization? It is administration of live attenuated by infectious agents or inactivated toxins or antigens which are obtained by genetic recombination. Passive immunization refers to temporary transfer of immunoglobulins or antitoxins. Is this helpful? We all know the success story of COVID vaccine. We all know about the importance of eradication of smallpox, polio control or polio eradication. All clearly say that immunization definitely is beneficial. Now, why in adults? Now, we know that as adults, with aging population, they become more susceptible. There is increased risk of comorbidities. We tend to see a lot of diabetics, COPD patients who tend to have their immune systems being disturbed. There is increase in exposure to infections because of this one. And the habits, especially they tend to affect their hepatic as well as lung functions. There is increase in antibacterial resistance. And we don't have a vaccination program for adults as we see in pediatric vaccination programs. So it's important to vaccinate. If vaccinated, if not vaccinated earlier, at least you need to vaccinate them, or if vaccinated, we need to give a proper booster so that we prevent infections. Now, what about the risk of how many infectious diseases we have, which can be covered by vaccines? We have a big gamut of infectious diseases, predominantly viral, to many bacterial infections, which are vaccine preventable. Vaccine preventable diseases, which are quite important. And of them, the major chunk is by influenza. We know that adults with comorbidities have an increased risk of hospitalization after influenza infection. Diabetes, unfortunately, quadruples the risk of ICU admissions after hospitalization. And death rates in diabetics to go to the extent of go in the extent of 5 to 15%. And longer duration of diabetes, advancing age, poor glycemic control tend to be worse, have a bad prognosis on influenza. And we know that influenza is known for its antigenic shift and drift. We tend to see various. So what happens? The vaccines may not be really effective, which has been produced earlier. This was a nice article from an Indian which clearly showed that people who have been vaccinated are found to have a better immunity compared to non-vaccinated people. So that means the hospitalization rates were significantly lower among vaccinated people with influenza compared to non-vaccinated adults. We have, when you look into the vaccination we have several vaccines. Of them, we have two important vaccines. One is the trivalent vaccine and the quadrivalent vaccine, which we have. And we also have a nasal vaccine, which is a live attenuated vaccine, which can be administered. This unfortunately doesn't have a robust evidence on the effectiveness, but that's the reason most often we tend to recommend the quadrivalent vaccine, which is being used routinely. We know about the antigenic shift and drift, so that's the reason WHO comes up with guidelines. Each year, the influenza strain vary, so WHO clearly comes up with the guidelines to change the vaccine. So each year during the Northern Hemisphere, guidelines come up for the Northern Hemisphere and Southern Hemisphere, which vaccine is effective against which strains. And correspondingly, we need to change the vaccine every year. And we have the live-killed vaccine in India, which confer immunity 2 weeks after the administration. And vaccination should be done annually, each year between October and November, because winter is this one when we tend to see a lot of epidemics of influenza. And CDC clearly says that the quadrivalent vaccine need to be administered or could be preferred over other vaccines, or the trivalent vaccine and nasal vaccines. And even Indian data, ICMR clearly says that quadrivalent vaccine is preferred over in influenza. RSSDI clearly recommends, as in 19 recommendation, it clearly says that we should administer, all diabetics should receive influenza vaccine, and it is preferable to give quadrivalent influenza vaccine, which should be used in diabetics. Coming to pneumococcal infections. Pneumococci, we know that pneumococci can be asymptomatic colonizers in the nose. They tend to invade and cause invasive pneumococcal disease in the form of, they can cause otitis media, they can cause pneumonia, they can cause bacteremia, and they can contribute to meningitis. And we know about various, almost 90 serotypes which can colonize. And the lower respiratory tract infection is one thing which can contribute for significant mortality, especially in Southeast Asia. And WHO clearly says that Asia has the highest burden of pneumonia, and in India contributes maximum for it. And of them, meningitis and pneumonia contribute the most common cause of invasive pneumococcal disease. And when you look into the risk factors, what contributes for that, we can just look into that. Diabetics tend to have a threefold risk of developing pneumococcal infections compared to non-diabetics. So when you look into the vaccines for pneumococci, we have a big list of vaccines. We have pneumococcal conjugated vaccine, pneumococcal polysaccharide vaccine, and a lot of studies have clearly shown that both vaccines are good or quite effective in giving adequate protection against pneumococcal infections. We have the PPS, that is polysaccharide vaccine, which confers T-cell independent immune response, and the pneumococcal conjugate vaccine, which gives a T-cell dependent immune response. The 13 and 23 tells about the serotypes which are being covered in the vaccine. So what are the guidelines? So it clearly says that diabetic patients beyond 65 years give pneumococcal conjugated vaccine is the preferred first dose, followed by polysaccharide vaccine after the 1 year. If vaccinated earlier before 65 years, it's better to give pneumococcal conjugated vaccine initially and give polysaccharide vaccine after 1 year. If polysaccharide vaccine has been given, give the polysaccharide vaccine after 5 years gap. And once polysaccharide vaccine is given, it gives almost significant protection. And compared to polysaccharide vaccines, these conjugate vaccines tend to give some amount of herd immunity as well. The next infection which we often come across is hepatitis B. We know that 1 in 20 hepatitis B progresses to chronic infection and can lead to cirrhosis and death, or they can lead to hepatocellular carcinoma. We are really scared about retroviral disease, but the infectivity, when you just look into the hepatitis B, is much more than retroviral infections. And diabetes has shown to worsen the outcomes of chronic hepatitis B infection. At least 29 outbreaks of hepatitis B virus in long-term care facilities and hospitals have been reported by CDC. And this, unfortunately, is higher because in diabetics, they tend to do assisted blood glucose monitoring, which can increase the risk of infection. So a patient is admitted for the postgraduates. If you need to administer the vaccine or booster for hepatitis B, you look into the HbA1c titer. If HbA1c positive, there's no point in administering the vaccine. If he has anti-HbS titer is more than 10, then vaccination is not required. If he is anti-HbC positive, then give a single dose of vaccine. If the anti-HbS titer goes beyond 10, then there's no point no need to administer the vaccine. If patient is anti-HbC and anti-HbS both are negative, then he needs to get the full dose of vaccination. That is, he needs to get the full dose of 0, 1, and 6 months, 3 doses of hepatitis B vaccine. COVID-19 has clearly taught us about importance of adult immunization or adult vaccination. We know that the ACE receptor is the one site of entry, and COVID comes in the way of beta cell function, contributes to significant hyperglycemia. And we know that COVID worsens diabetes by beta cell damage, contributes to insulin resistance, and drugs which we use in COVID, like steroids, are contribute to worsening of diabetes. Similarly, diabetes worsens COVID coming in way of its immune functions. So diabetics need to take complete vaccination, and National COVID Policy, vaccination policy clearly mentions 10 Jan 2022. It says that including healthcare workers, people beyond 60 years with specified comorbidities should take the vaccine, or should take the booster dose of the vaccine. Other infections which need to be covered in adults, one is about herpes zoster. 2006 FDA clearly said that 1 dose of live attenuated herpes zoster, or Zostavax, to be administered at 60 years, and later it brought down even beyond 50 years it can be administered. And the subunit vaccines are available. Subunit vaccine need to be administered only in patients who have received transplants, because this is a live attenuated vaccine. So that's the reason the zoster vaccine, subunit vaccines are preferred only in transplant patients. DPT, we know that it's covered in the infant or the child immunization program, but still people who are traveling abroad or adults who are at risk need to take the Tdap vaccine, which offers almost 92% protection. And it is preferable to use the acellular vaccine, that is called as DTaP, instead of wholesale vaccine, because wholesale vaccines tend to have some neurological issues in adults. Coming to MMR, adolescents and adults, women of childbearing age who are not pregnant, 2 doses need to be administered at 4 weeks apart. Tends to give protection. Other vaccine which may be of importance is about chickenpox. We have 2 live attenuated vaccines available, Varilrix and Vocavax, to be administered at the interval of between 4 to 8 weeks. Once vaccinated, people tend to have antibodies for a period of almost 10 to 20 years. So they don't need subsequent vaccination. Hepatitis A, all this needed in people, diabetics who are with advancing age, who live in old age homes, etc. Or if there is significant exposure to the virus. Hepatitis A administered as an inactive single vaccine, available as Havrix, 2 doses of 1 ml at 6-month interval. Once vaccinated, gives protection for almost 15 years. This was an interesting paper from some CMC, which clearly showed that 50% of people prefer to take the vaccine. And it said that it is the physician's role to convey them the importance of vaccine, and vaccine need to be taken. And they said that if the doctor recommends, they definitely would buy it and take the vaccine. And we know that there are definite well-defined guidelines for vaccination for diabetics, the ADA, ACIP, and many have come up with vaccination guidelines. Even for diabetics, we have different vaccines which are available. This is the adult immunization guidelines, recent US guidelines from 2019. It clearly mentions about using of 1 polysaccharide vaccine, 1 influenza vaccine to be administered, preferably a quadrivalent vaccine annually, DTaP once in 10 years, MMR 1 dose, varicella 2 doses at least 4 weeks apart, zoster especially for 1 dose, especially for beyond 60 years, hepatitis B if not covered to give a complete dose of 016, HPV vaccine on sexually active adults at the younger age group. These are the recommendations which are given by the US at this one, and this has been confirmed by ADA and 2022, clearly saying that these vaccines are needed for adults for being immunized. About India, in diabetic vaccination status, all adults diabetic subjects should be educated about administering vaccines, especially pneumococcal and influenza vaccine, and those above the age of 60 years should be strongly advised to be vaccinated. 1. Children with diabetes should get pneumococcal polysaccharide vaccine, and children should also receive influenza vaccine. Other vaccines may be needed in diabetic subjects based on the need. Patients with renal failure at any age group should be immunized. Patients with diabetes and immunocompromised state due to concomitant medications or concomitant conditions can be immunized irrespective of their age. Patients with diabetes and chronic lung disease, like COPD, bronchial asthma, etc., should be immunized irrespective of the age. People of any age with diabetes who smoke may be immunized. What are the barriers? 1, about the resources, and how do we overcome the barrier? 1 is creating greater awareness among doctors and patients about vaccination. Most patients will be willing to take if the primary doctor emphasizes or advocates the need of vaccine. Data generated from India with regards to efficacy and safety can lead to policy changes which may make this free, at least pneumococcal and influenza vaccine in elderly. And most important thing is you need to document about the vaccination. This is the vaccination schedule for diabetics 2022. Adds up COVID also, part of in the booster, along with the other vaccines. So, in conclusion, so even adults need to be immunized. So adults also need to be vaccinated to get adequate protection. At least they should get 1 annual influenza vaccine, that is the quadrivalent vaccine, which will protect them against infection, influenza. One polysaccharide, pneumococcal polysaccharide vaccine, zoster vaccine if they are exposed to, and in the other vaccines may be needed if they are in according to the scenario where they. Thank you.
Thank you, sir. Yeah, it was a wonderful talk on adult immunization. Within a short period, you have covered most of the immunization. I have got one question. In my clinical practice, most of the patients will come and ask, they won't be having any comorbidities. Is it advisable to give pneumococcal vaccine to them?
Influenza vaccine is recommended to be administered. Quadrivalent influenza vaccine, especially in adults, it is recommended to be administered even though they don't have any comorbidities. Okay. So pneumococcal vaccine, it's what is more important is to educate the patients, make them aware of these are the vaccines that are available for adults and they give protection. If they are made aware of, definitely they tend to take the vaccine. So that is the concept behind. So you need to make them clearly aware of these are the vaccines which tend to protect you against these infections.
Because most of the patients, they will come and ask, sir, ಹೊಸ vaccine ಬಂದಿದೆ ನಮಗೂ ಕೊಡ್ಸಿ sir ಅಂತ they will come and ask. That's what
Yes, people are aware. After COVID-19, people are clearly aware about vaccination and the importance of immunization.
Thank you, sir. Any questions?
Same schedule we can apply for non-diabetic also. It is only for diabetics or others?
No, we can follow for non-diabetics also. Even adults for non-diabetics
0
also.
to 100 years.
Yeah?
Age of the...
After 60 years.
Below 60?
Below 60. Yes, most often the vaccines can be, the talk was mainly for diabetics. Adults with adult vaccination with specific emphasis on diabetics. So even non-diabetics can use the same vaccine because they tend to confer adequate protection against influenza. Yes. Thank you.
Any other comments, questions on the floor? Thank you, Dr. Ravi Kumar. It was a
Thank you.
lucid and clear talk on adult immunization, which was very clear to us. Thank you once more.
Thank you, Chairperson.
We can have a photo of the chairperson and the speaker. Thank you, doctor, for enlightening us on the importance of vaccination in adult type 2 diabetics. One housekeeping announcement. The car number 1942 is creating hindrance to some other vehicles. Would request if the person is available can hand over the key to this. Before going on to the next topic, let's break some of the suspense. I hope you're aware that there is a quiz going on in the WhatsApp groups everywhere. So, just sharing out the current leaderboard for the quiz. Following are the top 10 doctors as of now. Dr. Rekha Ji, Dr. Sandeep S, Dr. Muhammad Ishaq, Dr. Mohit Reddy K, Dr. Sheetal Kamath, Dr. Balaji P.A., Dr. Mary Priya Bagashi, Dr. Madhuri Vinod, Dr. Chaitanya R, Dr. Joshna Ganesh Teli. And the next 5 doctors are aiming for the top 10. Dr. Arvinda Kumar M, Dr. Karthik N, Dr. Manjunatha S, Dr. Nagaraj N, and Dr. Rama Mishra. All the best to everyone. Moving on to the next topic of the day. One of the topics which is again not very much discussed about, management of gestational diabetes. The chairperson for the topic would be Dr. Yogita, who is a physician, and Dr. Ravi Kumar, who is a physician. And the speaker for the topic would be Dr. Bhavna.
Which is the point? Or does it work here? I don't know. But it's okay, I suppose. Oh, sorry, I seem to have changed quite a few slides. Oh, this one. Shall we start off? All right. So, good morning, everyone. I would like to first of all thank the organizing committee of Krssdi, Dr. Suman, Dr. Manohar, for inviting me here, and thank you all for joining us on a Sunday morning. We're running a bit late, so I'm going to move fast ahead into the topic given to me today, which is management of diabetes in pregnancy. I know your program says GDM, but broadly it shouldn't really differ, except that if someone has type 1 or type 2, they'd be on insulin much before they get pregnant, that being the key difference here. So, which is why the slide says diabetes in pregnancy. So what are the things that we actually look at when we're trying to treat someone? We need to monitor how much of activity they're doing, their exercise, then their nutrition, what's getting into their body, and then of course medications is the third arm, and all of these three go hand in hand to ensure that your patient has normoglycemia. Now, what's the aim of all of this? Whether it's nutrition, diet, or medication. Oh, okay, you're confusing me now. No? Oh, that's okay. I think the wordings are big. So what's our aim here with all of this? We want to ensure that the patient has normal glucose levels, and we'll define what that is subsequently. And why is this important? Because it ensures that there's adequate weight gain in pregnancy for both the mother and the baby, right? We don't want the mother to gain too less or too much weight, nor do we want that for the baby. And then we want fetal well-being, of course. So remember that calorie restriction is also not healthy. It can cause not just IUGR, and that also results in fetal programming, risk of type 2 diabetes in the offspring much later. So what do we want? Now, guidelines say 1,800, to 2,000 calories a day, but that's probably actually a bit too much. So what I would say is go and actually see how much an individual is eating and what their baseline BMI is before they got pregnant. And that sort of helps you dictate or tell your patient how much to eat. The other thing to note is that a pregnant lady need not eat for two, and that is an absolute myth in our families. Most GDMs can just be prevented if they make sure they gain zero weight at 12 to 13 weeks, and then after that all they need is half kg every week. So they can stand in front of a weighing scale at home, half kg a week after 12 weeks, and the first 3 months absolutely no weight gain, or even if they lose a little weight, they're vomiting, that's actually okay. So what we want is trimester specific goals. So compared to what someone was eating earlier, they need just 200 calories extra in the first trimester. They need, again, 200 to 300 calories extra until the end of the second trimester. And in the third trimester, they need about 300 to 400 calories more. So you can tell the patient amounts of, let's say, a chapati or a dosa or a fruit, how much more they need to eat compared to what they were eating before. Next key to remember is not everyone who's pregnant needs to gain 12 kgs. That's actually for someone who has a normal BMI of 20 or 21 before they were pregnant. An underweight person needs to gain maybe about 15 kgs. Someone who's overweight or obese needs to actually gain maybe just 8 kgs or 9 kgs. So what they need to eat is actually a bit lesser. This is to ensure that the mother's weight gain is appropriate and the fetal weight gain is appropriate. So I'm not going to go into diet, but eating too much just causes macrosomia, and we want normoglycemia, so we want them to eat right. So we want them to eat complex carbohydrate, split their meals if they need to. If they're not hungry in between and they have good postprandial control, they need not split their meals. Increase the protein and increase the fat, avoid fasting, and try to ensure that you avoid hypoglycemia, especially overnight. Exercise is again important in management of diabetes, and this says 30 to 60 minutes, but someone who's fit could do 2 hours of exercise. There's really no upper limit to that, and it depends on the pre-pregnancy fitness. So yoga is okay, Aerobic exercises are okay. Resistance training, which I mean weights, squats, using dumbbells, doing lunges, all of this is absolutely okay. And people can go swimming if they do. And all they need to do is make sure they don't get injured. If they're doing something like yoga, avoid planks, anything that causes more stress on the abdominal muscles. So certain poses are avoided. They can do weight training, go to the gym, all of that is okay, but just reduce the weight a little bit. So if someone's lifting, say, 5 kgs earlier, maybe make that 3 kgs or 2.5 kgs if you are worried, but otherwise just reducing the weight by 25-30% is okay. Now, another part of management is actually monitoring. This is, of course, for type 2, type 1, we check the renal function. In addition, a lot of these patients are hypothyroid, so we want to check the TSH levels. Type 1, type 2, you want to check their eyes. Type 1, you want to check blood ketone levels when the sugars are crossing a certain level, or if they're having nausea, vomiting, not eating aptly. Monitoring of glucose, A1C guidelines say monthly. Practically, that may not be possible, but at least try to do it every 2 months or so you get some idea. But that doesn't really dictate our treatment. And what decides our treatment is the SMBG values 4 to 6 times every single day. We can also use CGM, but this is an additional tool which is going to help us. It does not replace SMBG, especially in a pregnant women, because you need it all the time to titrate the glucose levels. And especially in the hypo ranges, an SMBG is much more accurate than using a CGM device. Now, what do we want our targets to be? If you look at the guidelines, it's very clear. Pre-meal under 95. Post-meal, it depends on when you're checking. 1 hour post-meal under 140, 1.5 hours under 130, 2 hours under 120. But don't tell your patient all this, give them one time. So you could stick to 1 hour and say check 1 hour after your breakfast, after your lunch, after your dinner. So after all the 3 meals. So that's important, not just checking their fasting and after breakfast. That doesn't really hold good. And under 140, so that should be a good target to reach. But in clinical practice, we actually ask our patients to keep their fastings under 90 because you know our mentality. You give them a little bit of leeway, they'll insulin doses. So that way, you know, they're kind of more or less in the safe zone. A1C may not be very reliable, but it does give you an overall idea, and you want to try and keep it under 6. But if someone has type 1, brittle diabetes, lots of highs and lows, you want to at least prevent the lows so you don't have any rebound. So you're okay with an A1C under 7 for a type 1 patient who is pregnant. Using CGM, I don't really see any GDMs going on CGM, very rarely. It's more commonly used for pregnant type 1s and people with type 2 diabetes. You want to make sure if it's type 1, their time in range, the range is 63 to 140 here. So that is more than 70%. And above that is under 25% and lows are under 5%. But if someone's GDM or type 2, see, you see here, you want the time in range to be much, much higher, more than maybe even 90%. In GDMs, you need not really use a CGM, and SMBG would be good enough. If someone can afford it and wants to do that constant monitoring all the time, that would also be absolutely acceptable. So coming to the medications, we don't really have, a lot of options here to discuss. So we have insulin, diet and medical nutrition therapy, we already went through that. And with OHAs, we don't even use sulfonylureas anymore, they cross the placenta. Metformin does get used, but it does cross the placenta, and that is something we need to remember. Of course, type 1, type 2, they're going to be on insulin way before they're pregnant, and if they're type 2, all their OADs would have been stopped before they actually get pregnant as well. So when do you start? Now, this is specific to GDM. The treatment of choice is very clear. It's insulin. Now, when do you start insulin? Right when you see that the sugars are not at target. So let's say someone's been referred to you by an obstetrician and you see values. When do you decide that you're going to try medical nutrition therapy for your patient? Or when do you decide I'm going to start her on insulin today? So go based on their values. So usually when an obstetrician refers, the patient rarely comes to you the same day. They come to you after about a week after monitoring their values. So take a look at that. If you have fasting values in the borderline of around 95, to under 100, post meals about 135 to 140. Maybe you can put them on medical nutrition therapy. If you're seeing values of 170, 180, don't even waste that extra 2 weeks of time of trying medical nutrition therapy, because that's anyway going to be one important arm, but you're going to add in insulin right from day one at that point of time. So look at the values and then decide if the values are high enough for you to start insulin. Sooner is better. The other indication to start insulin is to look at complications. And what do you need to look at? You actually need to look at their pregnancy scans. What is the AFI? What is the fetal abdominal circumference? Is there evidence of macrosomia already setting in? Is there polyhydramnios? And your obstetrician's file is going to tell you that. So we need to look beyond the HbA1c report or the glucometer reading. So if there's already macrosomia setting in, you're not going to put a GDM patient who's diagnosed with GDM on diet and exercise. That's for you an indication to start insulin straight away. Which insulin, we'll come to that, and which regimen, we'll come to that. We don't use insulin pumps in GDMs. That's for type 1, type 2, but this was anyway a comprehensive set of slides. We don't need to hospitalize anyone to start insulin. We can usually teach them, and they start taking it at home. Now, whenever we think of medications and pregnancy, the two things we ask ourselves is, does the medicine work? And then is it teratogenic? So we want to make sure anything we use works and is absolutely safe. And there's really no doubt with respect to insulin that it is safe in pregnancy, and it does help to deliver better fetal and maternal outcomes. So look at the patient's SMBG profile and then decide what insulin you need to use. Now, a common understanding or thought that is propagated is that pregnant women have higher postprandial glucose. That may be so, but not for everyone. I see several pregnant women who have higher fasting glucose, may not have a higher postprandial glucose. Some may have both. So choosing which insulin to use, which regimen to use, purely solely depends on that patient's glucose profile. You want a fasting control, you're going to have to use something that controls the fasting sugar, which can be NPH detamers, and there's of course glargine also. You want mealtime control, so you have human insulin and analogs, which are bolus insulins given at mealtime. You need to control both, then you use a 30-70 or a 50-50 mixture of it. Someone who has a higher post-meal glucose, you might need to use a 50-50 combination. A 30-70 may not do the job. But the most important thing to remember is your starting dose is just a number on the prescription. It has no other value. Your starting dose today may be 8, and after a week it may be 30. And there is no value in that dose if your patient does not monitor the sugar and adjust the dose. So you have to teach the patient how to adjust insulin, what their targets are, and they need to adjust insulin every single day. Now, can all our patients do this adequately? No. Some educated patients can. So this becomes a responsibility of the care team in the clinic, a nurse or a dietitian or another doctor who's assisting you to follow up the pregnant patient every 2 days or every 3 days to get the SMBG values back. And this responsibility goes on until they actually deliver. So we can use glargine as well, though it's not FDA approved. It's been used for years and decades in tens of thousands of patients across the globe, and glargine is not teratogenic and is safe. So it can be used in pregnancy as well. We don't have that same kind of data with degludec, so we at this point do not use degludec, though there are minor case reports that have shown that it can be used in pregnancy, but we still haven't used it in clinical practice. Now, with respect to metformin, there are a lot of patients with type 2, sometimes GDM, who also take metformin. But remember, they very rarely come under control with just metformin. About half of them end up requiring insulin. But there are a few benefits of metformin. So less weight gain, less neonatal hypoglycemia, reduces the incidence of PIH, and reduces the incidence of large for gestational age infant. But on the other hand, what are the long-term consequences? Now, it's not teratogenic. Some benefits seen at the time of delivery, but what is seen is much later on when the same child grows up, is 2 years old, 4 years old, or 9 years old. This child is much larger, has a higher body weight, higher, different body circumferences, measurements, compared to children whose mothers were not on metformin in pregnancy. Now, is this truly the effect of metformin, or is it just that there was less growth initially and then an accelerated growth later in adolescence? I mean, not adolescence, but in childhood. We don't really know what happens to any of them after 9 years, but we know that at least there's no issue in terms of teratogenicity. If someone is taking it, it can be given. But if someone is okay not taking any OHAs and sticking to insulin, we at least know in the long run there's absolutely no issue with insulin at all. If you do use metformin in pregnant women, just make sure there's one indication to not use it, that is in someone who already has an IUGR baby, who has placental insufficiency, maybe hypertension, some other reason where the birth weight may actually be small. So don't use metformin in those individuals. So you follow these individuals up until the time of delivery, and in most cases, the diabetes goes away after they deliver. That's something we need to check. And we ask them to stop all their medications. Next comes the follow-up, which is an OGTT with 75 grams of glucose, 4 weeks postpartum, as early as 4 weeks postpartum. And if someone has prediabetes type 2, they are followed up in the long run to make sure that they can avoid it, preferably. I mean, if someone doesn't have type 2 and prediabetes, they are followed up. And even if someone doesn't have prediabetes, they are still educated about maintaining a healthy lifestyle. If someone does have diabetes, then they need to be treated subsequently as well. Again, when they're lactating, there's a lot of limit with what medications you can use, but subsequently post that, they could be back on oral medications. If someone has GDM, there's a risk of future GDM, so that's important to remember. We don't really know what's going to happen to these children over time, but we want to make sure that, especially if the child has macrosomia and so on, well, maybe we want to avoid that in the first place, but sometimes patients do get referred quite late. These kids need to be followed up as well. So it's a long process and a lot of responsibility to try and see that, the child that your patient gives birth to doesn't ever develop diabetes in their life. That's how I think, but maybe there are a lot of external factors just other than diabetes control in pregnancy. Who knows what food is given in schools today? So at least the most we can do is control hyperglycemia. So thank you so much.
Thank you very much, doctor. It was very nice presentations. So for any questions now? I have one question for you.
Yes, please.
Patient is on glargine. You want to continue with the glargine, or you want to go for change to determine?
I have never switched a patient from glargine to a different insulin when they were on glargine before pregnancy. And there are several patients with type 2 who are on a mealtime insulin with breakfast, lunch, and then a 30-70 or 50-50 with dinner. And we see often that using a premixed insulin is not helping because either the 30-70 or 50-50 is causing night hypos, and then you try to reduce the dose and then the fasting ends up being higher. So we end up putting them on basal bolus with glargine. So even mid-pregnancy, when 3 shots, they're not doing well, we start glargine in them. It's absolutely safe to use glargine in pregnancy. Never switched to pre-existing patients. We've even initiated new glargine newly in pregnancy.
Doctor?
Yes, ma'am.
A diabetic lady want an IVF to be done. Any special advice you have for them?
Okay, so I haven't covered preconception counseling, but that's a whole big topic itself with a lot of things to screen. We want to try and make sure their A1C is under 6.5 before they try any assisted reproduction. Their TSH is okay, their blood pressure is okay, and they're on sufficient amount of folic acid as well. And they're also eating healthy at that point of time, not taking anything that could be potentially teratogenic, no statins or anything else that they could previously be on.
Change them to only insulin?
So if they are planning assisted reproduction and they come and tell you, now this is my plan, on that point of time, all their OADs are stopped and they are on insulin. But then I still wait for another 6 weeks of good glycemic control before they start attempting to get pregnant either spontaneously or through treatment, because you want to make sure that they're taking insulin, they're adjusting the doses. And even before they get pregnant, that's the time to get them to the pregnancy target. And we often tell them we want your fasting at 90s, post-meal under 130, 140, compared to the previous ranges of fasting 130 and post-meal 180. So get them into that mode of, if it is this low, then you get your baby, otherwise we won't sign off. So it's easier for them to just follow that. And sometimes they don't follow and they still accidentally get pregnant and their A1C will be 7.5 and they'll say, we did this, now what do we do? So that's okay also.
Yeah. Anyone? If there are no questions, thank you, Dr. Bhavna. It was really wonderful.
Thank
you.
you.
Can just go in the center of the stage just for the... Ma'am.
First we'll take a photo.
Not for that. That was Makar. Okay. Just for the photos. Dr. Bhavna was a Young Researcher Award. That's what someone told, that he got a Young Researcher Award, and she's the daughter of Dr. S.R. Arvind sir, the patron of Krssdi. Thank you so much for Bhavna.
We will have to just prepone one of the session. The RSSDI presidential address will be first, later on followed by the next session. One request to everyone would be, let us respect the speaker and the chairperson. I think there's too much noise at the back when the speaker is talking. Thank you all.
And invite everyone to inside the hall.
I would request if everyone can be inside the hall, and who are inside can call your friends also inside.
Yeah, thank you. The session, as announced, this will be an oration by our national president, Dr. Brij Mohan Makkar. I invite Dr. Brij Mohan sir to please come on the dais, sir. Dr. Makkar sir, please come on the dais, sir. It is our honor that the national president has come to our event to give an address on the RSSDI. So we would like to felicitate him in the first place before we go ahead with it.
I would request Dr. Vijay Kumar K, our Honorary Secretary, and Dr. Ravi K to come on to as the chairperson.
Good morning, friends. My dear colleagues from RSSDA Karnataka Chapter Executive Committee, the newly elected Chair of Karnataka Chapter, Dr. Manohar, Dr. Arvinda, all the Executive Committee members of Karnataka RSSDA Chapter and the Scientific Committee of RSSDA Karnataka Chapter. And of course, my friends in the audience. It is indeed a great pleasure to be here this morning in this RSSDA Karnataka chapter meeting. And I think I am coming after quite some time to this meeting. And it is a great pleasure to see that we are getting back the attendance to the meetings and we are having very good sessions going on. So before I move on to my presentation, which I am going to speak on guidelines versus rationale in the management of type 2 diabetes. As the president of RSSDI, I have an important duty also to talk of the importance and welfare of RSSDI. First thing I would like to ask, how many people sitting in this audience are members of RSSDI? Please raise your hands. So we can see still a lot of people are not even members of RSSDI. And I think it is a very important job, very important responsibility going on to Dr. Manohar to take up this as a challenge and run a membership drive. The higher is the strength of RSSDI, the stronger will be the voice of RSSDI. Second thing is, now all those members who are sitting here, how many of you have visited the RSSDA website in last 1 month? So quite a few, that way it is good. How many of you know what are the social media handles of RSSDI? See, this is important. This is where we people are lagging, actually. This is our own organization. We have to make it stronger. We have to make our voice heard at all levels. There are certain things which I feel that we are lagging on is, one, recognition of RSSDI as the premier diabetes society at the level of public, lay people, or at the level of governments. Though we are doing a lot of work, we do a lot of work in academics, we are doing a lot of work for our professional colleagues, but that is not enough. If we have to make a difference, we have to make our voice heard at all levels. And especially we have to have awareness about diabetes and awareness about RSSDI as the premier diabetes society in India, and not only India, in Asia. Unless we do that, we will not be able to make that difference. So my earnest request to all of you sitting here is, those who are not members, please join RSSDI, become members. Those who are members, please always follow the RSSDI social media initiatives, the tweets, the various educative initiatives that we are doing, and try to spread them in your groups. The more we do that, more we will be visible. And it doesn't take much time. It doesn't take any money. It doesn't cost any big effort. It's a small thing. Everybody is using phone. All you need to do is spend 2 minutes on the RSSDA social media. And if we start doing that, I think we will have a phenomenal multiplier effect in making RSSDI visible to masses. So that was a short, request that I had to make. And with that, I know there is time constraint, so I'll start with my presentation, and I'm going to speak on management of diabetes guidelines versus rationale. No, financial disclosures for this presentation. So whenever we look at diabetes, we are always reminded of number of complications that we can have with diabetes. We know diabetes doubles the risk of heart disease, 3 to 4 times his risk of heart disease, increases the risk of mortality, increases the risk of macrovascular complications. And we forget that it is only poorly controlled diabetes that we talk about when we are talking of complications. It is not diabetes that causes complications, it is the poorly controlled diabetes that causes complications. If it is well-controlled diabetes, it is useful, it doesn't cause any problem, it is associated with long, normal life. Important thing is it has to be well-controlled. Now let us look at the guidelines that we have seen sea change in the guidelines over last 5-7 years. And now this is the last ADA ESD consensus which looked at treatment of diabetes. The recommendation is first line should be lifestyle interventions and metformin. And once you have seen that, look for presence of atherosclerotic cardiovascular disease, CKD, heart failure, risk factors, and so on. And if you have that, this is the algorithm for treating diabetes. And to the extent that ESC actually, suggested that first-line therapy should be SGLT2 inhibitors if you have people with the ASCVD or risk factors or CHF and so on. What we are not looking at is the majority of people with diabetes who are in this segment who have diabetes but no atherosclerotic cardiovascular disease, not many risk factors, they are just type 2 diabetes without any other thing, newly detected, recently diagnosed, not having much problem. So there is increasing number of younger newly diagnosed diabetes population, both men and women, which do not come under this category. But if you look at the data from various cardiovascular outcome trials, that data looks at people who are either at high risk of diabetes or already have had complications. So we talk of diabetes as if everybody is either having a heart disease or is about to die, but we do not look at the population which has actually just started with diabetes. The focus is only on cardiocentric or complication-centric management of diabetes. This is a meta-analysis of 27,000 patients who were looked for the development of cardiovascular events. And this study showed that if the duration of diabetes is less than 5 years, and if they do not have established atherosclerotic cardiovascular disease or macro or microvascular disease, they benefit in terms of having low risk of cardiovascular events. So if you have early diabetes in absence of complications, and if you are controlling well, the risk of complications is going to be very, very low. This is a UK database, health practice database study, which looked at people with diabetes who were treated, and within first year, they were defined as those who achieved A1C of less than 7% and those who achieved A1C of, who were not able to achieve A1C of less than 7%. And they were followed up for 5 years. People who did not achieve A1C of less than 7% had 67% higher risk of myocardial infarction, 50% higher risk of stroke, 64% higher risk of heart failure, and 62% higher risk of a composite of cardiovascular outcomes. Just achieving A1C less than 7% within 1 year changed the whole story. We know from earlier trials, DCCT, type 1 diabetes, new onset, early diabetes recruited in trials, significant reduction in microvascular, macrovascular complications with 1% A1C reduction. Not only that, people who were in intensive treatment arm, there was significant reduction in the cumulative evidence incidence of the first any event, even after 20 years of follow-up. Similarly, in UKPDS, we had with every A1C percentage point reduction, there was significant reduction in microvascular complications. Macrovascular myocardial infarction did not achieve statistical significance. 10 years down the line, people who had good glycemic control had sustained benefit, and even the macrovascular risk reduction became statistically significant. So what does it tell? Early achievement of good glycemic control is important early in the course of disease to prevent complications. And now we have 30 years data from DCCT, which is the EDIC DCCT follow trial, showed that in the intervention arm, after 30 years, there is 30% reduction in the risk of predefined cardiovascular outcomes, and there is 32% reduction in the incidence of any 3-point MACE. 30 years after achieving good glycemic control in intervention arm, you are having sustained benefits. So we have to achieve good glycemic control right from day one. This is like you have bought a new car. Do you get it serviced or you don't get it serviced? Do you maintain your car or you don't maintain your car? If you are getting it serviced properly, you are getting it checked on time, you are driving it properly, after 20 years, you still have a good, very nice car, though it may be, you know, old model, but vintage car. But if you don't maintain it, what will happen? You have a bad, damaged car, something like a person with diabetes who has already got atherosclerotic cardiovascular disease, heart failure, and so on. So you have to start working on day one. So problem with cardiocentric view is that if you have a 60 years old patient with established cardiovascular disease and 7-year duration of diabetes, it is very different from a patient with diabetes who has 10 years of diabetes and no cardiovascular risk. And we start acting only after developing of the cardiovascular disease. So something like you have already had a nuclear blast and then you are going for peace talks. What is the fun in having peace talks after having a nuclear explosion? So if you look at the various trials, CV outcome trials, most of the focus is in the clinical evidence, is atherosclerotic cardiovascular disease, or in the area when there are risk factors. And most of the trials are, enrolling this population. The enrollment should be here when the hyperglycemia has started. And we have examples, we have studies which have shown that you can have great benefit by intervening early. Now this is, I'm just shifting gear here and moving to the de Fronzo's concept of ominous octet. This was Banting originally. There are multiple pathways contributing to hyperglycemia. And to deal with hyperglycemia, we need multiple agents acting on different pathways. So we have to, if we are using metformin, we are reducing insulin resistance, we are controlling hepatic glucose output. If we are using GLP-1 or DPP-4 receptor inhibitors, then we are controlling, improving insulin secretion, reducing glucagon, reducing appetite. We are using sulfonylureas. We are just working on the beta cell, increase insulin secretion. SGLT2 inhibitors work on different pathways. So we have multiple agents now available which are working on different pathways contributing to hyperglycemia. Now, another important thing is we know all this. What happens is once somebody gets diabetic, there is a time to initiation of therapy. Sometimes patient is not interested in initiating therapy immediately because patients are asymptomatic. At times physicians are also, giving them time to go for lifestyle interventions, wait and watch, and things like that. But in India, the good thing is, once the diabetes has set in, 86% of people are initiated therapy within first year, while outside India, it may take up to 2 years. But what happens after that? The second initiation happens after a significant time. It may take up to 2 years of uncontrolled hyperglycemia before you intensify therapy. And this is a famous study from Dr. Kamlesh Kunti in UK, which looked at the clinical inertia. People who are on first oral agent and uncontrolled, if the A1C was 7%, it took almost 3 years to initiate, add-on therapy. If the A1C was in the range of 8%, it still took 1.6 to 1.9 years to intensify therapy. But what after second agent? To add third agent, it took almost 6 to 7 years. And people were having significant hyperglycemia. They were exposed to a significant glycemic burden. And that is where you are increasing the risk of complications. So if we go by guidelines, we have a treat to fail approach. You start with one treatment, you wait for A1C to rise again, wait for some time, and that induces clinical inertia. You initiate second agent, bring it down, and go on. What we need is ongoing intensification to keep the A1C less than 7% to prevent complications and to provide a good quality of life. When De Fronzo presented the ominous octet concept, ADA sponsored a clinical trial for De Fronzo to compare the sequential therapy versus the combination therapy. And this was called EDIC trial. And this is the initial data from EDIC. In ADIC, the Defronzo used sequence therapy based on ADA guideline and compared with combination of exenatide, pioglitazone, and metformin as initial therapy in type 2 diabetes patients. So significantly better durability of control at 2 years in people who were on combination therapy, significantly better chances of failure in combination therapy, and now we have 6 years data again showing that it provided much more durable control if you started with initial combination therapy. And you have data from verified trial. Verified trial was very interesting trial because it enrolled people with new detected diabetes. The duration of diabetes was only few months. They were treatment naive, all. They were not given any treatment, or they had received only metformin less than 4 weeks. And the average A1C was only 6.7% at the time of initiating therapy. They were randomized to metformin versus metformin vildagliptin on day 1 and followed up for 5 years. The chances of failure of therapy on monotherapy, metformin arm, there was need for addition of third agent, second or third agent at 36 months versus 62 months in the vildagliptin metformin arm. Combination therapy provided much more durable control. Now, it was just initiating with combination therapy that provided control and improved beta cell function. They looked at beta cell function, and the insulin sensitivity and beta cell function improved significantly in people who were given combination therapy. Not only that, the interesting finding was that this group, intensive therapy, had much lower cardiovascular outcomes also. Though this was not a CV outcome trial, but all the CV endpoints were adjudicated. And the intervention arm, there were only 30 events as compared to 44 events in the monotherapy arm. So 30% reduction in the macrovascular events in people with new detected diabetes who were treated intensively. This sounds very interesting because we do not have data on reduction in CV outcomes in new detected diabetes, except for these, UKPDS and DCCT kind of trials. So this again reinforces that we should start with intensive therapy. Now, this is another meta-analysis from people who were on metformin and vildagliptin combination, and they were analyzed for different subsets, showed that people who were less than 65 years versus more than 65 years. More than 65 years who had established risk factors did not have any benefit. People who were less than 65 years and did not have any risk factors, there was 37% reduction in the relative risk of MACE. Again, showing significant CV benefit in early intensive therapy. And based on that, actually, ADA-ASD recommendations, concluded that we should consider initiation of therapy with combination, which may provide a good glycemic control for longer duration. In RSSDI recommendations also, we have option of initiating combination therapy with 2 drugs if the A1C is more than 1.5%, or if you are going by patient-centric approach and you want to initiate with 2 drugs, you can initiate with 2 drugs. And again, in the new, ADA-ESD consensus statement that was released at the ESD meeting this year, again, they have reinforced their, they have endorsed again that we should start with initial combination therapy to have early glycemic control, and this is because of the data from verified trial. So with that, I come to conclusion of my presentation. To sum up, rational or evidence-based approach to diabetes management suggests that we should have early aggressive control of glycemia, initiate with combination therapy to achieve early good glycemic control and have a longer durable control. We should focus on prevention of complications rather than having complications and treating them later. We should look at normal, healthy life for people with diabetes rather than preventing events or reducing the risk of events after they have become high risk. Guidelines recommend sequential therapy and have been doing so for many decades now. But it is time to move away from that, move away from clinical inertia, which is maybe like guideline-induced inertia only, because we are following those guidelines. And it is time to move from the guideline inertia to early aggressive intervention and achieving good durable glycemic control early in the course of disease to prevent complications and prevent complications before they happen rather than treat them. Thank you.
Thank you, sir, for this wonderful elaboration on the guidelines and evidence. Yeah, guidelines deal with disease, but doctors deal with patients. So who is better? We need to think. Individualization is much important. With this, if there is any clarification taken, it's all fine.
Thank you. Thank you. Thank you, everyone.
Thank you, doctors. The biostatic session will be in Hall B. Thank you, Dr. Baswaraj, for accommodating.
ಬಯೋಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್ ಒಂದ್ಸಲ ಹೇಳ್ಬಿಡಿ ಹಾಲ್ ಬಿನಲ್ಲಿ ಬಯೋಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್ ಇದೆ ಸೊ ಪಿ ಜಿ ಸ್ಟೂಡೆಂಟ್ಸ್ ಇಂಟ್ರೆಸ್ಟಿಂಗ್ ಪ್ಲೀಸ್ ಗೋ ಅಂತ ಒಂದ್ಸಲ ಇನ್ನೊಂದ್ಸಲ ಹೇಳ್ಬಿಡಿ ಅಂದ್ರೆ ಅದನ್ನ ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿ ಇಲ್ಲಿ ಬಂದಿದ್ದಾರೆ ಸೊ ಒಂದ್ಸಲ ರೀಎಂಫಸೈಸ್ ಮಾಡಿಸ್ಬಿಡಿ.
Just re-emphasizing the fact that biostatics session is in Hall B, and whoever the postgraduates would be interested can attend the session accordingly. Moving on to the next topic, making sense in digital technologies in diabetes. I would like to call upon the chairpersons for this session, Dr. Swati K, who's a senior program manager at MFine, who's also a practicing physician, and Dr. Sanjay Reddy, no introduction needed, an endocrinologist in Bangalore. And the session will be, the speaker would be Dr. Baswaraj.
Good morning, everybody, and I thank KRSSDI for giving me this opportunity to chair the session on digital technologies. We heard yesterday Dr. Arvind talk. We've been seeing these change. I don't think anybody welcomes change, but that's what we are. And how many of us use apps today for everything? I think we're moving away to a digital culture. And we have Dr. Baswaraj is an endocrinologist, a good friend, and who works with digital technologies. And let's see how these digital technologies can impact care or improve lives of our patients with diabetes and other chronic disorders. Over to Dr. Baswaraj.
Thank you. Thank you, Sanjay sir, and thank you organizing committee members, team KRSSDI. You put a fantabulous job. I see a jam-packed hall. Yesterday I was missing all of this show, but nonetheless I'm here to talk something about the technologies. So, making sense of digital technologies in the world of diabetes. So, post-tea session, this whole sessions are basically what we call as there are Rahu Kala, this Kala, Shani Kala, Black Kala, and this whole session is B Kala. It was Dr. Bhavana followed by Dr. Bridge and then me. So yeah, just that was for waking up everyone. So digital health, how do you define it? Basically, this is defined as a broad, multidisciplinary concept that includes concept from an intersection between technology and healthcare. So digital transformation bringing to healthcare is what is called as digital health. This can include softwares, hardwares, and associated services, if any. So digital health can include mobile health apps, EHRs, EMRs, wearable devices, telehealth, telemedicine, personalized medicine. So what do we do? Why do we need all of these things? To have a responsive and a sustainable healthcare, prevention to be focused more than that of the treatment, to remodel the patient-doctor relationship, expanding the outreach of the healthcare professional. So various other aspects which we have spoken of, the telemedicine or telehealth decreases the potential exposure to contagious agents. This has boon for a lot of us during our COVID pandemic days. So now things are better, things are normal. So, but again, this I do continue to do some of these telehealth video consultations or virtual consultations for my patients, even now who are from far off flung places. Then again, we have been using more of EHRs or EMRs for better medical care and treatment. Mobile health or mHealth is the usage of mobile apps to track patients' their own health data and digital services. And then there are these virtual care or telecare models which we have discussed. So digital, the name seems to be of landing. Is it in India? Yes, very much in India. COVID has triggered a structural change to the whole of dynamics operating in India and has encouraged plenty of Indians to use healthcare technologies. Roughly 750 million people use, as of now, smartphones, and the number is going to go up to 1 billion within a couple of years. 47% of the people have internet penetration in India. 550 million have WhatsApp user base, and 245 million downloads of health apps is there. That's huge. That's pretty huge numbers. So just taking a jibe at my software friends who run the health tech companies. So let's not give out all our surgeries to them, or else they'll shut it down and then try to restart it. Chalo, going forward to digital health in India, the major trends in India. So 76% of the healthcare professionals are using digital health records, and quite a good number have easy access. They have positive record, and they have patients are also willing to use this digital health mode. And it is being projected, and also what Government of India is taken up in a big way. My father has got recently an Aadhaar number. It's like an Aadhaar for the health records. So even Government of India knows the power of digital health. So it is going forward and trying to get digital aspects into the healthcare. And most of the leading hospitals have their own apps, their own digital care models, their own digital presence, so that because they meet up the demands of the patients for complete and continuous care. So this is going to be the future of the diabetes care. Nonetheless, until we get an upgraded pancreas for all of us, we'll still manage with upgraded iPhones. Sure, we do not have upgraded pancreas, but yes, we do have some of these new smarter insulin pumps, which have got, and further on, other technological advances with your CGM, that I'll be dipping in very, very shortly. And we have got very interesting devices, non-invasive glucose biosensor, which works on the salivary models. Blood salivary models have been found to be very closely correlated with the salivary glucose models. And then we have got diabetes insulin guidance systems. We have got systems to check in your neuropathy risk. And then there is a C8 non-invasive optical glucose monitor system. So the future is quite promising. Digital technology is going to help us a lot in doing this, what we call as precision lifestyle intervention. Why do we need this? This is required to have a cost-effective, consumer-friendly, sustainable healthcare system to empower individuals to manage their own health. You see a round figure, the whole concept of 360-degree care being proposed by the KRSSDI for having a sustainable healthcare diabetes journey. We need this precision lifestyle intervention, which can actually be aided a lot by the digital health tech. So Paul Franks, a famous epidemiologist, always keeps telling, robust lifestyle interventions are more personalized and they are more effective than the today's standard of care. As Dr. Brij told in his presidential oration, lifestyle followed by metformin. But more often than not, we tend to forget this word lifestyle. moving on to the next aspect, I'll join all the missing links here. But yes, so one of the technological aspects which has been off lately being taken up by doctors like us is CGM. CGM is basically a tiny flexible electrode inserted just under the skin. There's a transmitter which attaches to the sensor, there's a receiver, and it records the blood sugars continuously, and then you get the mean average glucose while the patient with diabetes continues his daily activities. So this is the principle of the CGM. So the CGM checks the sugars not with the capillary blood, it is with the interstitial blood, and this works on the principle of equilibrium. Chemistry classes, we have learned about equilibrium. So when glucose is stable, there is an equilibrium which is created between the interstitial fluid spaces, similar to that of the blood glucose in the capillaries. So when the sugars go up and down, when the sugars have a very high slope, either they are very rapidly increasing and very rapidly declining, then it lacks the interstitial fluid space to have a normalization or to represent with that of the capillary blood sugar. It usually takes some time, which can be usually between 4 to 14 minutes. CGM recommended across the board from various international bodies. CGM ACE puts it as technology that is not only novel, but can improve the lives of patients who incorporate into a comprehensive diabetes management plan. This is again a diamond study done with patients with type 1. Average A1C reduction was 1% more, less time in hypos and hyperglycemias, overall better quality of life, plenty of studies, plenty of reviews, plenty of meta-analysis, but I put only one for simplification. So SMBG versus CGM, what is it like? So it's like this cartoon. SMBG or glucometer readings are your photos, which while you take a snapshot, whereas your CGMs are basically short videos which are run across 24 hours for the next coming 14 days until it is inserted. So then it comes with its own pros and cons. And then why is it required at all? CGM. HbA1c we know is insufficient to capture detecting the glycemic variability and overall risk associated with diabetes. Variable sugars can be more damaging, the risk of hypoglycemia, endothelial damage, and higher mortality because of the severe hypoglycemias. CGM can come to rescue here with helps and also checks and also tries to control the GV. Time in range, the retinopathy data is an indirect data which has come out of the DCCT trials, which tells that time in range is more than 70%, similar with that of nephropathy, similar with that of the peripheral neuropathy, and some soft pointer indicators towards the cardiovascular risk also. So there's an inverse correlation between TIR and HbA1c. Higher the TIR, lower will be the HbA1c to some certain extent. So benefits of TIR causes a 40% decline in the hypoglycemias, improves the quality of life, and improves glycemic control, 50% reduction in the nocturnal hypoglycemias, and overall decreases the length of stay even in ICUs. Coming to one of the very complex topics of CGM, which is called as CGM metrics, the CGM glycemic variability. Now what we are talking of the glycemic variability parameters, this is for the y-axis when it is charted. We have got standard deviation, coefficient of variation, mean absolute glucose, MARG, IQR, CONGA, MOD. Then we have got glycemic risk metrics, which is your LBGI, HBGI. And then we have M value, J value. And then we have got the TIR, which is a metric of the x-axis, which is there. So this is an ambulatory glucose profile of a normal patient, CGM data from an Abbott reader, I think. So, and then, yes, CGM can track your sugars, but difficult for some of the patients to read our handwritings there. Then this was one proof of concept study on the CGM, which was done through OneCare on lifestyle. Basically, it does a DSME programs, diabetes self-care and management education programs, which lasts for 12 weeks. What we did was we installed the CGM in a couple of our patients who enrolled in the program, impact program, for the first 14 days, and then repeated the CGM after 3 months to look for the changes in the variabilities of the glycemic variability parameter. So our program, or OneCare's program, impact program, had a qualified health coach, yoga and physical training sessions, emotional wellness coach, including a mobile app. Basically, 96 CGM points were derived for 24 hours from each patient. Totally 25 eligible patients were taken, and we could gather 44 evaluable CGM tracings of 22 subjects. And what we did see was that just lifestyle interventions changed the baseline standard deviation from a mean of 2.1 to 1.63, coefficient of variation 30.2 to 22.9. That's a drastic 10% decrease in the variation of the sugars, and then the mean absolute glucose also did decrease significantly. What about the classical parameters of HbA1c and weight? Definitely. There was almost more than 2 to 2.5% HbA1c reduction in all of these patients, and the change in weight was roughly around 2 to 3 kgs. Average mean weight change was around 2 to 3 kgs in these patients. So, but what's the problem with the CGM utilization in India? So, costs, additional time needed for the doctors or the healthcare providers to learn and interpret, and also patients probably sometimes can be the barriers for the usage. So, to solve all of this, probably there's something called as OneCare CGM MetaSense. MetaSense is basically a diagnostic tool plus a software and a service layer to the existing hardware of the sensors. CGM metrics, which are easy to understand, adapt it to clinical practices. It helps in getting in the precision care in a very practical way to get your index patient trends matched with the lifestyle logs, helps in the involvement of the patients with starting discussions, decision making, and has a simultaneous visibility to the doctor and the physician. Personalization occurs at each step. And then there's this health coach remote calls, which occurs during this MetaSense. And then this is truly the technology meant for the doctors. So this is what is the snapshots of these mobile apps which do occur, which is available on my mobile app who use this OneCare MetaSense. So you get these logs here. If you see the lower x-axis level at 9 a.m., he had a food log. There's a question mark. The patient has entered something, but he doesn't remember what he has entered. And then there are these food logs, insulin logs, and the medication logs which are there. So similar of the kinds there. So what's this OneCare? OneCare is basically a digital tech-enabled healthcare company accelerating the future of management of patients with chronic diseases. 3 main limbs as of now. It involves a digital DSME programs. DSME program, my dear friends, are again recommended by even the ADA standards of care as one of the measures to reduce A1C in people with diabetes. Digital supports to doctors enable the clinics to become super clinics by having a 360-degree, and then the CGM MetaSense, which we already spoke about. The OneCare DSME program, did we have some experience? Yes, research experience, patients love it. That's what this NPS speaks of 70%. HbA1c of less than 7% was achieved in a quite significant percentage of patients of 66 post-intervention without changing the medicine. In fact, there was a reduction in the medicine to the tune of almost 1/3 percentage. 33% of the patients had reduction in the medicines. They had a good reduction in the weight, with 70% of them either being on sulfonylurea or insulin. In spite of that, they had a reduction in the weight, and then there was a reduction in the medicines for almost 33 to 49% of the patient. Yes, so then again, some scientific footprints of OneCare. We have presented posters across the nation, across some international posters also, wherein we have been recognized by some international bodies with an abstract award also for the programs, which was again very gladly, I was lucky to present the same thing. And following all of this, we had so much of confidence among these programs that an RCT, a multi-centric RCT, is currently underway, looking at the standard of care versus OneCare's impact program across centers, which includes Narayana, Manipal hospitals, and Aster. Probably next year, KRSSDI, God-given chance, then probably I'll present it. So the magic, any sufficiently advanced technology is indistinguishable from magic, told by Arthur C. Clarke. So probably we at OneCare believe that the spell of the magic has just begun. Thank you.
Thank you.
Yeah.
Thank you, Dr. Basavaraj, for a comprehensive talk and your in-depth explanation of the experience that you've had. I have a question for you.
Yes.
With regards to the acceptance of this CGM by the patients per se, how easy it is to convince them to have, an object inserted with them?
Yeah.
How far is their acceptance with
Yeah.
this?
Probably the barriers are more with us rather than the patients. Some of us probably we must have not even seen CGM. We must have not even worn a CGM. To be very frank, I put a CGM myself just some 15 days back, wherein I had to experience how a CGM looks like, so that I tell to the patient how it feels and all of that. And I did it. I had been to Lisbon IDF, where I met Dr. Sanjay, and I was wearing the CGM all through the trip of the Europe. None of the airport could catch it because there's nothing metal in it, and none of them could stop me. Okay, there's nothing with that. That's the first thing. The pain is very minimal, as little as that of a prick, not even of a finger prick. The whole of that insertion mechanism very well automated. Even a health counselor can do it at your clinics, very easy. Okay, and probably we get a lot of insights seeing this CGM. Just for example, I had a colonel who refused, absolutely telling that HbA1c is 8, sugars are very good, he's been monitoring, perfect, fantastic, but he wants his HbA1c less than 7. You understand colonel's right? No, Dr. Saab, no, Dr. Saab. And then it went on, and then we put him on CGM. Then his early morning sugar spiked sometime in the morning at around 8 o'clock. We caught him, we checked with him. He was like, Doc, I have some 8 biscuits in the morning. Okay, and then that raises a discussion coming out of it, and then the patient understands, yes, there's the sugar spikes, and that is what is the reason for my high HbA1c. He brought it down. I'm waiting for his review HbA1c in 3 months. Probably a good discussion with the patients is usually going to convince them for the CGM.
Thank you, Vasaraj. Hope the magic begins.
Thank you.
Let's see, technology magic is going to happen. But my question is, yes, we use a lot of CGM. Apart from the cost, it gives a lot of information. We at least 1 or 2 of my patients every a week, at least 5 of CGM we do only for patients who don't reach targets, like how you said, in spite of being on repeated multiple doses of insulin, going into hypoglycemic unawareness, and so on. My question here is the One Care program. We have many such programs using digital technology for behavioral change and for weight loss, for managing A1C. First, and they are all expensive programs. Yes, somebody has to bear the cost of this. Now, my question is, how long does a patient continue on these programs? Is the effect after discontinuing from the program the same? The first part of the question is, what is the maximum duration a person continues, provided his pocket is friendly for the same? Second, is a short-term intervention on a program like this have an effect over a long period of time? So do you have any data on this?
Yes, absolutely. So very nice question. This we have been always pondering on, that how can it be sustainable and driven over a longer run. So usual One Care's behavioral program costs roughly around 1,000 rupees a month. A typical program runs for 6 months. A typical well-tailored program, which we call the Impact program, runs for 6 months. The program is structured in such a way so that we tend to inculcate much of the diabetes self-management education in the initial months, and over the last 6 weeks, 4 to 6 weeks, we leave the patient on his own. So in the last 6 weeks, it's like asking them to training them to drive a car. So the first few weeks, we ask them to drive and we train them, and then the last 6 weeks, we just leave the car to them. And then the Impact program goes on a low touch mode. That is number 1. Number 2, we are more than happy the patient doesn't come back to us. That means we are very happy telling that patient has learned how to drive. So if the patient tells, no doc, I want to join back, we have not done a decent job. So that is what we take pride on. Third, with several other programs, there are so many internal doctors who are playing the role. No, in this program, you are at the center. Doctor is always at the center. Treatment decisions will be taken by the doctor in coordination with the doctor with respect to that of the calorie restriction or any of those lifestyle intervention. Doctor is always involved in the care of the patient, and the patient need not see a XYZ doctor from XYZ company. The patient was yours, will be yours, and always we hope it stays with you for all of his life.
Thank you.
Dr. Basuraj,
Any questions from the audience? Yeah. Go ahead.
Dr. Basuraj, thanks for the wonderful talk. I have a question, two questions actually.
Yes.
The first question is, we had an excellent debate yesterday on CGM for the pre-diabetic to be used or not.
Yes.
What is your take on that? Second is like, what is your take on the CGM for the super elderly patients or senior citizens like who are above 70? Because generally we don't have a strict glycemic control to them. So what is your take on
Yeah, I'll go the other way around. So the super elderly or the elderly patients who come with us, so probably patients who are like they are exceeding their targets and we are not able to understand why they are exceeding their HbA1c limits, probably I would use CGM in them. Number two, someone who is having a recurrent midnight hypoglycemia where the person is not wanting to get up and check or is not able to catch up those things, someone who is having hypoglycemic unawareness. So those are certain high risk category patients where I would use CGM. But definitely current thing with respect to the cost and other things, we do not, apart from type 1, in type 2 patients, I usually do not use it probably not earlier than 3 months in any of my patients. If severe, if very bad control, then probably 2 months should be a good call. And now coming to pre-diabetes, yes, it's again a personal take. I would definitely not use it in someone with pre-diabetes, but if the patient insists and he wants a better lifestyle modifications just to understand how it goes, then probably a CGM would be a worthwhile.
I have something to add. If you have a patient with reactive hypoglycemia, there are a lot of patients who come to you and say, 2 hours after I take my meal and I have this, and they're willing to have a CGM to understand what they're eating and to modify this to prevent this reactive. 12 o'clock I get into the office, start sweating, and the A1C is a normal and this reactive hypoglycemia. That is the type of patient I want to use. Not regularly for everybody, but some people come after looking at the data, say, I want to use this to see what I'm eating and what this, that. Very rarely you get those into the clinic. But reactive hypoglycemia, yes.
In India, do you have the non-invasive tests like saliva and tears available now?
No, sir. I don't think they are just in the research.
I think the tear technology using contact lens is shelved. That's what I heard from Dr. Garg, who was the principal investigator with Janssen contact lenses, trying to estimate blood glucose and provide like a CGM. That is shelved for now. Saliva, I don't know, sir. Probably will come in.
What about the
GlucoWatch. Sir, there are so many companies which are going, but still not there.
There's some Hyderabad company which has come out with that.
So here also there are 3 companies, sir, I can tell, but they're still not standardized. I think we will end. Manohar is telling me,
Just one more last thing, just for the RSSDI faculty and the delegates. We have got our kiosk. Those who are interested, please register yourself and get 2 CGMs for you to use. We want you to use for free with added MetaSense program. Do visit our kiosk and get yourself 2 free CGMs and MetaSense plan. Thank you.
Thank you very much, Dr. Basuraj. It was an interesting presentation. Thank you.
We can have a group photo of the chairperson and the speakers. In a state like Karnataka, Namma Bengaluru, which is tech savvy. Thank you, doctor, for enlightening us on the technology in diabetes. For the next session, I would like to call upon Dr. R. Suman, Dr. K.N. Manohar, and Dr. Vijay Kumar.
If everybody are inside the room, can we please close the door there? I request everyone to maintain silence, please, because we are moving on to the next oration, which is Dr. C. Munichudappa's oration. Dr. C. Munichudappa has been credited to be the first person to introduce the super specialty concept of diabetes care in Karnataka state. So he is our Bhishma Pitamaha of diabetes care, holding medical qualifications from India, Canada, and USA. He worked on several research projects and published newer findings related to diabetes. He held several positions in many professional bodies such as the API, DIA, IMA, RSSDI, ADA, and Diabetes Club. So it is in his honor, Dr. C. Munichoda Oration has been established. So let us give a oration for the. So, in fact, we were honored to have him yesterday on our dais during the inaugural function. So for this prestigious oration, we have none other than our Dr. G.B. Sattur to give the oration on this name. Dr. G.B. Sattur, please could you be on the dais? Stand, I'll need to collect. Dr. G.B. Sattur, born in Dharwad in a highly respected family, completed primary and secondary education in Kannada medium schools. After completing PUC in Karnataka Science College in Dharwad, Dr. Sattur joined Karnataka Medical College. A journey of the medical career after getting first rank in PUC for the first time in the history of Karnataka University in biology section. So wonderful, sir. So he's completed his MBBS in KMC Hubli. Dr. Sattur, rank holder throughout the medical career. He regularly participated in extracurricular activities like the annual gatherings. After completing MD in general medicine, he proceeds to the UK in 1997, popularly known as the Walking Harrison in UK. He stayed for 6 years in UK and gained wide experience in diabetes and emergency medicine. He completed MRCP in 1981, returned to India in 1983, and started private practice as a consulting physician and diabetologist. He completes 36 years of medical practice, and he was honorary professor of medicine in SDM Dental College for last 7 years. Dr. G.B. Sattur, an astute clinician, acclaimed academician, and a gifted speaker and teacher par excellence. Dr. Sattur, known as vast clinical acumen, has delivered more than 200 lectures in CMEs and conferences, received Best Speaker Award during the 17th International Cardiovascular Conference in Kathmandu, Nepal in November 2019. His clinics in SDM was a great attraction to the students and drawn to his teachings like an ant to the sugar. Dr. G.B. Sattur, with a galore of honors, awards, and accolades, he was awarded the Fellow of Indian College of Cardiology in 1995, received the prestigious Dr. B.C. Roy Award in 2018, and the prestigious Suvarna Karnataka Rajyotsava Award in 2005. National Vikasa Sangam Award in December 2018, honored by Munawali Veerashaiva Samaj in 1990. Also, Akhila Karnataka Brahman Samaj Award for Excellence in Medical Services. He was awarded the Pratibha Puraskar by Gajanan Utsav Samiti and the IMA Sugar Doctors Award in 2002 and felicitated in 2002 by the IMA State Medical Conference in 2003. He also received the Lifetime Achievement Award by the Belgaum IMA, awarded Vaidya Shiromani Prashasti in ILKL during the Mega Free Medical Checkup Camp, many regional awards for various NGOs and organizations in his name. Dr. Sattur is Governing Council of the Karnataka Institute of Medical Sciences, Hubli, for the consecutive last 3 years, was Chairman, Association of Physicians of India, Karnataka State Chapter between 2018 to 19. Dr. G.B. Sattur, a social avatar and more. Dr. Sattur conducted 1 lakh people public diabetes awareness camps during the August 2012 and 2013, which is acclaimed as the first time event in Karnataka. A mega free BP checkup camp also conducted for BP awareness, conducted more than 150 free diabetes BP camps in North Karnataka. In December 2023, the Asha Diabetic Trust and Research Foundation adopting Baihatti village near Hubli for support study and prevalence, awareness and control of diabetes and hypertension for a period of last 5 years. Dr. Sattur is Academic Coordinator, Lipid Association, and was appointed member COVID Clinical Expert Committee by Government of Karnataka and contributed immensely. He's got more than 45 TV appearances and many social media and print media. He actively participated in forming Indian consensus for the lipid management. A free booklet on diabetes is given to more than 1 lakh diabetic patients. More than 300 lectures are delivered in various NGOs to promote good health and spread awareness about heart attack, diabetes, and high BP. So, Dr. Satur offers free consultation to defense personnel and their parents and children. Dr. Satur has been Chairman Capicon, Organizing Secretary CSI Hubli, Chairman IMA State Conference 2002, Joint Secretary API Conference, and Dr. Satur has national and international journals publications in his name. He also co-authored textbook Clinical Medicine in Dental Practice and introduced nebulizer treatment. Dr. Satur and his family, so really a doctor's family, married to Mrs. Kavita, blessed with 2 sons, Dr. Mithun, who is MCH neurosurgery, has settled in the USA, and Dr. Amit, who is MD-DM cardiology and is an interventional cardiologist in Hubli. So with this, I would like to felicitate Dr. G.B. Satur for his achievements in his career. Yeah. So for this, I invite the chairpersons, Dr. Basaraj M. Patil and Dr. Puttraju K.R. to please come on the dais to chair this oration.
Good afternoon, everybody. At the outset, I will thanks for organizing this Krssdi as a chairing person. And already, ಇವರು ನಾನು ಅನಿಸಿದ ಮಟ್ಟಿಗೆ ಸೆಕೆಂಡ್ ಭೀಷ್ಮ ಪಿತಾಮ ಅಂತ ಹೇಳ್ಬೋದು ನೆಕ್ಸ್ಟ್ ಎಲ್ಲ ಅವರು ಬಯೋಡೇಟಾ ಓದಿದ ಮ್ಯಾಗ ನೆಕ್ಸ್ಟ್ ಮೂವ್ ಆನ್ ಟು ಅವರ್ ನಾನ್ ಎಚ್ ಡಿ ಎಲ್ ಕೊಲೆಸ್ಟ್ರಾಲ್ ಆ್ಯಸ್ ಎ ಕೋ ಪ್ರೈಮರಿ ಟಾರ್ಗೆಟ್ ಇನ್ ASCVD. Over to Dr. G.B. Satur.
Thank you. At the outset, my deep thanks to Dr. Manohar, Dr. Vijay Kumar, Dr. Suman, my friends in front of me, ACP Governor Dr. Anujji, Madam Kamath, Dr. Ravi, many of my friends, Dr. Jagdish, Dr. Belgamkar. It's indeed a tremendous pleasure. After almost 3 years, we happen to see a crowd in front, which with a limited time, limited resources, with NMC regulations, applause to the RSSDI committee for excellent academic feast. Without delaying, I'd like to go. It's non-HDL cholesterol as a co-primary factor. This is around 10 years ago. The jury, the queen of jury or the goddess, was sitting on a fence, and now with a lot of water flowing under the bridge, the jury is out that the non-HDL cholesterol should be treated almost equal to an LDL cholesterol. Now, we all know that LDL cholesterol is something that always is known to be a primary target because we all know it's a causal for cardiovascular disease. Until some years ago, statins were the only drugs on this planet to undergo maximum number of clinical trials. And we now know, in fact, to this extent, when it was on the top of its career, the statins, now they are maintaining a plateau. When they are on the top of this is how the impact of lipids came into existence. And because it's a causal for LDL, and why it became causal, you could see that because of the observational study, the Mendelian randomization study, clinical studies, experimental studies. LDL cholesterol, we all know, is a primary target for combating cardiovascular disease. But we know that large-scale statin trials internationally did reduce the cardiovascular risk. ASCVD is atherosclerotic cardiovascular disease. There was a definite risk reduction. But even then, even though you put the patients on statin, look at that, staggering 55 to 70% of the patients did not reach the desired levels of LDL cholesterol. And that leads to the point that there are other atherogenic lipoproteins circulating in the blood apart from LDL. And they happen to be these triglyceride-rich lipoprotein remnants, VLDL, IDL, lipoprotein little a. These non-LDLs, so to say, have an importance in somebody who has elevated triglycerides. And we know that atherogenic dyslipidemia, which is common in diabetics in India, a lot of TG higher levels are seen in large number of our patients. So this is very important to remember these things. What is non-HDL cholesterol? Why has it become a hit marker? Because extremely easy. It doesn't need your prefrontal cortex. Your kindergarten child can do it. Non-HDL cholesterol is nothing but total cholesterol minus HDL cholesterol. And if you have just look at it, if you just see this chart, you can see that the plasma proteins on the top, if you see VLDL to LPA, all of them have ApoB. ApoB is a strong atherogenic molecule. All VLDL, IDL, LDL, they all contain one molecule of ApoB each, and hence they are atherogenic. If you just come to chylomicron remnant, that is ApoB48 derived from the gastrointestinal tract, and you can see that here, they are all triglyceride-rich lipoprotein. VLDL is very rich in triglyceride, so they all form the non-HDL cholesterol. Therefore, it is very easy. Non-HDL cholesterol is total cholesterol minus HDL cholesterol. We have now got remnant cholesterol. Lot of attention is being paid to VLDL remnants, cholesterol remnants in the last 5 years. And that is nothing but in this total cholesterol minus HDL cholesterol, you minus the LDL cholesterol. What is the evidence for non-HDL? If you just have a look at this slide, look at the leftmost corner. For a hazard ratio of LDL of 0.44, where the LDL has been reduced to less than 50, if you just see the red column, the non-HDL is at 0.57, indicating although you achieved LDL of 50, you still have residual risk. I think that's what needs to be realized. Apart from that, you have meta-analysis of around 62,000 statin-treated patients, 8 trials, 4S, AFCABS, lipid trial, CARDS, TNT, IDEAL, SPARKLE, Jupiter. And all of them showed one standard deviation between LDL, ApoB, and non-HDL. You can see that non-HDL was 16%, indicating that ASCVD risk was greater for non-HDL than for LDL or even ApoB, although ApoB is a significant component of non-HDL cholesterol. This is a normal lipidemic individual. You can see that LDL has a very large proportion of ApoB to be followed by the VLDL and the IDL. Lipoprotein little a, which is almost takes a malignant form in Indians, has a very little amount of ApoB, but it can create a havoc. So it also now this slide very vividly shows that why LDL is a primary target, because large amount of atherogenic ApoB is in LDL-C. Now, the fasting is not required. There was a time when Dr. Manohar could tell his patient from Tumkur to come next morning. He would make him stay in a hotel, paying around 5,000, and bring him to the lab around 7 o'clock in the morning. And I would ask a Gangavati patient to come and hang on in one of the hotels, and next morning come for a fasting. No more fasting lipid profiles. Take a random lipid profile as the patient walks into your clinic. This is meant mainly by the joint consensus of the European Atherosclerosis Society and the European Federation of the Clinical Chemistry and Laboratory Medicine. All this was spearheaded by none other than Dr. Nordesgaard. Dr. Nordesgaard probably is due for a Nobel Prize because of his work on VLDL remnants. I was very happy to be with him in one of our international conferences. And these points that I have made here are right from the horse's mouth. Non-fasting lipids can be used to assess the risk of ASCVD. Non-fasting has got total cholesterol, HDL, and they are similar to fasting. Now, LDL can be measured directly, does not depend on TG. Food intake, how much does it increase really? All HDL, LDL, and cholesterol are increased only by 5%. What about your triglycerides? They increase by 15%. That's one of the reasons why postprandial hypertriglyceridemia is gaining a lot of importance as an important risk marker or a risk factor, if you would like to use that word. So we saw non-HDL, what non-HDL cholesterol is, and unfortunately, although LDL is a major component of non-HDL-C, focusing on non-HDL-C maintains focus on LDL-C, which is the primary target, which means you need not go in for LDL cholesterol. You can straightway do non-HDL cholesterol. And you know that most of the Indians, why there are more myocardial infarctions in Indians who have a normal LDL cholesterol in your clinic when you test them, but these normal LDL cholesterol apparently have got a lot of small, dense LDL. The small, dense LDL is highly atherogenic compared to the buoyant, large LDL particles. But unfortunately, the LDL readings that you get in the lab does not tell about the LDL particle size. That's still in the experimental stage, but the time we try to decide LDL particle size, we can easily target patients who have a normal, apparently looking normal LDL, but they have very high small dense LDL. This is 2016 consensus when the Lipid Association of India started declaring that non-HDL cholesterol as a co-primary target. And this is in 2020 when we released the consensus for Indian dyslipidemia, because Indians are very different from the Western counterparts in our phenotype. And here, we almost consolidated the fact that non-HDL cholesterol is a co-primary target. Now, let us look at some of the evidences. Let us look at some of the meta-analysis. 14 statin trials, 7 fibrate trials, 6 niacin trials, 1 each of bile acid diet and ileal bypass showed that when you use statin as a monotherapy, there is a 1-to-1 relationship between percent non-HDL lowering and CHD reduction. What do I mean by that? Look at the left end here. You can see the Voskhop's trial come down here. Look at the 25% non-HDL-C reduction and look at 1-to-1 25% CHD reduction. So when you use statins, the CHD reduction is equal to the amount of the LDL, non-HDL reduction. Another program which said non-HDL is good is about the Lipid Research Clinic program, 4,000 odd patients for 19 years, and finally showed non-HDL was a strong predictor. EPIC Norfolk study, less than 200 milligrams of triglyceride. SHEP study, more than 400 milligrams of triglycerides, rely on non-HDL rather than LDL. You know that more than 400 milligrams of triglycerides, you cannot calculate LDL cholesterol. You need to do direct LDL cholesterol. Inter-heart study, one of the largest studies, 52 countries. What's wonderful about the study is 15,000 MI patients, but almost 15,000 non-cardiovascular MI patients. And what did it show? Apart from all points, ApoB bar, ApoA1, this ratio became an extremely effective modifiable risk factor for an MI. So since non-HDL cholesterol measures cholesterol component of all ApoBs that you saw, it correlates well with the circulating levels of ApoB, meaning you don't need to calculate ApoB unless you are interested in lipids and want to do some extra studies. Now, this is again a risk consortium. Almost around 5 lakh odd patients showed less than 2.6 of a non-HDL to more than 5.7. Everywhere you could see the risk reduction of coronary artery disease. And hence it is pertinent that all laboratories should report non-HDL cholesterol in addition to conventional reporting of LDL and TG. Please raise your hands. How many labs of yours report non-HDL cholesterol? Raise your hands. Okay, from today onwards, after this, you are going to set your lab to report non-HDL cholesterol. You are not going to calculate. Your kindergarten son is going to calculate. Give him total cholesterol, give him HDL cholesterol. He will minus it and give you non-HDL cholesterol, and that goes on your reporting. Now, of course, what about non-HDL versus LDL, ApoB versus non-HDL? The Women's Heart Study, Health Professional Follow-up Study, non-HDL was definitely a better predictor. Now, regarding diabetes, we know all this. Many diabetic, male, female patients have dyslipidemia, and the non-HDL was very much supported by these 4 studies: the Framingham Cohort Study, the Framingham Offspring Study, the Lipid Research Clinic Program Follow-up Study, and the Multiple Risk Factor Interventional Trial. Now, when you see the joint distribution, almost of around 19,381 patients, you could see that the almost identical LDL levels, say of around 148 in non-diabetics, were also corresponding with the diabetics, indicating the CV risk in diabetics increased with increase in non-HDL, but not with LDL cholesterol on multivariate analysis. This is a study from one of my senior colleagues, Dr. Narsingan from South India, presence of elevated non-HDL in patients with DM. They came out with the conclusion, despite getting good LDL cholesterol, 47 patients had CV events, which means they had a residual risk. So they recommended do the non-HDL cholesterol in all your patients. So calculated LDL cholesterol excludes the cholesterol triglyceride rich lipoprotein. Therefore, no calculating by the Friedewald's formula in your laboratory. Direct LDL is available, spend more money, charge a bit more. Not necessary to save the patient's money. They can spend it if they want to get better. So get a direct LDL done in your laboratory. Now, just to make you understand what are small dense LDL, if you look at this slide, you can see on the left side is no diabetes, on the right side is diabetes. Look at LDL particles, they are equal. LDL particles on the left, non-diabetic, are large, buoyant with 1 ApoB. On the left, you have many more LDL molecules, many more ApoBs. What does that mean? Suppose you have got a 2 kg stone on the left and 2 kg sand on the left. Look at the sand molecules are huge as against the stone, indicating the small dense LDL are plenty, which means more particles equal to more plaques equal to more instability is more rupture is more morbidity and mortality due to cardiovascular disease. We don't need to go all this. Now, there is a non-HDL cholesterol paradox. What is this paradox? This is one of the Chinese study. They always come with paradoxes. They were the one to start COVID-19 also, and they are the one to suffer now, which is biting them back. So they said, why respect non-HDL all the time? Come with the this concept of non-HDL paradox. What is this paradox? Look at the top red line. that is a non-HDL cholesterol of less than 2.2, and the lower green, the blue one, is more than 2.2. It showed that you would normally expect red should not be there because higher the non-HDL cholesterol, there should be good response. But these patients had more deaths. Now, what was the cause for this non-HDL paradox? A paradox associated with baseline non-HDL and a long-term all-cause mortality. And this is mainly because of the malnutrition. And how does malnutrition contribute to the non-HDL paradox is not really well known. Could be because there are albumin binding gets screwed up in the blood. That could be one of the reasons, but we really don't know. So finally, we have, this is the last slide, and clinicians treat patients and not the meta-analysis. If you just make the patient sit in front of you, he would know the numbers, but you have to tell him what is cholesterol. And so what should be for Indians then? We have more diabetes, we have more obesity, we have more metabolic syndrome, more high TG, atherogenic dyslipidemia, and hence non-HDL is almost an identical indicator or target. So according to LAI, non-HDL is a co-primary target as important as LDL for lipid lowering. In individuals, in all individuals, in your clinics or the hospitals, the non-HDL should be not higher than 30 milligrams. Suppose you bring LDL to 40, your non-HDL should be 70. So we don't need to go through all this. Intensifying lifestyle is extremely important if you want to bring down the non-HDL effectively. This is one of the extreme risk group on the right, which is recently introduced by LAI. You could make out that this is an extreme risk group there. Whatever, whether you are in the first one or the last one, the lifestyle is what is extremely important in non-HDL. Increase the lifestyle measures. The more the risk, for example, compared to low-risk ASCVD and extreme risk ASCVD, higher the risk, higher the lifestyle, better the results. This is extremely important point to realize. This is one of the journals. I somehow came to be in touch with this on my flight to Amsterdam almost 15 years ago. You can see that how ladies are then and how ladies are now, end of an hourglass era. Now, this is the hourglass deformity, which women are jealous of their own women colleagues who are hourglass. There is a story in Mahabharata. Draupadi was taking bath in the lake, and you know that she had a lot of colleagues with her, and she was an epitome of beauty. And all her female friends, when she was bathing, they expressed, "Wish I was a man." So this is how the beauty of femininity is being always respected, but over years, not just women, even men. Pregnant men are not uncommon. Postmenopausal pregnant women paradoxically are not uncommon. Therefore, you can see that in today's world, the 46% are rectangular females, but males are no better. That's why it is thin fat Indian. Now, diet is very important. You all know that. One has to go for Mediterranean diet. I had one patient, diabetic patient, a Brahmin patient. He was a priest, and he followed with me for about 10 years. And at the end of 10 years, always he used to ask me, "Sir, allow me to eat some sweets." HbA1c was always 7.2. And I said, "This guy is teasing me so much." I said, "Addilla, ನೀವು ಒಂದು ಚಮಚ ಸತ್ಯನಾರಾಯಣ ಪ್ರಸಾದ ತಿನ್ನಬಹುದು ಯಾವಾಗರೆ. You can eat 1 teaspoon of Satnarayana Prasada." This guy maintained HbA1c of 7 for many years, and one day he came after 3 months, 324 milligram of blood glucose. I said, "Idu ಏನ್ರಿ ಇದು ಎಂಥ ಚಂದ ಇದ್ರಿ ನೀವು, ಏನಿದು 374?" "ಇಲ್ರಿ ನೀವೇ ಹೇಳಿದ್ರಿ ನನಗೆ ಸತ್ಯನಾರಾಯಣ ಪ್ರಸಾದ ತಿನ್ನಾಕ." "ಹೌದ್ರಿ ನಾ 1 ಚಮಚ ತಿನ್ನಾಕ ಹೇಳೀನಿ." "ಇಲ್ರಿ ನಾನು ಗುಡಿ ಪೂಜಾರಿ, ದಿನ ಒಂದು 7-8 ಸತ್ಯನಾರಾಯಣ ಪೂಜೆ ಆಕ್ಕವು. ಸೊ ಒಂದು 7-8 ಚಮಚ ಅಂದ್ರೆ ನೀವೇ ವಿಚಾರ ಮಾಡ್ರಿ ಎಷ್ಟಾತ." So be very careful when you are advising diet to your patients, and always depend on exercise, as I said, at all times. Now you may ask me, yesterday we had a brainstorming session. Many of you attended the morning yoga session. Now, is there an alternative to exercise? I think many of us ask this question. Of course there is. The best alternative to exercise is hospitalization. So get ready to get hospitalized whenever you are not exercising. So summary, you could add ezetimibe, icosapent-ethyl to reduce non-HDL further. You know that the REDUCE-IT trial is in a bit of problem. This is the last slide. This is our Prime Minister, who we always think, whenever we post this glass, a very internationally well-known joke, the negative people think the upper half of the glass, the life is boring, it's negative, I'm not getting the girl I want, my children are not smart and brilliant. And those who think, oh, life is great, I have got 2 legs, I have got 2 eyes, I can walk, I'm kind, God is kind. So half empty, the negative attitude, half full, the positive attitude. But our Prime Minister said it is neither. Why did he say it is neither? He said when it is half full with water, the upper half is half full with the air. Therefore, it's never empty. There is half water, there is half air. That's what you should have an attitude while treating your patients with ASCVD. Have an attitude of positivity that you get them out, not if LDL, take it to non-HDL. Thank you very much.
Thank you, sir. You aptly addressed the unmet needs in lipid-lowering goals. You have shown other than LDL, there are many other atherogenic lipoprotein parameters carrying ApoB, that is non-HDL cholesterol. You have shown it is as strong a predictor or a more powerful predictor of future CHD risk. Hence the appropriateness of considering non-HDL cholesterol as a co-primary target in therapy. Thank you very much.
Thank you very much.
Well, just in continuation with where Sattur sir left, diet, exercise. So we have a wonderful lifestyle symposium which is going to start in Hall B. Some of the speakers may not like it, but I have to give the options of Hall A, Hall B. We have a good panel of nutritionists, physiatrists, and the physiotherapists who will enlighten us on practical aspect of lifestyle as a prescription. So rest who are interested in continuing, we have beautiful talks. My friend Vijay Rao is there, and of course Dr. Anuj Maheshwari, well-known speaker, is also there. So some of us who are interested can come and join the lifestyle symposium.
So, as you all know, we have 4 pillars of diabetes management. Remaining on to the medication part of the pillar diabetes management. Steroid tailoring for diabetics and autoimmune rheumatic disease. The chairperson for today is Dr. S. Nagaraj, who is a rheumatologist and practicing in Trust Rheumatology, Arthritis and CTD Clinic in Banchankri. And Dr. Adarsh KS, who is an endocrinologist in Manipal Hospital. The speaker for the topic would be Dr. Vijay Rao.
Good afternoon, everyone. I thank the guest Krssdi SSDI organizers, particularly Dr. Vijay Kumar and team, to having invited me here. It's an honor for me to introduce my colleague, my dear colleague, Dr. Vijay Rao. He is also academic coordinator of our Karnataka Rheumatology Association. He's a senior consultant rheumatologist practicing in West Bangalore, that is Basaveshwar Nagar. He was previously with Manipal Institutes. Now he is having his own center, which is flourishing very well. He's trained in UK and has multiple international publications to his credit. And I invite him to start his presentation as we are running late. Dr. Vijay Rao, please.
Thank you, Dr. Nagaraj. I wish I was in the other hall for the lifestyle session. But anyway, half of you are interested to listen to me. I'm not a diabetologist. I used to be about 8 years ago. I'm a hardcore rheumatologist, and I use steroids. So myself and Dr. Nagaraj use steroids. We were using steroids a bit more than before, but using less now. And I'm going to share a few tips of when you should not use steroids, or if you have to use steroids, how judiciously you can use, and what are the diseases where you cannot avoid using steroids, and what are the best times you could call me or any of the rheumatologists listed in Karnataka Rheumatology Association website early on, so that the diabetes complications are minimized in these patients. So I'll tell you a brief about steroids, steroids in rheumatology, and steroid strategy in various autoimmune diseases. So we know these three, the eminent clinician scientist, Kendall, Reitstein, and Hensch. They shared the Nobel Prize for steroid discovery in 1950. And they're called corticosteroids because they regulate glucose metabolism, and they synthesize in adrenal cortex and have a steroidal structure. So initially they got excited and treated rheumatoid. Patients got better, but by 20th day they saw horrible side effects with facial acne and hair and so on and so forth. So initially, if you see from 50s to 80s, before the methotrexate and other drugs came into being, steroids were all through the pyramid. So the treatment flow began from the top, that is the apex, with aspirin and glucocorticoids and DMARDs. Moving on, we use steroids initially only at the base of the triangle, inverted, and we remove steroids very quickly, within a month or month and a half in really bog standard inflammatory diseases, and add several other DMA RDS. And now with revolutionary targeted drugs, we hardly are dependent on steroids. We know that steroids can cause hyperglycemia. By the top part of the diagram, we see that it involves in amino acid breakdown, gluconeogenesis, and hence the fatty liver part, and also decrease glucose uptake or increase insulin resistance, and causes abdominal fat accumulation and lipolysis. By all this, the side effects, which is the bottom part of the diagram, we are aware of them. But steroids is important for inflammatory diseases because it's an endothelial stabilizer, and as shown here, and it basically prevents macrocyte monophage activation and apoptosis, and it also prevents dendritic cell antigen presentation with naive T cell activation and cytokine release. So even with several of our agents, we need steroids. As practicing rheumatologists, some of you in the crowd might be seeing autoimmune disease patients. So steroids we cannot get away with, even with as a first treatment we need to use for the symptoms to improve. But if you look at the pharmacodynamics, the steroids as rheumatologists we are comfortable using are the second row one, which is the intermediate acting. The reason being, the relative glucocorticoid effect is not very high if you compare to the long-acting ones, and it has got nearly 18 to 36 hours biological half-life. So it's fairly long-acting in that way, with potentially least affecting compared to long-acting dexamethasone or betamethasone, which has 20 to 30 relative glucocorticoid activity. But most of our rheumatology society, we are comfortable with this classification. Low dose is less than 7.5 milligram per day. Medium dose is up to 30. High dose is 30 to 100. And there are conditions which me and you are aware that we'll be needing with very high doses, especially with pulse therapies like 250 or 500 milligram per day pulses. So the options are either use oral, that is prednisone or prednisolone, methylprednisolone, deflazacort, dexamethasone or betamethasone. Less preferable to use dexa or beta. And prednisone is a prodrug which is converted to the active form prednisolone. And the dosages, equivalent dosages are 4 mg of methylprednisolone equivalent to 5 mg of prednisone or prednisolone or 6 mg of deflazacort. A single morning dose is usually preferred in order to least interfere the circadian rhythm and usually used as a bridge therapy until our disease-modifying drug therapy acts. The problem is all of our disease-modifying drug therapy like methotrexate, leflunomide, sulfasalazine takes 3 to 4 months to work. So initially, some bit of respite is needed for the patient. It's also used as an induction therapy for the control of symptoms like in a vasculitis case or a severe lupus nephritis case, or sometimes maintenance therapy like in a polymyalgia rheumatica, which I'll come to shortly. So parenteral administration, these days we are more comfortable with intramuscular than IV drugs. So intramuscular, either triamcinolone or methylprednisolone. IV methylprednisolone, IV hydrocortisone, you all are familiar with as physicians, which you have used very much again in the COVID era as well. But less preferable, causing more deleterious effect on the blood glucose. IV steroids, as rheumatologists, we use when we need a rapid onset of action as induction or when we suspect that oral absorption could be erratic and the patient could be non-compliant. It's also used for life-threatening conditions. And pulse therapy traditionally is anything about 250 mg to 500 or even 1000 mg, 1 gram. Somewhere between 1 to 5 days is used. So intralesional is used as well in intraarticular, intraocular, periorbital, intrabursal, epidural, and dermal as well. So if you look at the conditions where low dose traditionally is enough, you don't need to use high dose. Low dose, by my classification, or the one I listed, is up to 7.5, is our traditional inflammatory arthritis with mild flares or even long-term maintenance. The strategies you want to minimize the glycemic risk is, basically start thinking of a steroid-sparing agent early or immunomodulators early along with your steroids. Just don't use steroids alone. And optimize your steroid-sparing agents rather than depending on steroids more. A moderate dose up to 30 mg. If there's scleroderma lung disease, we need to use steroids at least for a month and a half or 2 months. In serositis lupus cases such as pleural or pericardial effusion or even ascites, you need to use up to 30 mg, that's 0.5 milligram per kilogram. And polymyalgia rheumatica, you don't need to use anything more than 15 mg in these cases. So the strategy in this second column, moderate dose, is you need to combine with a steroid-sparing agent at the upgo, at the upfront. And you early escalate the steroid-sparing agents or the disease-modifying agent so that your steroid dependence on the patient or diabetic patient comes down. And high dose use in lupus nephritis, renal vasculitis such as Wegener's, or pulmonary hemorrhages, or neurological vasculitides, primary CNS vasculitis, or even conditions like cardiac sarcoid, or large vessel vasculitis such as Takayasu or giant cell arteritis. So in these cases, you need to think of involving us early because biologics or targeted therapies have to be planned earlier if your patient has to be spared from devastating effects of hyperglycemia. In these patients, of course, intravenous and intramuscular is used. Intravenous, as I already said, we prefer in a rapid control of symptoms and intramuscular and rapid relief of symptoms. So intralesional is used by several other specialties for a localized effect so that without altering the diabetic complications. Even in these intralesional or intramuscular, your DMARD strategy should be quite robust. So this is a slide which tells us that induction therapy we use for polymyalgia rheumatica, giant cell arteritis, Takayasu, ANCA vasculitis, major organ SLE involvement such as nephritis or cerebritis or even pneumonitis, and with systemic infiltrative diseases such as IgG4 disease or granulomatous disease, or the latest what we have a new kid in the block is the Vexus syndrome. All these are steroid dependent high induction required. Whereas for maintenance, for polymyalgia rheumatica, giant cell Takayasu, ANCA, SLE and myositis, these patients in my experience, I'm sure Dr. Nagaraj would agree, that we probably would need steroids somewhere around 5 to 7.5 milligram per day, at least more than a year. And these are the ones which we think rely on disease-modifying drug therapy, either targeted biological or non-biological pretty early on. And rheumatoid therapy is now gone almost steroid-free and is used only during flares or bridging. So European and American guidance has shown or given specific guidance for rheumatoid, and this applies for diabetic as well in terms of steroids. The short term is what you have to be using, and different dosing and regimes have to be used. And always think of upfront combination with disease-modifying drug therapy rather than steroid alone. And in lupus, it is advocated that pulse therapies are preferable to oral to prevent the cumulative toxicity of steroids. And maintenance therapy restrict to less than 5 or 7.5 mg. Whereas the situation is different by these organizations for vasculitis and small vessel and large vessel, where higher doses of induction is required and longer maintenance is required, in which case you need to depend on biological drugs or disease-modifying drug therapy. Same thing applies with polymyalgia rheumatica or myositis as well. Our societies discourage using more than 30 mg of steroids in these cases. Try and minimize the steroid requirement so that the sugar levels are much maintained. And in the last one, the spondyloarthropathy, that's an steroid non-requiring conditions. You should not be using steroid in ankylosing spondylitis or psoriatics. There are better agents now to control these diseases. So if you look at individual diseases, rheumatoid, psoriatic, and ankylosing spondylitis are low steroid requiring diseases. That's effectively shown by our European guidance. You start with methotrexate. In diabetics, I probably use methotrexate leflunomide or methotrexate sulfasalazine upfront. And within a month, it says 3 months, within a month, if sugar levels are not maintained, I probably think of adding a JAK inhibitor, which is these days available as generics. Of course, after you do the respective routine screening for tuberculosis and viral serologies. So biologic drugs is something which you should think of if your steroid requirement is higher in rheumatoid, more than 10 milligram, even after 3 months. That's when you probably should involve rheumatologists at this stage. In psoriatic, these are domain-based diseases. If you see for IBD and uveitis, they're predominantly steroid-requiring conditions. So they also cause this seronegative arthritis, and now it is grouped for convenience sake under one category, whereas enthesitis, axial disease, dactylitis, psoriasis, nail disease, IBD and uveitis, all of these. Apart from IBD and uveitis, none of them require steroids. Peripheral arthritis requires intra-articular steroid rather than oral. So all of these, we have moved away from steroids, and you should be think of JAK inhibitors or sulfasalazine, methotrexate, leflunomide. If they don't work, then think of TNF or non-TNF inhibitors like IL-17 is something which has come up. Spondyloarthritis, which I said, mostly in peripheral, steroid has a role, especially for joint injections. But most of all, it's usually sulfasalazine or these days JAK inhibitors, failing which it's biological disease-modifying drug therapies. Moderate requiring doses are SLE and PMR. And this is the European guidance for non-renal lupus, which says that steroid is initially required, but the moment you cross to moderate and severe stages of lupus, such as serositis or cerebritis or any of these conditions, nephritis, then you should be thinking of aggressive immunosuppression such as calcineurin inhibitors or mycophenolate or cyclophosphamide or rituximab. So in polymyalgia, again, think of methotrexate or other disease-modifying drug therapy at an earlier onset rather than depending on steroids. And these patients require steroids for a longer time. High-dose ones have already touched upon, that is, large vessel, small vessel, and myositis. The ones in green actually basically shows that there are other agents we should be thinking like rituximab or cyclophosphamide right from day one with these patients rather than just depending on severe GPA or MPA with this. Same thing with giant cell arteritis causing iotitis in above 50 years, where you need other agents such as tocilizumab, which is now indicated, or even JAK inhibitors as well. So Takayasu, again, in a younger patient with any of these high steroid required condition, we probably use the steroid sparing agents early on. And myositis, of course, we use methotrexate, mycophenolate, tacrolimus as a steroid sparing agent early on. So summary is, use steroids if needed only. Some diseases like psoriatic and spondyloarthritis, you don't need to use. If you're using it, keep steroids dose minimum, less than 7.5, at least by month 1. And keep the minimum duration of steroids as possible. Plan and use steroid sparing agents early. Talk to us, where we'll be working as a team with you as diabetologist or physician and the patient for effective use of other non-steroiding drugs. Thanks.
Thank you, Dr. Vijay. Very lucid presentation on steroid use in rheumatology and comorbid condition is diabetes. Any questions from the audience? Please.
I have 2 questions. In rheumatoid arthritis, for flare-up, do you recommend steroids?
So flare-ups these days we manage with intramuscular only, sir. So normally we have moved away from oral steroids. If the intramuscular doses of triamcinolone or methylprednisolone, like depot preparations, depomedrol doesn't work, and there are no other options, then we go for oral steroid, that too at a lesser dosage, maybe around 5 mg max.
Intramuscular, what is the dose?
Triamcinolone, 120 mg we use in a 70 kg adult, which comes in a 40 mg vial, 3 vials loaded in a 5 ml syringe, given as a 1 intramuscular gluteal IM.
Okay. The other question is in giant cell arteritis, initially we give high dose of steroid and maintenance, what is the tapering this one? And for how long we have to give?
Yeah, so for giant cell arteritis, it's a very high steroid requiring condition. We know this, that once we start reducing steroid and the patient flares, it's not a normal rheumatoid. That's when we actually think whether this patient might be having any other iotitis or large vessel vasculitis. Normally, I would be happy if my patient reaches around 7.5 mg by 3 months. That's what I would be looking at. And that I would have started the patient on methotrexate or mycophenolate, methotrexate probably, at an earlier stage. If by 6 months my patient is requiring more than 20 mg of steroid, that's when I'll talk to them about tocilizumab or interleukin-6 blockers, which is available in subcutaneous form as well these days, just like adalimumab, which is given once in 2 weekly or once in weekly, depending on the weight of the patient. But if some steroid is something which is used for giant cell to treat flares, that's what I would say.
Thank you. The essence was to kind of reduce the use of high-dose steroids without involvement of rheumatologist. See, basically we look at the reluctance from patients. For example, this is a message I just received few days back. This is a good morning message in a WhatsApp. Dr. Basarava said about 500 million users use WhatsApp. And in the morning, if you receive a message like against painkillers, I mean, we deal with chronic pain management, each of us. If the patient is reluctant to use a NSAID for pain, and if a physician is over-enthusiastic to use a high-dose steroids, how do you manage that bridge? That's the essence of talk of Dr. Vijay Rao.
I wanted to know the decrement. Previously, it was recommended only 2.5 milligram once in 3 days. You have to give a decrement.
Yeah.
Can it be higher?
Yes, sir. We start. Yeah, for giant cell, I would probably, the textbook says 1 milligram per kilogram, but I would probably start at 40 mg, and 40 to 30, I would go 10 mg increment dose reduction. I would go in a 2 to 3 weekly fashion. Once I reach 20, I go in a 5 milligram decrement at probably a 10-day or 2-weekly fashion. And once I reach 10 mg, I probably go even slower, probably 2.5 mg reduction. And I go probably around monthly fashion. So it's towards the end, we go a bit more slower, is what I would say.
In any case, the requirement of more than 5 milligrams by the end of 3 months should be, we should think of adding additional agents, additional immunomodulators.
Definitely. I mean, that's why I said methotrexate I would start upfront in these patients so that it helps.
All these last questions. Yeah, please.
The books always say prednisolone, methylprednisolone, never deflocortil. What is this paradigm? I mean, why is this confusion? But you people use it a lot, I've seen. You, Dharman and everybody. Can you elaborate why the books say this and you don't, you people use it?
Right. I would answer this in two questions you said. Deflazacort is something India-specific molecule I've never seen in the West. And I would beg to differ, sir. As rheumatologists, we rely less on deflazacort. We don't use deflazacort much. It's a myth that deflazacort, people say that it causes less steroid side effects. That's a myth. When you're using higher doses of steroid, deflazacort doesn't work. If it is a rheumatoid, probably yes. Beyond rheumatoid, any of the polymyalgia rheumatica or giant cell or large vessel or small vessel vasculitis, it's a strict no to go for deflazacort because your requirement of deflazacort dosages will be fairly high. And at that stage, it's immaterial whether you go to prednisolone or deflazacort.
I completely agree with Dr. Vijay. It's just about practice. Predominantly, physicians and orthopedicians tend to use deflazacort. Rheumatoids very, very rarely we use, especially in, mainly in RA, mild RA. Beyond that, we use typically prednisolone and methylprednisolone. And that's what it's probably about marketing and how they place the molecule in the, the pharma companies, how they place it in their domain of practices. I think I'll just probably end this session. I thank Dr. Vijay Kumar and the team for having given us the opportunity. Any more questions we can discuss at lunch.
We can have a photo with. Thank you, doctor, for enlightening us on the autoimmune rheumatic disease in steroids. So we are coming almost to the end of the day. The last topic for the day is gaps in management of CVD in type 2 diabetes mellitus. Yes, it's almost to the end. So the chairperson for the topic would be Dr. Prem Payas, who's a consultant in internal medicine at Manipal Hospital, and Dr. Anil Kumar, who's a physician and diabetologist at Karnataka Institute of Endocrinology and Research. And the speaker for the topic would be Dr. Anuj Maheshwari.
Welcome, Dr. Maheshwari. Dr. Maheshwari is going to discuss with us a very key topic. We all know how important cardiovascular diseases and diabetes, and we have actually moved forward quite a lot from initially seeing the harmful effects or possible harmful effects of anti-diabetic drugs on cardiovascular disease to now a stage where we see cardiovascular, or at least diabetic drugs being used in cardiovascular disease, even in non-diabetics like GLB-1 agonists as well as SGLT2 inhibitors. But nevertheless, we have a way to go in the road ahead, and Professor Maheshwari is going to point out to us or indicate what still are the gaps in the management of CVD in diabetics. Please go ahead, sir.
Thank you. Thank you, Chairperson, for the kind introduction of the topic and kind introduction of myself. Thank you, Dr. Manohar, for organizing wonderful conference. Dr. Arvinda Jagdisha for giving me this opportunity to be here. And wonderful time management. We are only 20 minutes left behind of the schedule. So this is, I think, one of the most well-organized conference, I could say. So if we talk about the gaps in management of type 2 diabetes regarding the cardiovascular disease, you would agree with one thing. If these gaps would not be there, or if we could fill these gaps, probably diabetes would have lost all its charm. Diabetes would have lost all eagerness to speak about that, or search about that. Because our biggest worry 20 years before also was the cardiovascular disease, especially the macrovascular disease. And today also, after 20 years, when lot of things has been invented, lot has been done about the diabetes management, but still this is the giant question before us, how to fill the gaps for the management of the cardiovascular disease, for the management of the macrovascular disease. The biggest reason is this, what I understand, that macrovascular disease, it starts in the patients of type 2 diabetes much before the type 2 diabetes occurs. All this presentation is based on this article or this review, what I have written last year on occasion of World Diabetes Day, when a Journal of Diabetes Mellitus has taken its special issue on the World Diabetes Day. So while writing all these things, the ideas which came in my mind, I am probably keeping before you in the form of the slides. We all know about that cardiovascular disease is a leading cause of morbidity and mortality in diabetes patients, because the risk of CAD is threefold higher in type 2 diabetes patient. Up to 80% of the mortality in type 2 diabetes patient is because of the cardiovascular disease. And mortality due to cardiovascular disease have been found to be 7.5 times higher among persons with type 2 diabetes without prior MI when compared to persons without type 2 diabetes and without previous MI. So it is given a status of the cardiovascular risk equivalent, because 10 years risk of the coronary heart disease in diabetic subjects was found to be more than 20%. May it be type 1 diabetes or type 2 diabetes, no previous MI, if is there, having a similar risk of an acute coronary event as non-diabetic subject with established coronary artery disease or established patients of the previous MI. We could know that intensive glycemic control and cardiovascular risk reduction may be associated together when intensive glucose control treatment substantially decreases the microvascular complication but not the macrovascular complication. We could not find any strong evidence that intensive glycemic control can reduce the macrovascular events. But in the post-trial monitoring of the UKPDS, very interesting things came out, that although we do not find any hardcore evidence which can prove that tight glycemic control can reduce the macrovascular complications, but if we treat the intensive glucose control in the early part of the disease or in early days of the disease, it significantly reduces the risk of MI and mortality from any cause because of a legacy effect, which was also given a name of the metabolic memory. Intensive diabetes therapy, even in type 1 diabetes, have been found to be conferring long-term beneficial effects on the risk of cardiovascular defect. The statin have been found to be a very good tool for reducing the cardiovascular disease. So we can say that cardiovascular disease is not only a thing which is to be handled by good glycemic management, but lipid lowering also play a pivotal role in primary prevention of CVD in type 2 diabetes. In patients with a stable coronary heart disease, intensive statin therapy decreases LDL cholesterol concentration below 100 milligram per deciliter and confers substantial clinical benefit. Antihypertensive therapy is again another pillar for the avoidance of the cardiovascular events in type 2 diabetes patient if we can really control blood pressure tightly in patients with hypertension, those who are having diabetes. It confers a clinically important reduction in the risk of diabetes-related morbidity and mortality. Antihypertensive therapy significantly lowered the risk of major CV outcomes by 25 to 30% in a wide spectrum of the high-risk, middle-aged, and elderly people with diabetes mellitus. But what was there? When we were knowing that diabetes is one of the biggest killer or one of the biggest root cause for the cardiovascular disease, and drugs which were being used largely 20 years before for the treatment of diabetes, they were actually found to be having some killer instinct. Sulfonylureas, conventional sulfonylureas which we were using for a long time, they could be detected with pathways of the cardiovascular risk through binding to ATP-sensitive potassium channels. And this binding actually found to be blocking relaxation of the vascular smooth muscle cells that improves the coronary blood flow. Because of this binding, there has been a limitation of the myocardial damage during ischemia is lost. So myocardial damage was open to spread without any limitation. At the same time, we could see the protection of energy generating mitochondria and cardiomyocyte could be lost because of this ATP sensitive potassium channel binding with the sulfonylurea. And at the same time, they enhance the production of the proinsulin and thus inhibit endogenous fibrinolytic system. So long-term inhibition of the potassium channel with less selective older generation sulfonylurea could be linked to excess cardiovascular mortality in diabetes patients. Sulfonylurea monotherapy or combination therapy, whatever way you are using, was associated with significantly higher CV and all-cause mortality risk. At the other end, in last 20 years, what has been designated as a killer, after making it designated as a killer, after making it out of the market, we could get an evidence that actually it is not killer, it is a savior. Thiazolidinedione. We were told, and it has been proven, that potential pathways of the cardiovascular risk in thiazolidinediones were there through the multiple mechanisms, like increased sympathetic nervous system activity. It was found to be intestinal iron transport alteration. It was found to be endothelial permeability alteration. It was also found to be PPR-mediated expression of the vascular permeability, and ultimately ending with the retention of the water in the form of the peripheral edema. It put up the increased stress on the left ventricular wall and increased myocardial oxygen demand. All these things made the persons more flexible to get the myocardial ischemia. And because of what a time has come in 2009 and 2010, then this particular molecule, especially one member of this family, rosiglitazone, has been kept out of the market. But what happened in due course of the time later? In 2017, a meta-analysis of randomized controlled trials has been published, which has shown the secondary prevention of cardiovascular disease could be facilitated by the pioglitazone. In this meta-analysis, pioglitazone have been found to be lowering the risk of recurrent major adverse cardiovascular events, stroke, MI, in patients with clinical manifestation of the vascular disease. And that too, independent of the glycemic control. Pioglitazone have been found to be providing all these benefits not through the glycemic control, but independent of the glycemic control. That was the biggest achievement of this molecule. Over an 18-month treatment period, pioglitazone slowed the progression of the carotid intima media thickness in atherosclerosis patient compared with glimepiride in 462 adults with type 2 diabetes. So pioglitazone after ischemic stroke and transient ischemic stroke in IRIS study again have been found to be more protective for the cardiovascular events, may it be the MI, may it be the stroke. It has been found even in pre-diabetes patient pioglitazone, where has been used, the patient, those who got the ischemic stroke, they did not get the another ischemic stroke, or they did not get the recurrent of the ischemic stroke. On the other hand, we could also find something cardiovascular risk associated with insulin therapy also, which was the most preferred and most effective therapy for the diabetes management. Nothing could be found the most effective and and faster than this particular therapy. Multiple actions have been attributed for this cardiovascular risk, which includes the increased cell proliferation, endothelin 1 receptor. A lot of you can read on this screen. And they all were taking towards the smooth muscle cell proliferation, monocyte addition, vasoconstriction, extended QT interval, fluid retention, prothrombotic activity, and it has been proven that potential negative effects of the insulin with regards to cardiovascular risk. So even insulin was not found to be safe in cardiovascular risk. Hypoglycemia, we were already knowing that this is the major factor which can initiate the cardiovascular event. Multiple mechanisms are there. You all know about those mechanisms, and you can see on the screen also. Not going into the details, hypoglycemia induces the several indirect changes that have potential adverse effects on cardiovascular morbidity and mortality. Similarly, through the hypoglycemia, actually we could know that intensive glucose lowering have been not beneficial for the cardiovascular event. ACCORD trial have been stopped, and it has also been seen that no benefits could be achieved with the intensive glucose lowering regarding the cardiovascular benefit. Intensive glucose lowering was associated with significantly higher incidence of severe hypoglycemia and did not confer a significant cardiovascular benefit. The one more factor has been discovered in last 10 or 15 years, and that was the glycemic variability, which has been attributed to the cardiovascular risk. We have seen a number of patients are coming to the ICU who could keep their HbA1c well controlled for last many years. They were keeping their lipid profile well controlled for last many years. They were saying, doctor, I kept my fasting and PP both well controlled, still I am in the ICU with a heart attack. What happened with me? What was the reason? Even doctors were also very much amazed what is going to happen, and this was actually the glycemic variability which was playing an important role in causing cardiovascular adverse outcomes. So medications that target postprandial hyperglycemia not only attenuate the glycemic excursion but also reduce oxidative stress. This could be established by reducing the glycemic variability. In fact, the glycemic variability could only be reduced if we can reduce the postprandial excursion. Many a times we see the people keep on eating throughout the day and they always remain in the postprandial excursion. Probably that becomes one of the important reasons of getting cardiovascular adverse outcome. So potential, and even this reduction in the glycemic variability was having the potential to improve endothelial dysfunction. And even with the glimepiride, we could achieve lesser glycemic variability if we could stop the post-meal excursion. Insulin pump has also been found to be a very effective tool in minimizing the glycemic variability. Bariatric surgery has also been found to be playing a very effective role in minimizing the glycemic variability. Later on, the gliptins has also proven its worth in reducing the glycemic variability. May it be any gliptin, vildagliptin, sitagliptin, and although the GLP-1 receptor agonists have been found to dual role, they also reduce the glycemic variability. At the same time, they also reduce the atherosclerotic cardiovascular disease risk also. So cardiovascular risk reduction have been found to be clubbed with less number of the excursion. MAGE is the glycemic excursions or mean amplitude of the glycemic excursion reduction is associated with reduction of the oxidative stress and markers of the systemic inflammation in type 2 diabetes patient, and which was the key to stop cardiovascular adverse outcomes. In TOSCA trial, we could find that long-term cardiovascular safety could be assured even with the sulfonylurea. So sulfonylurea were not actually the criminal, not actually the villain in the management of the cardiovascular disease, in management of the macrovascular, in the prevention of the macrovascular complication. We could see that incidence of the cardiovascular events was similar in patients treated with sulfonylureas, mostly glimepiride and gliclazide, and those treated with pioglitazone as an add-on treatment to the metformin. Carolina trial reassured on the CV safety of the modern sulfonylurea. There was no significant difference in occurrence of 3P MACE in patients treated with glimepiride as compared to those treated with linagliptin. Recommendations has already been there by multiple organizations, almost all important organizations, may it be ADA, may it be RSSDI, may it be ESD, may it be IDF, that if your patient is carrying the high cardiovascular risk, then GLP-1 receptor agonist could be a better choice. Liraglutide, semaglutide, and dulaglutide have been found to be the best possible recommendations for the patient, those who are carrying high risk of the cardiovascular disease, high risk of the stroke, on the basis of these three trials: LEADER, SUSTAIN 6, REWIND. And all these three trials has shown the reduction in the 3-point MACE, CV death, non-fatal MI, and non-fatal stroke by using them in patients with high cardiovascular risk. Now come on to the most innovative and most new or most recent, you can say that, gliflozin or SGLT2 inhibitors. It was the EMPA-REG outcome which shows that SGLT2 inhibitors confers early and sustained risk reduction for cardiovascular death in patients with type 2 diabetes and atherosclerotic cardiovascular disease. And this risk reduction was much higher in Asian patients, what you can see it here. Overall study population showed 38% risk reduction, but Indian or Asian patient had shown a 56% risk reduction. The same trial has also given us an insight that this risk reduction was not only on severe side of the heart failure or in particular specific range of ejection fraction. Actually, it consistently lowered the risk of CV death and heart failure, hospitalization in patients across the spectrum of the heart failure, may it be the reduced ejection fraction or it is the preserved ejection fraction. SGLT2 inhibitors has conferred the significant and meaningful cardiovascular benefit in patients across the CV risk continuum. So now, coming to the end of this presentation, how did our understanding of the cardiovascular outcome has evolved over the years? Earlier, we were thinking that insulin resistance is the core defect in metabolic syndrome, pre-diabetes and type 2 diabetes, which is actually responsible for all evils of the cardiovascular adverse outcome. Insulin resistance has been attributed to initiate the endothelial dysfunctions before onset of the type 2 diabetes. We say that 15 years before occurrence of the type 2 diabetes, endothelial dysfunction starts taking place in an individual. Its role in pathogenesis of the atherosclerosis is relatively well documented. Therefore, interventions which improve insulin sensitivity could reduce the cardiovascular events. This was the one idea or one thought of the coin. But on the other side, we could know that improvement in CV outcome in type 2 diabetes cannot be entirely attributed to the lowering IR, since we could see the decline in cardiovascular outcomes also noted in extension of the diabetes control complication trial, which we know as EDIC trial, which was done in type 1 diabetes, and which was attributed to aggressive glycemic control, and metabolic memory effect has played a bigger role in type 1 diabetes here. So most of the CV outcome trials, except the IRIS, did not determine insulin resistance or its surrogate markers. It is plausible that improvements in CV outcomes in clinical trials using GLP-1 receptor agonists, SGLT2 inhibitors, and pioglitazone may have been mediated via increase in insulin sensitivity. Intensive lowering of glucose can help if it is being done in early days of the diabetes, that already I have told to you and it has been well discussed. Landmark clinical trials have demonstrated that reduction of hyperglycemia, low density lipoprotein cholesterol or LDL cholesterol levels, and hypertension confer significant cardioprotective benefits in patients of diabetes. So It has been known that not only the glycemic correction is enough, until unless you are not taking care of the good blood pressure, you are not taking care of the good cholesterol lowering. Complications and metabolic abnormalities are consequences of the multicellular dysfunction secondary to lack of entry of glucose, the most efficient fuel caused by insulin resistance and insulin lack respectively in type 2 and type 1. Treatment with dapagliflozin or any SGLT2 inhibitor, you can say, for as little as 2 weeks modestly increase insulin-mediated glucose disposal secondary to the reversal of glucose toxicity. So ultimately, we could reach to the increased blood ketone levels, reduced levels of the uric acid, and increased angiotensin and angiotensin type 2 receptor activity are also suggested to be responsible for beneficial CV effects in MPAREG outcome. However, the main contributor to the improvement in heart failure is likely to be diuretic activity of glycosuria. So this is another method of filling the gap we could be invented. Another very interesting beneficial cardiovascular effects of the SGLT2 inhibitors are hemodynamically mediated. And those of the GLP-1 receptor agonists and pioglitazone are direct action on the vasculature to reduce the atherogenesis. It is plausible that combination therapy with SGLT2 inhibitor with pioglitazone and or GLP-1 receptor agonist may exert an additive or even more synergistic cardiovascular benefit, which could be useful to fill the gap of the cardiovascular disease and type 2 diabetes. Thank you very much for your kind listening.
Thank you. Thank you, Dr. Is this on, please? Thank you, Dr. Maheshwari, for a very excellent review of cardiovascular disease and diabetes. Keeping in mind the whole target of the talk, do you think we are on the right track to cover all the aspects of cardiovascular disease and diabetes? We know the ADA has just come out with a new guideline saying further tightening blood pressure and lipid level. Or do you feel that there are still some gaps, some aspects of cardiovascular disease in diabetes that we have not yet been able to address? Or is it that everything is addressed, but except that we have to really push the present therapies?
Yes, sir. 20 years before, we were not talking about the heart failure. Nowadays, we talk about the heart failure. We have a tool to stop the heart failure. Nowadays, we say that a naive diabetic patient, type 2 diabetic patient, when comes first time to a doctor, he has already the diastolic failure before coming to the doctor. A certain level of the diastolic failure already exists there. That's why we see that SGLT2 inhibitor should be there to initiator. And that's why the ADA ESD has also given a liberty to the clinicians whom you are finding the cardiovascular prone or cardiovascular problem is more predominant, you can start your therapy with the SGLT2 inhibitors and or a GLP-1 receptor agonist. Affordability is biggest barrier while we talk about the GLP-1 receptor agonist. But GLP-1 receptor agonist is very good to attack on the vasculature. As far as the cardiovascular risk are concerned, macrovascular complications are concerned. They are having multiple things, but we works only what we know about that. And we knows only what we are getting the evidences of what. Maybe in future we could get some another evidence which may open our eyes, oh, this is also a factor, this can also be one of the important factors. As we could earlier understanding that insulin resistance could be the only thing. Later on we could understand that most of the time people are not treating their diabetes. Even if they are not having the insulin resistance, they are not knowing that they are having diabetes, they are running in the pre-diabetes and they are continuing with their endothelial dysfunction, which is taking them towards the diastolic failure when they detect it. And that is biggest reason that cutoff for the diabetes is coming down day by day. Earlier we were cutting it at 140 milligram, now we think 110, and now we are, that 100 milligram is the diabetes.
Thank you. From the floor, any questions before we break? Yes.
Yeah. Going forward from what Dr. Anuj was mentioning about, and the question that you asked related to what's the kind of a residual risk that we have in spite of optimal management of diabetes, blood pressure, and the coronary risk factors. So I did a recent talk in the last Epicon that was there, and where we are talking about what are these residual risk factors and how do we club them. And what we did is we just demarcated them into 3 groups into one. One is a pro-thrombotic, the other one was a pro-inflammatory, and then the next was a residual dyslipidemic risk, which is still not addressed by optimum statinization. So when we put all these things in together, then probably there are more newer avenues that could be opened up in saying that how we could use these inflammatory markers. Is there a role for any anti-inflammatory to address these pro-inflammatory states? Are we using the optimum anti-thrombotic agents in the right kind of an individuals? Is there a more role for oral anticoagulations? So these are all probably the newer avenues that can be explored when we talk about optimization.
One thing you are forgetting, that is the glycemic variability.
True. So when what I was mentioning was, we've been talking about optimization of HbA1c, blood pressure, and dyslipidemia. When we've done all these things, still there is some other
There are
residual
still
risks,
gaps.
and
Yeah,
that residual risk.
That's the important question.
More use of the SMBG, more use of the SMBG, more use of the CGM, so that we could be more focused on the prandial excursion instead of the basal excursion. We should be focusing ourselves on the after meal what we are going to have. I have seen many people after meal, they just shoot at a 160 or 180 or 190 even if they are not diabetic. So it is very much important how to reduce that will be giving us long-term protection.
Thank you. There was another question from there. You need a mic.
Is pioglitazone recommendable even in non-diabetics cardiovascular disease?
Yes, pioglitazone has been getting the recommendations even in non-diabetic individuals for the NAFLD and fatty liver disease. And even the Gastroenterology Association, Indian Association, or even International Association of the Gastroenterology has recommended pioglitazone for prevention as well as for the treatment of fatty liver disease even in non-diabetic individuals.
In cardiovascular disease?
Yes, it is not yet recommended for the cardiovascular prevention, but it is recommended for the NAFLD prevention. But definitely in future we may come. At this podium, I cannot say you anything which the recommendations and for which the evidences are not there. But you are in very right direction. We should get this kind of the recommendations in near future. But one thing should always be remembered while using the pioglitazone. Pioglitazone is a drug which is to be used in the youngsters only, not the age of above 55 or 60 years people. Because at that place, it is not so much preventive of the cardiovascular event. It is causing a lot of other problems like water retention. It is having the tendency for the increasing heart failure. As I already said that people, those who are coming with the diabetes, they may be having some sort of the diastolic failure with them. So if we are giving the pioglitazone or any PPR gamma receptor agonist, then probably there could be a chance. So always we should be very much judicious. Doctor's own assessment shall always work. It will not be blindly going with the recommendations and advice of the various ADA, ESD or RSSDI, various organizations.
Secondly, this hyperinsulinemia due to exogenous insulin.
Yes.
Is it atherogenic?
Hyperinsulinemia is the another side of the insulin resistance. Whenever we talk about the insulin resistance, hyperinsulinemia is a part of the insulin resistance. From where this hyperinsulinemia comes? When we keeps on eating, insulin secretion takes place, but we do not use that insulin for the physical activity, for the energy purpose. That insulin keeps on storing, keeps on piling up in our blood, and insulin resistance develops. The best thing to stop insulin resistance is start physical activity. Again, physical activity could be a part of our living, our lifestyle, because that is the only thing which can reduce hyperinsulinemia as well as insulin resistance. Insulin resistance and hyperinsulinemia cannot be separated with each other.
Thank you, Dr. Maheshwari. I think we'll end the session for a very excellent talk. Thank you very much.
Thank you. I really enjoyed it.
So we can have a photo. Thank you, Doctor, for enlightening us on the topic gaps in management of CVD in type 2 diabetes mellitus. Coming on to the most interesting part of the day, that's the quiz finals, which will be chaired by Dr. Hem Kumar, who's a physician and diabetologist at Sakra World Hospital, and will be hosted by Dr. Surekha Shetty.
Yeah, everybody's hungry, I think, but little food for the thought also. So we'll take 2 to 5 minutes to arrange the quiz arrangements. And the delegates also are a part of this quiz. So please don't prompt the contestants. You will be getting the quiz questions in WhatsApp. You can answer it at the same time the contestants answers. And the delegates who answers most questions rightly will get a prize too. And lunch is being served. Please bring the plates, stay here, and be a part of this knowledge extravaganza. Give us 2 minutes. And meanwhile, I would like to announce the winner of the paper's abstract presentation. And I would request the chairman of the jury, Dr. Pradeep, and Dr. T.J. Pradeep Kumar, and Sydney sir to be here. So here he's kind enough to convince his institution to give a prize money of rupees 10,000 to encourage the young minds into research and to honor their commitment and labor. Please come, sir.
Sydney sir was my teacher and always encouraged all of us towards science and research. And he had done a noble cause by being twice chairman of RSSDI Karnataka chapter, did a lot of good to the institution. And also when he was becoming the past chairman, he has instated this prize for the best paper presentation at every year of the KRSSDI. Thank you so much.
Dr. Vatul.
So, congratulations to Dr. Vatul B. Subramani. He has been declared as the overall winner of this KRSSDI oral and abstract presentation.
Hello. It is with pleasure that I am handing over this check of rupees 10,000 for the best paper presented during the conference. This is not one time, this is ongoing. This is an effort which I wanted to do. I collected money from the Department of Medicine, Yenapaya Medical College, and equally funded by our Yenapaya University. So we kept a corpus. From that corpus, every year, rupees 10,000 will be removed and will be given for the best presentation in the KRSSDA conference. This is just to ignite the young mind so that do a quality research in times to come. And hopefully there will be other people who will be contributing for all these activities so that the name of KR, R stand for research, and that has to be, highlighted for during any conference. And with that, I present this to Dr. Vatul B. Subramaniam.
So, Dr. Vatul's topic that that was selected as the best topic was the inflammatory markers in diabetics and non-diabetics in COVID patients and their impact on morbidity and mortality. So, congratulations.
Congratulations, very well done.
we can pick up the lunch plates and come into the hall. We have an exciting quiz. It is not only for the quiz participants, but also for all the delegates, and the top 5 delegates also would get some prizes. Not for the prize, just to ignite our mind, even at the end of almost the last session is the exciting quiz contest. So pick up the plates, please come inside the hall. Hello. One small announcement here. Please pick up the plates and you can come into the hall for the quiz. And even delegates can participate in the quiz. Pick up the plates and get into the hall, please.
Hello, check.
Check, check.
Check. Check. 1, 2, 3.
Quiz participants, please come forward, take your position.
Check.
Your team name has been marked in front of the table. Please identify and sit over there. Let them come. Quiz master will announce.
Check. Check.
So, Team A, Banting, Dr. Vikram, Dr. Meenas from Sakra World Hospital. Team B,
Check. Check.
Best. So, from KMC Manipal, Dr. Siddharth and Dr. Vaibhav. Team C, MacLeod from Akash Institute. Dr. Harika and Dr. Danush. Team D, Kolip from Vaidehi, Dr. Mohit and Ishak. Team E, Jocelyn from Manipal Hospital, Bangalore, Dr. Manjunath and Dr. Venu. And Team F, Langerhans from KIMS, Bangalore, Dr. Anjan and Dr. Foram. So 2 teams which are missing, please come forward. They have gone for something to eat and come. They are here. We have spoken everybody. This allotment was done with them. He's done. Just give them to me. So the delegates in the audience, so you will be getting the questions real time when the question is being displayed here in the screen. You can get it in the mobile. So you will get 30 seconds or till the first team answers that right answer if it appears. So you will get time. Whichever is earlier, your time window will close. So please be alert. You can be a part of this quiz and don't try to prompt your friends who are the participants here. That's why some space has been left behind. First screen, state level. So our quiz master, Dr. Sureka, has given a very nice names for the teams: Banting, Best, MacLeod, Kolip, Jocelyn, and Langerhans. So all related to diabetes, the science of diabetes, pioneers in diabetes inventions, discoveries. So I think it's going to be a thrilling and exciting quiz. Madam, please take over.
Warm good afternoon, everyone. And it is indeed my proud privilege to be part of this 18th annual conference. And here we are at the end of the 1.5-day session. And at the outset, I'd like to thank the organizing committee of KRSSDI just for being innovative and moving on from speaker-centric to audience-centric approach. Congratulations to the whole team. And more importantly, I'd like to begin by thanking Dr. Hem Kumar for being the brain, spine, everything for this quiz. I'm just here to speak out the questions. Shall we begin? So, what is the purpose of this quiz competition? No, there is no money involved. Neither are you going to be any millionaire. The whole idea behind this is to stimulate your gray cells and generate interest in diabetology, because diabetes is one of the most common chronic diseases, and that will amount to almost 30% of your clinical practice, no matter which subject you finally choose to super specialize in. We are waiting for the last contestant. So here we are, Banting, Best, MacLeod, Kolip, Jocelyn, and Langerhans. So we are going back to history of diabetes and test your knowledge of diabetes. So the rules of the game, you have all been briefed. There are going to be total 6 rounds, 5 rounds with MCQ questions, 1 visual round. The question session will go on clockwise and anti-clockwise every 2 rounds. Answering time per question is only 30 seconds because I'll take my time to spell out the question, and please discuss and be ready with the answer. And 10 marks for correct answer. Wrong answer shall be passed to the next team, but if that is answered wrongly, it will come with a negative marking of -5. And please discuss and give one answer. Judge's decision shall be final and abiding, please. No prompting by the audience here, and there shall be no usage of mobile or any other electronic gadgets. So, are we ready? Yes. All the best to all of you. I feel it's already lunchtime and I am feeling palpitations, probably in some time hypoglycemic also. So let's get through this. The round 1, which I'm going to begin with Team A, the team banting. Please keep an eye on the timer. The first scientist who found that pancreatic extract could decrease glycosuria in depancreatized dogs. A. George Usler, B. Eugene Glay, C. Nikolai Polescu, D. Frederick Banting. The time starts now.
Option number C.
Nikolai Polescu. The answer is wrong. So would best like to take a choice? If you're sure, you can make an attempt. Otherwise, you can pass it.
Pass.
C, Team C.
Pass.
Whoa, the first question seems to be hitting a 0 answers. I definitely feel when we practice medicine, we should know the history. And that is why I began this round with history. And if you look at these options, all the 4. No, everybody passed. Yes. Yes, please. Yes, that the answer is right. I assume that all these 4 options were the ones who were involved with evaluation of initial diabetes. And if you look at the answer, all of these at different points of time attempted to treat diabetes, but somehow it was finally Frederick Banting who succeeded. So Eugene Glay, a French scientist, ligated pancreatic duct and used the extract to decrease glucosuria in 1905. But somehow he did not perceive it, and his name was left in the dark. But this was the first scientist who actually did the first experiment with pancreatic dogs. So Team E gets a score of 5. Now let's move to Team B. Sir Frederick Sanger received the Nobel Prize for finding methods for insulin purification, prolonging the action of insulin by addition of protamine, determining the amino acid sequence of insulin, discovering the radioimmunoassay for insulin. Sir Frederick Sanger, a Nobel Prize winner. 30 seconds. Team B, come up with the best option, please. We are halfway through.
Finding methods for insulin purification, A.
Finding methods for insulin purification. The answer is wrong. McLeod, would you like to take the option?
Ma'am, C, determining the amino acid sequence of insulin.
Excellent. The answer is right. Congratulations, McLeod. So, the sequencing the structure of insulin was Frederick Sanger did, and received Nobel Prize in 1958. And if you look at it, James Collip was insulin purification. So the discovery of insulin history would tell you that. And Hagdorn was the one who was involved in prolonging the action of insulin. That is why we arrived at NPH insulin. And Rosalind Yallow was the researcher who was involved in radioimmunoassay. Now we shall move to the team C. Blood glucose lowering effect of sulfonylurea was first discovered by Frank and Fuchs of Germany, Jan Born at Montpellier University, August Lebert and Ruse and Associates. All these names look Greek and Latin. They almost ran on the same path, but it would be one scientist who finally clicks the buzzer, just like one of you. The time is up. Team D, I don't see any one of you discussing with each other. What's happening?
Pass.
Team E, Ruiz and Associates. Yes, it is the right answer. So, in 1937, Ruiz and Associates discovered the hypoglycemic action of sulfonamide while testing compound for typhoid fever. So that is how it ultimately led to discovery of sulfonylureas. Team D, Collip, who discovered the first oral anti-diabetic drug, metformin? Euseb Gracia, FSH Kurd, Gene Stern, Emil Werner and James Bell. Fifteen seconds down.
So time up for Team D, Team E. So Team E passes. Team F. One moment, we'll have a small glitch. It's a wrong answer, and Team A, would you like to take it? So Team A passes. Team B? Team C? No, all of them has passed the answer.
I'm sorry for this glitch. I think I need two screens. And the answer is C. He was the one who discovered metformin in 1957. So Team E, Jocelyn, glucose tolerance test, something that was described today in detail in a talk, during pregnancy was first discovered by Hurwitz at Jensen, Jocelyn, O'Sullivan, and Priscilla White. It's a wrong answer. Langerhans.
C. O'Sullivan.
Again wrong. Would Team A like to take a choice?
Option A.
Sorry?
Option A.
Hurwitz and Jensen. Was it a guess or answer of exclusion? Yes, you are right. So it is Hurwitz and Jensen. The question was first described. So it was Hurwitz and Jensen who studied carbohydrate metabolism in 25 healthy pregnant women and reported that 2-hour value more than 120 was abnormal. Then we have O'Sullivan and many others who came up with the criteria, but the first cutoff was advised by Hurwitz and Jensen. So Team F, are you ready? So the question is, creation of the term diabetes is credited to Galen of Pergamum, Apollonius of Memphis, Avicenna of Persia, and Aretius of Cappadocia. I had tough time learning these names. Time is ticking away. Do any of these names sound familiar to you? Probably something that you had read in your P and SM days, Greek and Latin. The time is up. Team A. If you answer wrongly, it will be a negative, so please be careful. Team B. Team C, McLeod. Team D. Nobody wants to take risk. Well, the right answer here is Apollonius of Memphis, who was the one first who spoke about siphon, that is to go through. And this was followed by Erasius in 15 AD, who described melting down of flesh and limbs. So now we talk of analogs and techniques and technologies. It took years for them to come up with the name and the definition. So we are at the end of round 1. Now, without much ado, we shall move on to round 2 because we are in the lunch time and I don't want any one of you to be hypoglycemic. So team A, Banting. Here is a case history. A 3-month-old female child born to a consanguineous parent presents with history of irritability and poor oral intake, random blood sugar 517, treated with insulin injection. She is also found to have liver dysfunction, skeletal dysplasia, and growth retardation. If you had to test her for a genetic mutation, what is the abnormality that you would found? Glucokinase gene, KCNJ11 gene, ABCC8 gene, or EIF2AK3 gene? Please remember 30 seconds. There were topics yesterday that had discussion of some of these genetic abnormalities. Team A, the time is ticking away.
Option C.
Option C, ABCC8 gene. Sorry, you're wrong. Team B, would you like to take a chance? Quickly. You have to be ready with the answer.
Answer B, KCNJ11 gene.
KCNJ11. Sorry, you're wrong. Team C. Team D.
Pass.
Team D. Team E.
Option D, ELF2AK3.
EIF2AK3 gene, you're right. This is something called as Walcott-Rallison syndrome. The catch here is, yes, I think one of the teams got confused. KCNJ11 gene is what they were thinking about. That is a form of MODY. But here, the most common genetic mutation that would be found, one, in consanguineous parents, and second, whenever there is a liver dysfunction. So this is the gene that needs to be looked at, and it is Walcott-Rallison syndrome, the most common cause of permanent neonatal diabetes in consanguineous parents and Indian lineage. And the index of suspicion increases when there is liver dysfunction. Team B. A 5-year-old boy admitted to hospital with polydipsia, polyuria, loss of appetite, and hearing impairment, hemoglobin 4.4, macrocytic picture, blood sugar 387, C-peptide 1.33, HbA1c 5.9. Genetic analysis showed a homozygous mutation in SLC19A2. How do you treat the condition? Vitamin B12 and small dose glibenclamide, niacin supplement and insulin therapy, thiamine supplement and insulin therapy, desmopressin injection and insulin therapy. Team B, keep a watch on your time, 30 seconds. Audience, if you're getting this question in your mobile, please answer. I notice that nobody is looking at your mobile.
Choice A,
Team A, answer is A, vitamin B12 and small dose glibenclamide. Sorry, the answer is wrong. Team C, if you know the answer, tell it quickly or pass. Team D,
Option D, desmopressin injection and insulin therapy.
the answer is wrong. If you know it, answer, no time, quickly. Team F,
Niacin supplement with insulin therapy.
you're also wrong. The answer is thiamine supplement and insulin therapy. The diagnosis is thiamine responsive megaloblastic anemia. So, yesterday this was spoken about, ask for hearing impairment, visual impairment. So, the hearing impairment is a classical feature of this, and the most interesting part here is thiamine supplementation can bring down the blood sugars, and many of those patients can maintain blood sugars without insulin at a later date. Team C, are you ready? All are true about latent autoimmune diabetes in adult, except HLA predisposition is less marked than type 1. Antibodies to GAD65 MAB indicates high risk of progression to insulin requirement. LADA patients can have both ICA and GAD antibodies. Euglycemic clamp study shows no difference in insulin sensitivity between LADA and type 2 diabetic patients. Team C, your time is ticking away. Again, there was a slide on this yesterday's session, diabetes in young. 13 more seconds. Time up. Team D, no or no? Yes or no? Team D, Team E.
Option D.
Option?
D.
D. The answer is wrong. Team F. No time. Team A.
Option C.
Option C, LADA patients, wrong. Team B. No. None of you are able to answer because the passing teams will not get time for discussion. Either you're ready or not ready. And the answer is little tricky probably. So antibodies to GAD65 MAB indicates high risk of progression to insulin therapy. So there are two types of GAD antibodies, CAB and MAB. So the presence of CAB indicates high risk of progression to insulin requirement, while MAB, the clinical features are more similar to type 2 diabetes. Team D, all the following are true about lean type 2 diabetes except male preponderance, high risk of stroke, lower risk of coronary artery disease, and higher postprandial hyperglycemia at diagnosis. Team D, Colip, your time is ticking away. I don't see you discuss. The other teams could have a discussion and be ready if there is a pass.
B, higher risk of stroke.
The answer is wrong. Team E.
Option A, male preponderant.
Wrong. Team F.
Option C, low risk of CAD.
Answer is wrong. And so, there is no more pass-ons. Are you keeping account, please? Both of them. Both of them. Yes. So, I hope you're keeping the count. So, the answer here is, it's higher postprandial hyperglycemia diagnosis. Lean type 2 diabetes has predominant fasting hyperglycemia because of the increased hepatic glucose output. And if you want to look back at the answers, yes, there is a male preponderance. They have a lesser risk of stroke, higher risk of stroke and lower risk of CAD, but they have more commonly fasting hyperglycemia. So whenever you see a patient who has predominant fasting or predominant postprandial hyperglycemia, there are a few conditions to think of. So this is one of them. Team E, a person undergoes distal pancreatectomy, which is true of this patient compared to type 1. Decreased incidence of diabetic nephropathy, decreased incidence of diabetic ketoacidosis, decreased risk of brittle diabetes, increased risk of diabetic retinopathy. Am I confusing? Your time has started now. That is the whole idea. In clinical practice, we see that the patient in front of us will confuse us. We need to find a way out.
Option C, decreased risk.
Option C, decreased risk of brittle diabetes. The answer is wrong. Team F, ready or not ready? Team A,
Option D.
increased risk of diabetic retinopathy. Wrong.
Answer B.
Decreased incidence of diabetic ketoacidosis. Yes, the answer is right, and that is obvious. In contrast to type 1, they rarely develop diabetic ketoacidosis. Can anybody guess why?
Glucagon is also lost. alpha
Exactly, that's the right answer, and that's the way how you think about the clinical presentation and correlate it with the pathophysiology. Excellent. Team F. Here is an 18-year-old lady presenting with progressive diabetes and family history of young onset diabetes. She is found to have renal cyst and hypoplastic uterus. She has detectable C-peptide levels. She could be having which gene defect? HNF4 alpha, glucokinase, HNF1 alpha, and HNF1 beta. Keep in mind 30 seconds, and other teams, please be ready with your answer. Don't wait for your turn to pop up. I'm sure Anil Kumar sir will be ready with the answer. Team F.
Option D, HNF1 beta.
HNF1 beta. Yes, was it a guess? Yes, the important aspect here is presence of renal cysts and hypoplastic uterus. So modify, very good. And if you can see here, the most important aspect of differentiating different types of MODI is the non-extrapancreatic manifestations that they have, and this is one of them. Now we have moved on to 12, 13, and 14. So, but this is one of the rapidly progressive diabetes which is associated with renal dysfunction and uterine dysfunction. So, may I have the scoreboard, please, Dr. Prem Kumar? Okay, he is busy calculating it. Let us not waste our time. We are now moving to round 3. And the round 3, the team F seems to be happy to begin with. I'm happy with that. So, this is, all the following are true about normoglycemia and intensive care evaluation and survival using glucose algorithm regulation, that is nice sugar study, except intensive glucose control with insulin decreased 90-day mortality from 27 to 24%. Intensive glucose control did not cause a difference in length of hospital stay. Intensive glucose control increased CV death. Intensive glucose control was associated with lower median survival. I'm sure this is something that you would be interested in when you're posted in ICU. Your time is ticking away, 20 seconds left. The other teams, please be ready with your answer. I'll not be giving you any time if they pass on. Team A, would you like to take an attempt? Team A, Team B, Team C, Team D, Team F. Sorry, E. Team
Option D.
Option D, intensive glucose control was associated with lower median survival. Sorry, you lose 5 marks, but I'm happy that you at least tried. The answer is A. This nice sugar study brought out an important difference between targeting blood glucose less than 108. So what did they mean by intensive glucose control? Less than 108 versus less than 180. And they found that targeting sugars less than 108 did not bring out any benefits, and in fact, it increased 90-day mortality. increased risk of hypoglycemia, and probably increased CV death. So this was a catch. Team E, in action in diabetes and vascular disease, pre-TRAX and dimicron modified release controlled evaluation, that is advanced study, all are true except intensive glucose control reduced the incidence of combined major macro and microvascular complications. Reduced microvascular event rate was primarily because of reduction in incidence of retinopathy, no significant effects seen on major macrovascular events, no statistical decrease in death from CV causes or death from any cause was seen. Team E, you have 30 seconds.
Option A.
Option A, it is a wrong answer. Team D. Team C. Team B. Team A.
Option C.
Option C, no significant effects seen on major macro events. Sorry, you're wrong. Team F likes to pass. So again, it was a minor word change that does the trick. The answer is B. Reduced microvascular event rate was because of reduction in incidence of retinopathy. It was not retinopathy, it was nephropathy. So they did not notice any reduction in retinopathy, but they noticed a reduction in nephropathy. So you need to read the outcomes of any clinical trial to understand what specific primary or secondary outcome it was able to achieve. Team D, in dapagliflozin and prevention of adverse outcomes in CKD, that is DAPA-CKD trial, all are true except subjects had type 2 diabetes, GFR between 25 to 75, and urinary albumin creatinine ratio between 200 to 5000. Hazard ratio for composition of sustained decrease in eGFR or death from renal cause was 0.56. Hazard ratio for composite of death from cardiovascular causes or heart failure hospitalization was 0.71. Dapagliflozin reduced the risk of primary endpoint equally in patients with heart failure and without background heart failure. Team D, the time starts now. I'm looking at audience also wondering what is the right answer. You're all postgraduates. I'm sure you must be studying all these trials. So please pick between the words, pick between the lines. Your time is almost up. Team C, are you ready with the answer? Team B, Team A, Team F, Team E. The answer is A, because the DAPA-CKD had patients with or without diabetes. And our option A said subjects had type 2 diabetes, but the trial included both with or without diabetes. And that was the important highlight of this study. That is where the clinicians started understanding that dapagliflozin could be used even in patients without type 2 diabetes. Team C, during UKPDS study, type 2 diabetic patients were assigned to intensive treat arm or a conventional treatment arm. In intensive treatment arm, which of the following benefits became apparent when a 10-year follow-up study was conducted? Reduced risk of microvascular complications, clinically lower overall BMI, reduced risk of MI, lower overall mean A1C. Team C, your time starts now. Team C, your time is ticking away. Okay, team
Choice A.
Choice A. The answer is wrong. Team A, pass. Team F. Team E.
Option D.
Option B.
D. Lower overall mean A1C.
A1C. Wrong again. So the right answer here is option C, reduced risk of myocardial infarction. The reason being, the UKPDS told us that the microvascular risk complication risk comes down with intensive glycemic control but had no effect on the macrovascular complications. But on the follow-up, after 10 years, it was found that though the mean A1C was not maintained in the intensive glycemic control, they had a reduced risk of MI. So this was something that became evident after 10 years of follow-up. Team B, in semaglutide unabated sustainability in treatment of type 2 diabetes, that is SUSTAIN 6, to evaluate CV and other long-term outcomes with semaglutide in type 2 diabetes, all are true except primary outcome occurred in 6.6% patients in semaglutide versus 8.9% in placebo. Rate of new or worsening nephropathy was lower in semaglutide. Rates of nephropathy complications were significantly higher in semaglutide group. Acute pancreatitis occurred in 12 patients in semaglutide and 9 in placebo. The time begins now. Team B. Are anyone in the audience answering the questions on your WhatsApp? Yes, I'm happy to see one hand raising.
Is it choice C?
The choice C. Yes, you are right. Sorry, it's a wrong answer. Sorry. Team A.
Option D.
Option D. Is that what you said, option D? Yes, the answer is right. It's again a trick here. What you would have assumed is that it is a GLP-1 agonist, so pancreatitis should have been higher. But when compared to the placebo, they found that the pancreatitis was found in 9 patients versus 12 patients. Of course, it is statistically not significant, but at least it proved that the risk of pancreatitis is not higher as we all assume it to be. Team A. In clinical outcome assessment of effectiveness of insulin degludec in real-life medical practice, that is the confirmed study, compared degludec versus glargine U300 in insulin-naive type 2 diabetic patients. All are true except degludec was associated with larger reduction in A1C. Degludec was associated with greater reduction in change in likelihood of hypoglycemia. Risk of nocturnal hypoglycemia was significantly lower with degludec versus glargine. Patients treated with degludec were 27% less likely to discontinue treatment. The time begins now. All the options look right. Team A, your time is ticking.
Option C.
Option C, excellent. What made you think of that answer? Just a guess. Yes, this study did not look at nocturnal hypoglycemia, so there was no reporting of whether the nocturnal hypoglycemia risk was higher with degludec or glargine. Both being extra long-acting were found to have low risk of nocturnal hypoglycemia compared to others, but here there was no difference found between the two. Round 4. Again, we shall begin with Team F. About diabetic retinopathy, all are true except during first 12 months of improved glycemic control, established diabetic retinopathy may transiently worsen. Aspirin therapy may worsen the hemorrhages in diabetic retinopathy. Individuals with known retinopathy are candidates for prophylactic photocoagulation when initiating intensive diabetic therapy. Field studies showed that those treated with fenofibrate were less likely than controls to need laser treatment. The time starts now. Team F. This is something simpler is what I thought. All are true except. The other teams, please be ready with your answer.
Option B.
Option B. Yes, you are right. Aspirin therapy may worsen the hemorrhages in diabetic retinopathy. There was earlier this fear that whenever there is a bleed, aspirin needs to be stopped. So also true for retinopathy, but it has been found that aspirin does not worsen the retinopathy, and in fact, there was this trial called Early Treatment Diabetic Retinopathy Study, which showed that it has no effect on even the vitreous hemorrhages. Team E. A 64-year-old woman with 11 years of diabetes on metformin, 1 gram BD, vildagliptin, and telmisartan, BMI 32, decreased vibratory sense, absent Achilles reflexes and pedal pulses, and A1C 8.2, creatinine 1.8, eGFR 28, urine albumin creatinine ratio 62. What is a drug that you would like to avoid? Glipizide, glibenclamide, pioglitazone, dapagliflozin. Team E, your time starts now.
Option C, pioglitazone.
Option C, pioglitazone, you're wrong.
B. Glibenclamide.
B, glibenclamide. Yes, you are right. This is something tricky. Even I had to come up with an options, and the most important aspect here is the eGFR number. And I've given you that number, 28. So metformin, yes, obviously we had to withdraw, but glipizide doesn't require any dose modification, but to be used in lower doses in stage 4 kidney disease. Glibenclamide to be avoided in GFR less than 60 because of high risk of hypoglycemia, long-acting. And please remember, pioglitazone is not contraindicated in CKD unless there is a hypervolemia. So volume overload state, obviously you would not like a drug that could cause volume retention. Dapagliflozin can be used up to eGFR 25 with the latest study of DAPA-CKD. So that was a trick. I hope Dr. Haim is keeping a track on the scores. I'm entirely reliant on you. Team D, Colip. All the following drugs are approved by FDA for long-term treatment of obesity except lorcaserin, phentermine, topiramate ER, naltrexone, buprion, liraglutide 3 mg. Team D, are you there?
C. Naltrexone, bupropion.
Your answer is wrong. Team C, pass. Team D, sorry, Team B, Team A, Team... Huh? Wrong answer.
Option D.
Option A, lorcaserin. Yes, that's the right answer actually. In fact, this same slide was put yesterday in one of the talks. So what is the problem with lorcaserin? It reduced significant weight loss, but why was it withdrawn? Any idea? It was actually approved, but then withdrawn because of the increased risk of cancer. So now the current drugs that have been approved are orlistat, phentermine, topiramate, naltrexone, bupropion, liraglutide, and now the new kid on the block is semaglutide. So yesterday there was one speaker who said an important statement. Obesity is no longer called as a lifestyle factor, it is a chronic disease. It requires therapy for long term, so we need safer and effective drugs, and that is why any drug with any of these side effects are withdrawn quickly from the market, and this is what the basket now contains. Team C, 67-year-old woman with type 2 diabetes for 14 years on glimepiride plus metformin. She is also on losartan, atorvastatin, and clopidogrel. She has history of coronary artery disease and has undergone PTCA. Blood pressure is 130/84, BMI 34. And if the patient is initiated on empagliflozin, it would reduce the likelihood of which of the following outcomes? Fatal MI, limb amputation, fatal stroke, death from cardiovascular disease. And the time starts now, Team C. When you have MCQs, you need to read through every word. So what would it decrease? Your time is ticking away. Team C. Team B.
Choice D, death from cardiovascular causes.
Excellent. I thought this shouldn't have been a doubt. Very good, because I think we have so many talks about SGLT2 inhibitors, and the most important benefit that we provide is reduced risk of death from cardiovascular causes. And if somebody was confused, the first option, it is fatal MI. But the CVOT outcome trials looked at MACE, which talks of non-fatal MI and non-fatal stroke. So the primary outcome did not include fatal MI or fatal stroke. So that is where I tried to confuse you. So if you look at the primary outcomes, CV death, fatal MI, non-fatal MI, and stroke. So team B, 32-year-old woman presented to emergency assessment with feeling unwell. She has no past medical histories. She is tachypneic, confused, tachycardia, and hypotension. Urine ketones 3+, random blood sugar 558, sodium 153, potassium 5.3, bicarbonate 12, creatinine 1.67. In addition to insulin, what is the most appropriate infusion to be given in this patient? Potassium chloride, sodium bicarb, sodium chloride 0.4%, sodium chloride 0.9%. Team B. Has the audience arrived at any answer? Team B, please. Your time is over.
Answer C, sodium chloride 0.45%.
You're wrong. And team A?
Option A.
Potassium chloride. Sorry, wrong. Team F?
Sodium chloride 0.9%.
Yes, you are right. IV fluids, hydration, and insulin. Those are the first two treatments that you give. The choice of IV fluids in presence of severe hypovolemia is 0.9% sodium chloride. Only then you look at the sodium and decide whether you want to give 0.45% sodium chloride or 0.9% sodium chloride. So this is the chart, a beautiful flow diagram. You should all take a printout of this ADA guidelines, which describes how do you give IV fluids, bicarbonate, insulin, and potassium. Please note that bicarbonate is given only when the pH is 6.9, and the potassium is given only when the potassium is between 3.5 to 5.2. So if potassium is more than 5.2, then you can start the insulin without any hesitation, but if it is less than 3.3, you hold insulin. Team A. In a type 2 diabetes woman with high HbA1c and high CV risk, you advise SGLT2 inhibitor, but patient has history of recurrent vaginal fungal infection. So as an alternative, you consider liraglutide 1.8 milligram per daily. Which of the outcomes could be found with liraglutide? Lower rate of retinopathy, decreased risk of CV death, average body weight loss of 12%, increased incidence of pancreatitis. Liraglutide. The time is ticking away. Team A?
Option B.
Option B. Yes. As I read through this question, I found, yes, the previous answer should have prompted you. It is the decreased risk of cardiovascular death, and the other options were there just to confuse you. If you note, again, look at the flow chart by ADA current guidelines. In a patient with high risk of ASCV or CKD, it is either SGLT or GLP-1 agonist. So both of them offer decreased risk of CV death. The scoreboard is not yet ready. I would like to give him time to calculate it. I know it is confusing. Please take your time. Round 5. Team A. A 24-year-old woman brought to hospital following a seizure. She is found to be disoriented and confused. Her plasma glucose is 36. She is not a known diabetic. A further sample taken for plasma insulin and C-peptide levels, and then she is resuscitated with IV glucose. C-peptide less than 0.5, plasma insulin 40, the most likely diagnosis. Insulinoma, exogenous insulin administration, tumor producing IGF-2 and surreptitious sulfonylurea abuse. The team starts now. Team A. There was a talk on this. Were you all there?
Option B. Option B.
Option B, yes, it is the right answer. Exogenous insulin administration. If you look at the second slide, in the presence of blood glucose less than 55, insulin levels more than 3, but C-peptide less than 0.2 goes in favor of an exogenous insulin administration. On the other hand, in case of sulfonylurea abuse, it would be both levels being high. Team B, 55-year-old male, progressive, severe, watery, and large volume diarrhea without blood and mucus, feels weak, lost 3 kgs, has dehydration, generalized muscle weakness, and lab reports show sodium 138, potassium 2.3, fecal fat 3 gram per 24 hour, urinary 5-HIA normal, gastric acid secretion fasting 0.2, after pentagastrin 3.7. So you need to know the cutoff values. Which of the following would you consider? Gastrinoma, Crohn's disease, glucagonoma, VIPoma. And the time starts now for Team B.
Choice D, VIPoma.
Choice D, VIPoma. I'm so happy you have come with the answer. Can I ask you, how did you arrive at that? Yes, all of that could cause that. What about the investigations? You need to know the cutoffs. Fetal fat, if it is more than 5, it is in favor of fat malabsorption, which would have made a diagnosis of Crohn's. Urinary 5-HIA normal, so rules out glucagonoma. Gastric acid after pentagastrin is normal, so it rules out gastrinoma. So what we have left it with, out of exclusion, VIPoma. So pancreatic cholera, Werner-Morrison syndrome, WDHA syndrome, and I'm sure in your medical casualties you will see such patients. Please keep an eye open for anybody diarrhea in diabetes. So please look out for these syndromes. That may not be just acute GE, it might be one of these syndromes. Team C, 65-year-old patient, previously healthy, no family history of diabetes, BMI 22, new onset diabetes with steatoria. He also recalls having a recent gallbladder surgery for gallstones. What type of secondary diabetes does he have? Glucagonoma, carcinoid tumor, somastinoma, gastrinoma. Team C. The triad. Am I giving clues? Team C, your time is ticking away. Are the other teams ready with the answers? I will not give you any time. Your time is up. Team D. A, glucagonoma. Sorry, you're wrong. Team E.
Option C, somatostatin.
Excellent. So, somatostatinoma is a rare tumor that arises in the pancreas and duodenum, and this is the one that comes with the classical triad: diabetes, steatoria, and gallstones. So the next time you see a diabetic patient with steatoria and cholelithiasis, please remember to exclude this. So everything is not type 2 diabetes or type 1. There are so many other varieties, and that is what I wanted to communicate today. Team D, 32-year-old male diagnosed with diabetes 3 months ago, A1C 7.5, poor libido, erectile dysfunction. He has no gynecomastia, testicular volume is 10 ml below normal, skin and has skin pigmentation. He has joint swelling and pain for past 4 months. Family history is negative for diabetes, but his mom has cirrhosis. What diagnostic test does he need? Total testosterone, serum insulin, serum transferrin saturation levels, testicular ultrasound.
Serum transferrin saturation levels.
Excellent. Right answer, and why do you want it?
Hemochromatosis. Skin pigment.
Yes, excellent, excellent. I'm happy for this answer. So it is hereditary hemochromatosis where there is iron deposition and the classical 3Ds, diabetes, dermatitis, and diarrhea also in these patients. Team E, 51-year-old woman, type 2 diabetes for last 2 years, hypertension, dyslipidemia. Her BMI is 34, HbA1c 7.9, creatinine 1.2, AST and ALT 98 and 89. Which of the following is correct? Saraglitazar can significantly improve her condition. Lobeglitazone is not safe for her. She is more likely to have positive hepatitis C antibodies than general population. Statins are safe for her. Incorrect, yes. There were talks on this yesterday.
Option C.
Option C, no, you're wrong. Team F?
Option B, lobeglitazone is not safe for.
Excellent. So you were attentive during the talk. Lobeglitazone is safe, and probably both lobeglitazone and saraglitazar improve the liver markers. Yes, now it is evident that I'm talking about non-alcoholic fatty liver disease, a very common comorbidity in type 2 diabetes. And these group of patients might be having more common in hepatitis C virus actually. Team F, 56-year-old type 2 diabetes presents with diabetic foot. Before intervening, which of the following is the best imaging modality for evaluation of complications and extent of this disease? 99 technetium MDP bone scan, CT scan, MRI, X-ray of the foot. Radiology in diabetes. Team F, your time is ticking away. Since the team F was added last, my husband had to help me out with this question, a radiologist.
It's option A, ma'am, technetium 99 MDP bone scan.
Sorry, you're wrong. Team A?
Option C.
Option C, MRI. Yes, you are right. I'm sure both of you were somewhere closer by, but MRI is the diagnostic best imaging modality, and wherever it is contraindicated, probably presence of a pacemaker or claustrophobia, where it can't be done, technetium scan would be a alternative. Round 6. Yes, we will start. Team A, Banting. 12-month-old female, failure to thrive, skin abnormalities and abdominal distension. On examination has coarse senile facies, lack of subcutaneous fat, acanthosis nigricans, enlarged genitalia and hirsutism. Investigation show postprandial hyperglycemia and extreme hyperinsulinemia. Please identify the condition. No options here? Team B. No pediatric team here. Team C. Team D.
McCune-Albright syndrome.
McCune-Albright. Sorry, you're wrong. Team E.
Prader-Willi. Prader-Willi.
Sorry, you're wrong.
It's a Rosen-Mendel syndrome, ma'am.
No, all of your turns are over. Yes, it is Rapson-Mendel syndrome, a syndrome with severe insulin resistance. It's an autosomal recessive disorder caused by mutation affecting the insulin receptor gene. And the most challenging component here is that the diabetes is very insulin resistant and have severe postprandial hyperglycemia, and along with the other features that were described in the picture. Team B, identify the condition. Type 2 diabetes, acute onset of pain and swelling of the leg, MRI imaging of the thigh. Team B, your time starts now.
Diabetic amyotrophy.
Sorry, you're wrong. Please, you could have taken your time. Team C, Team D, Team E, Team F, Team A. Why? This was an easy image is what I thought. It is diabetic muscle infarction, pain and swelling. One of the most common complications in diabetes is musculoskeletal complications. High blood sugars never bring them to hospital, but shoulder pain, leg pain, all these are the what brings. And the acute onset muscle pain and swelling, palpable mass, tenderness, and the MRI showing focal muscle edema. So that is the classical picture, and I'm sure you'll see them in your clinical practice. Team C, 64-year-old diabetic with 2-year history of asymptomatic, widespread erythematous to violaceous papules that were distributed symmetrically on his trunk, arms, and legs. Identify the condition. Dermatological manifestations of diabetes. There are quite a few. Do not always refer to the dermatologist, make a diagnosis yourself. Team C, your time is ticking away.
Annular.
Could you please be louder?
Annular.
Would Team D like to take a choice?
Granuloma annular.
Yes. So we have half marks here and half here. But annular, there are many annular lesions in skin, but granuloma annular is the right answer. And I think I would stick to Team D. So granuloma annular is a benign, non-infectious skin lesions, especially most of the patients' dermatological manifestations are seen when they have high blood sugars, and a very good management of diabetes can bring down many of these conditions rather than trying all the dermatological interventions. Focus on good diabetes control and also HCQ. Team D, a young girl presenting with history of poor sucking, weak cry, delayed milestones, overeating and increasing weight, short stature and delayed puberty, symptoms of obstructive sleep apnea. Identify the condition.
Lawrence Moon Beadle syndrome.
Sorry, wrong answer.
Prader-Willi.
Excellent. And I think that answer was previously given, and that is why I was sure this answer would come up. Yes, these are the typical features: short stature, delayed puberty, obesity, and delayed milestones also. So Prader-Willi syndrome associated with classical endocrine abnormalities. Team E, identify the cells in the slide. Team E. Please take your time 30 seconds. The rest of the teams will have no time lag. Pathology. The time is up. Team F, Team A, Team B, Team C, Team D. So I can imagine what we were seeing in the microscope. It is normal islet immunostained for glucagon. Why glucagon? The staining is in the periphery. So in the islet cells, the glucagon producing cells are in the periphery. So that was the whole idea of this picture. Team F, 62-year-old man, type 2 diabetic for last 10 years, uncontrolled, presents with rapidly increasing ulceration and palmar abscesses of the right hand. Patient did not recall any history of trauma, no signs of vascular compromise. Identify the condition. When we see a wound in the leg, diabetic foot. What about hands? Team F. Anybody in the audience is thinking of an answer? Team A, Team B, Team C. Nobody wants a negative mark. Team D, Team E. Carpal tunnel? Sorry, it's a wrong answer. Carpal tunnel is more of neurological symptoms along the course of the nerve extension. This is a wound, tropical diabetic hand syndrome. And this picture is not from the textbooks. It is from a patient whom recently one of our colleagues had seen. And a specific complication affecting patients with diabetes in tropical. It's a localized cellulitis, swelling and ulceration, progressive, fulminant, requiring higher antibiotics. Now, you have to come up with the scoreboard. We are at the end of the rounds. I'm sure many of you found the questions difficult or confusing, but the whole idea was to make you all think out of the box. Especially diabetic subjects move from doctor to doctor with the same challenges offering to each doctor. Somewhere we need to give them an answer, and all of these questions might help you think.
If you guys could sit back, we'll arrange the table for the valedictory and we'll announce the results. Dr. Suman. Yeah. Dr. Arvind, Shekhar, we'll have a quick valedictory. Sayajava, sir. I request everyone to stay back, especially the postgraduate students. We need to make some announcements. Yeah, if someone has not had lunch, to my left is the lunch. There you can pick it up and come here. People, especially who participated in the quiz and couldn't have an opportunity to have their food.
Sorry for making you wait for the quiz points and all. The peculiar marking system makes it little difficult to announce it in between. So it will be a discouragement for the people who are contesting and make it very anxious. Second, the PGs who were in presentation and quiz, we have actually given multiple times advice to attend the conference. It's not possible to attend the entire conference for the 2 days, but madam has made sure out of 36 questions, 12 questions, that is 33%. 1/3 of the questions are from the talks which has happened yesterday. So that if whoever has attended could have answered at least 50% of that, because we will not be able to understand. 1 mark I was sure, I was minus 180. So that I was sure about that. But the PGs, they could have done better if they would have attended some of the talks yesterday. And we will be announcing the winner shortly during the valedictory. I think the quiz participants can have lunch and come back.
नहीं है, पॉकेट में नहीं है, नहीं है, लिखा हुआ है, खाने वाले पे लिखा होता है, खाने वाले का, पीछे आ जाओ,
They didn't come, it's okay, leave it.
This is thanking or what?
Yeah, momentous get next.
Huh?
Momentous get.
Congratulations on a successful conference.
Thank you so much. This conference success is all Teams conference.
Teams meet.
Teams meet.
Microsoft Teams.
You Nakandappa, Pankaj. First we'll start thanking. First we'll. ಹೊಡೆದಾಕಿಲ್ಲಿ ಬರ್ದಿರೋದ ಇಲ್ಲಿ ಹೊಡೆದಾಕ್ತವ
ಕ್ವಿಜ್ 5 ಜನ ಕೊಡೋಣ ಅಲ್ಲಿ ಇವ್ರು ಗೆದ್ದವ್ರು ಏನು ಕೊಡ್ತೀವಿ
ಏನಿಲ್ಲ ಊಟಕ್ಕೆ ಹೋಗೋದು ಯಾರು ಗೆದ್ದಿರು
ಏನಿಲ್ಲ
ಊಟಕ್ಕೆ ಹೋದ ಅನ್ಸುತ್ತೆ ಇಲ್ಲಿ ಸಾಕು ಬೆಟರ್ ಸಿಟ್ ಹೋದೆ
ಹಾಂ ಕೂತ್ಕೊಂಡು ನಾನು
ಹ್ಯಾಂಡ್ ಮೇಕಿಂಗ್
ಹ್ಯಾಂಡ್ ಮೇಕ್ ಸ್ಟಾರ್ಟ್ ಮಾಡು ಕಾನ್ಫರೆನ್ಸ್ ಎಲ್ಲ ಮುಗಿಸು
ಅಲ್ಲಿ ಕೂತ್ಕೊಂಡು ಮಾತಾಡ್ತೀನಿ
ಅಲ್ಲಿ ಕೂತ್ಕೊಂಡು ಮೈಕ್ಸ್ ಕೊಡ್ತೀರ ಒಂಚೂರು ಮೈಕ್ಸ್ ಸುಮ್ಮನೆ ಒಂದು ಸ್ವಲ್ಪ ಮಾತಾಡ್ತೀನಿ
ಹ್ಯಾಂಡ್ ಮೇಕ್
ಅಲ್ಲ ಇವರಲ್ಲಿ ಏಮೇಲು
You must have gone for lunch.
Yeah. Welcome again to the August audience. First of all, I would like to thank one and all who attended the conference. And even now, I could see a good number of people sitting here, and that makes us this conference a good success. I think we all need a good. So before we start off with anything else, I would like to invite our immediate past chairman, Dr. Suman R, to give a few words.
Very good afternoon, and I would say that thank you so much. You know, whenever we thought about conference, the conference success only comes through the appreciation what we get from all the audience, and the number of audience was really good in both the days, and that makes us really feel good actually about it. Before we just talk about the conference, I just want to tell, in fact, the team what I had was really awesome and very excellent, and it was the brainchild of Dr. Manohar, who had lot of things in his mind. He kept us on the run. In fact, he wanted to do so many things, and just 10 minutes you leave it, you'll get 10 messages on WhatsApp, I will do that, I will do that. So it was so tough to catch up with him. But luckily, me and our secretary, Vijay, have really worked hard, and probably we helped him out, and he has come out with an excellent conference, and it was really very well appreciated from all of us. And in fact, I would really want to thank Dr. Manohar for his excellent scientific oration for all these things. And also, I would like to thank a lot of senior doctors who have really come in sitting till the end of the conference, that makes us really feel good about it because it says that they are so enthusiastic even at that age, and that itself is tell us that what the quality of conference we gave it across. And not the least, I would say that all the PGs who were there, who had participated, something like around 44 papers, what we could get, abstracts, was really good actually, what we had actually, and that's something phenomenal. And I also like to thank my team of Madhumeha who were really there, and probably they were supporting in the reception counter, on the registration counters, and they were really good in all aspects. And also want to thank Dr. Arvinda J, who was a real backbone for us, who used to send us the reminders. A sort of a reminder telling that, have you done this, have you done this? Then we used to scratch our head, come on, oh, we missed out on that. That was something good actually. No, he was still in the loop and he was really helping us out a lot. And totally it was not one-man show, it was all the team. The team is really with me. Thank you so much, and I'm so happy. I'm ending my chairmanship with a very high note, and it will carry my lifetime. Thank you so much for that.
Having said that, Dr. Suman R. will always remain with us, and he will be continuing to guide us in the future also. And from today, in fact, from the last AGM which conducted yesterday, a new chairman has been taken the chair. That is Dr. K.N. Manohar is the new chairman for the next coming year. And also, I would like to announce we have one of our person in the central the EC committee, executive committee, that is Arvinda J, is elected as one of the members of the election committee in the central RSST. So, thanking all these dignitaries here, we would like to move on with the award presentation and prize distribution. So firstly, I would like to appreciate the number of posters that has been participated in this conference. We received a whopping for more than nearly 45 posters in this conference, which was, the response was excellent. And I'm sure in coming years we'll have more and more. And let me announce the winners of this poster presentation and the oral presentations. The first prize, Best Paper Award was already given, who also received a cash award of 10,000 rupees, sponsored by Enapoya Medical College and University. That is Dr. I don't know if he's here. Okay. Is Dr. Haim here? Okay, then we'll first move on with the. Okay, before we give away the poster and oral presentations and also the quiz competition presentations, we'll first try to honor a few of the support group which has really made a difference in conducting of this conference. I'll hand over this to Dr. Manohar.
Thank you. Thanks everyone, especially the delegates, the younger generation, I call the postgraduate students. There were some hiccups here and there. What I would like to place on record is that group what we have formed will stay here, and we will keep adding people to it, and we'll try and build something on it, which is useful for all of us who are research oriented. The R of RSSDI would be represented very well. I would like him to join for the poster presentations prizes. But before that, there are a lot of people who had helped us. So I would like to call upon few names and receive a token of memento. One is Dr. Pradeep. He helped us with the scientific rearrangement of posters, abstract, and responsibilities, and easing our burden. Dr. Karunesh, apart from helping us in this, every and last but not the least, many of us make much more noise than what we are. It's our usual. Sureka, please stay on. So, my good friend, very, very intellectual person, and a silent hard worker, him. Prem. And another important person who contributed with his views in our lifestyle symposium, a good friend of mine, Prem Kumar Bhiya. I think that was one of the most appreciated workshops, and all the workshops were very well appreciated and very well attended. Many a times I felt that I should have given more time to people. And another member of the scientific committee, Dr. Swaraj. I don't know if I have missed out on any name. And apart from being in the scientific committee, he also captained the Hoysalas, and I don't think nobody wins in a debate. No. Science wins. Hey, don't put it that way. So now to announce the quiz and the papers and poster winner, I would like Swaraj, please stay back. And all the Hem, Pradeep, onto the stage to announce the winners of the posters and the paper presentations and also the quiz winners. So firstly, thanks for the younger generation. There were few hiccups from my side. I'm sorry for that. But the team here has done wonderfully well. All the laurels should go to them, and if there are any brickbats, I can handle it.
So let's put our hands together to all the postgraduates who presented the papers and the posters. It was a wonderful contribution, and we think this is going to be the beginning of better research to come over. And let's KRSSDI be the forefront of research for RSSDI in our country. So with that note, let me announce the winners of the poster the overall best paper presentation was, we've already rewarded and awarded Dr. Vatul R. Subramani. He was the best paper from, and he was awarded a cash prize of 10,000 rupees. The runners-up is Dr. Venkata Sai Shashank Mutya. Is he around? Yeah. Congratulations. A huge round of applause to Dr. Venkata Sai Shashank Mutya. So in the oral presentation, the runners-up was, it was a tough fight between the top two presenters. The second position goes to Dr. Siddharth Sadhwani. Dr. Siddharth Sadhwani? Anyone on his behalf? It was a wonderful presentation, and it was very relevant to the clinical scenarios. Congratulations. And the first place goes to Aishwarya Varudu. Aishwarya Varudu, the first place goes to Aishwarya. So Dr. Aishwarya, the only place where Dr. Siddharth lost out was because of his time. Otherwise, I think both of them were on par. So that's probably the point that we need to note in our future presentations.
I just wanted to tell, we give marks separately for all the things. Both the content was pretty similar and the application to our clinical practice was also pretty same. But only place where probably you lost out was time. That's why very important to maintain time for all your futures. This is for all the postgraduates. Wherever you're presenting, it is very important that you stick to the time.
See, in the jury, there are very prolific people, not only as researchers, but also presenters and orators. So
we are all upset that program has been stretched. That's why even at a younger age, I'm also young, but even at a age lesser where you're not got out of the medical school with your post-graduation, you should learn how to present, how much to present, and how to provide it to make it more interesting and impactful. So I think this group, what we'll form, we'll start working on those things with our great jury, and we'll add some more people, and then we'll try and make better researchers, better publishers, and better orators through the KRSSDI.
Can I request all the presenters who are here to come onto the stage, please? We'll have a group photo. Please come over. All the presenters. All those who have presented the poster and the oral presenters, please come down. Bug up fast. Come.
Or we can come back, yeah.
Yeah, see, many of these people didn't attend only, they got 0. They are in the third question, that's what we do every day. Just a second, in the third question. We will give them.
All those who have presented their papers, please collect the certificate onto the right of my stage or whatever, onto my right. And over to him to announce the quiz. It was a very exciting quiz contest. I was just praying that the quiz masters won't say that if nobody answers the question, scientific chairman will answer it. Luckily they didn't. It was a very, very tough questions. Of course, it is at a higher level, but I think it was really very well done. And apart from the physical quiz, what was happening, we also had a live quiz. There are a lot of delegates who have participated. I don't know, I hope few of them are here. And we will also announce their names. Over to him.
So, the main quiz which has happened within the 6 teams, the winners are Dr. Vikram and Meenas from Sakrawal Hospital. I would request them to come here to receive the trophy from the quiz master. And the runners are Dr. Anjan and Forum from KIMS, Bangalore. So I would say that these two PGs are my PGs, but I didn't teach them because probably even if you had given the question before, I would have not known the answers. So I wish them all the best and congrats. Yeah, I got that. No, second team, Dr. Anjan and Dr. Fora.
And as Dr. Haim said, everybody is a winner here. It was just a matter of few questions that had to be answered rightly, that's all. Please, all of you come.
And meanwhile, the main quiz participants are coming up to the dais. I would announce the quiz winners. There was a quiz running all through the 2 days of the conference. So our One Care team has done an excellent job of implementing this quiz, which is a running quiz relevant to the topics which are being added in the conference, where each topic has been relevantly, the questions has been asked. So Dr. Rekha G has been the leader and top delegate who has answered most number of questions, followed by Dr. Sandeep, and the third winner was Dr. Muhammad Ishaq. After that we'll announce them. Yeah. No, we'll announce later, probably we have announced. So the delegates quiz for the 2 days, it is Dr. Rekha Ji, Dr. Sandeep and Dr. Muhammad Ishaq were the winners. And the quiz which was conducted, along with that, delegates were also involved in the actual main quiz. In that, Dr. Rekha G has come as first, followed by Dr. Siddaramappa Patil and Dr. Balaji PA, the first three scorers. So any of these 6 people are here? Dr. Rekha Ji, Dr. Sandeep, Dr. Muhammad Ishaq, Dr. Siddaramappa Patil, Dr. Balaji PA. What we are giving? We have the color that not that one.
Thank you. Thank you. ಹೌದಾ? Okay, join it. Thank you. Well, in fact, in my journey of 1 year as a chairman, I really had a lot of people who really helped me out. But one outstanding person is here with us. He was really instrumental in taking things out. He was so enthusiastic to do this program, the Dog Skill Training Program. And it was a big hit. In fact, we got queries from the central telling that please take this dog skill program to the national level. That was a query what we got it, and I would request Dr. Manohar to kindly pursue it and make sure that dog skill program reaches the central. That's what I always feel. And I would just request Dr. Pankaj Srivatsav to please come on dais for a special appreciation of thanks from the whole Krssdi.
In fact, the main anchor of Dog Skill program was Dr. Shekhar. And Dr. Shekhar was addressing Pankaj as Dr. Pankaj Srivastav. Thank you, sir.
Well, one other person we thought really deserves a lot of things. He was totally, any time in a day, if you can just call him, he was always on the computers, he was always on the WhatsApp, he was always on the things. Any changes you need to happen, he was always there for us. The software designer, the software man, Banu, please, I request you to please come over and whatever the printouts he got, whatever the slide it shows, whatever you're seeing, it's all because of Banu. He was very instrumental in doing a lot of things. And hats off to this guy, and thank you so much for us. I would request Vijay to say a few things about.
Well, if I say about Banu, I should only say how much I tortured him all these days. Day and night. In fact, I called him over to my office one day, and whole day till night I didn't allow him doing all corrections. Maybe it was like a hitting on his head with a hammer. So that's what I should say. And Banu, really thank you for working hard so much. And all this would not have been so smooth without your hard work. Thank you, Vanu. And
Well, I also wanted to call my team, Madhumya team, Asha, Dr. Smita, Anita, they were all MCs, Suma, Umesh. Please come on the dais with just one small photo with us to say that you're really done an excellent job.
What visuals we get here, and it has been live throughout through the YouTube and Facebook channel. So I would like to thank our AV team, Ravi, to come over and please please accept our token of appreciation. Ravi and team, please come on. Thanks, ಎದುರಿಸ್ತಾ ಇದ್ದೆ ಬಟ್ ಮಾಡ್ತಾ ಇದ್ದೆ ಚೆನ್ನಾಗಿ ಒಂದೇ And if you notice this, throughout these 2 days, 2 boys were running up and down at my commands. Both Ramesh and Mahesh, please come on to the stage. They were very, very helpful in getting things in order. And when we come, it should be ready. And thanks to both of them for helping me out, helping us out. Ramesh and Mahesh. I don't know if how many pharma colleagues of ours are there. It will be, the conference would be impossible to happen without their support. And everyone have been very, very nice and kind to us, adjusting and accommodating all of our requests. A big thank you, and whoever is out there, I would request all of you to come onto the stage and we'll take one picture. Kindly, I don't want to call names, but please volunteer and come down. All of you are very equally important for all of us to have a successful conference. Yeah, it is customary in a valedictory function for some delegate to speak about the conferences and give their feedback. So if someone is willing, I would request one of the delegates to come over and talk about what they felt about it, what were the deficiencies, what are the suggestions they can give us to improve it better. So anyone willing, we are more than welcome. It could be a postgraduate students who have submitted their papers or whatever. In your marking and prize is all over, you can vent it out because it's in the right spirit for me to take it forward for our team. It will act as a guide. So one of the students and one of the delegates, if someone can, yeah, please come over.
Good afternoon, everyone. Nothing wrong or bad about it, just my observation or opinion about the event. It was a great event to start with, and it was a great opportunity for all of us who are still learning a lot from all of you as a senior, as a guide to us. So, had an opportunity to present a poster and had planned to give a oral presentation as well. If the slots were more, then that would have been helped in us getting an opportunity to present our poster with the as a paper as well. But I couldn't do that, and the few of the programs were overlapping, so we could miss out on few of the programs. So that's all. That's all are my observations. Thank you.
Yeah, thanks for that. So anytime, not only in KRSSJ, anywhere you submit paper, it is the jurisdiction of the jury to select it into oral and abstract. In fact, I and Dr. Sidney sir also wanted it to be showcased more than what we have done it. So we are coming up with plans where we can say that we might come up with a day's meeting only dedicated to research and publications. So that is the plan which is in just now we drafted it. And overlapping of talks can't be helped. Many people, in fact, one of the speakers who was speaking, he said, I wish I could be attending the lifestyle symposium. So that speaks good about the content. But again, YouTube links and Facebook links are available. In fact, I got so many WhatsApps. That's what I was telling to Ravi, that you condense and give it off. Hall A, Hall B, throughout the day, you will get a YouTube and Facebook links also. Or please like SSDI. Thank you very much.
Good afternoon.
Student membership is much lesser. Log on to the website and let us start the membership drive also.
Good afternoon, everybody.
Congratulations to our newly elected chairman. It is not even 24 hours gone. Congratulations. Thank you.
Not this much, and our this team was excellent. Our Suman, Manohar, Arvind J, Vijay, and others, they have done excellent. They are arranged very meticulously. Scientific program has started in time, and also they have finished in time also, both A hall and B hall. And second thing I want to tell, he has conducted today morning yoga program. That was the one of the highlighting program. And also this quiz program also they conducted very nicely, and very delicious food also. And yesterday night was also, it is a very delicious food. Wonderful, we are enjoyed. Thank you so much, and best of luck. And that guitar is also wonderful. Thank you so much. Continue this same thing in next year also. Thank you.
So, 11th man has come to bat now. So everyone has finished their job. It's a Sunday, need to go home. So last 2 days have been really exhilarating for all of us. And there have been a few hiccups that have happened, which we tried to manage to the best of our abilities. When you have someone behind you who just keeps you on your toes all the time, doesn't let you relax, and sees to it that the things happen on time and maybe even before time, there is no choice that you can delay. So I would like to thank each and every delegate who has attended this conference, because without delegates, a conference can never be a success. The attendance of a conference itself is an indication of the success. We have had some very good talks, very good speakers were there on the dais yesterday and even today. And we had some very good lectures. The scientific content was too good. The scientific chairman, the secretary, the vice chairman, everyone has played their part here. I'd like to wholeheartedly thank all the delegates from the whole GC of KRSSDI for making this event a success. I would also like to thank our pharma partners, without whose support this conference organization wouldn't have been so easy for us. Last 2 days, there were no hiccups, not even a single glitch on any of the screens or the mic, no, with the AV issues. So we should thank Skyline also, our AV partners, for this event, for making this an uneventful one. Thank you, everyone. Thank you once again. See you next year again.